Good morning, everybody. I declare open this hearing of the Senate Community Affairs Legislation Committee's inquiry into the National Disability Insurance Scheme. I begin by acknowledging the traditional custodians of the land on which we meet and pay my respects to elders past, present and emerging. The committee will be conducting today's hearing via video conference and in person in Melbourne. I'm Senator Karen Grogan, I'm the chair of the committee, and I have with me Senators Askew, Anandaraja, Daliga and Steele-John. And then we also have Senators Antic and Kovacic joining us online. These are public proceedings being audio streamed live via the Parliament website, and a Hansard transcript is being made. I remind all witnesses that in giving evidence to the committee, they are protected by parliamentary privilege. It is unlawful for anyone to threaten or disadvantage a witness on account of evidence given to a committee, and such action may be treated by the Senate as a contempt. It is also a contempt to give false or misleading evidence. Witnesses also have a right to request to be heard in camera. If a witness objects to answering a question, they should state the grounds upon which the objection is made, and the committee will determine whether it will insist on an answer, having regard to the grounds on which it is being claimed. If the committee determines to insist on an answer, a witness may request that the answer be given in camera. I remind senators of their obligation under the Behaviour Code for Australian parliamentarians to treat witnesses with dignity, courtesy, fairness and respect. And I remind committee members and witnesses who are appearing via teleconference who are not speaking to mute their microphones. I would now like to welcome a representative from Queenslanders with a Disability Network, and I believe we have Ms Michelle Moss online.
Good morning, Chair.
Good morning, Michelle. Thank you for joining us. I understand that the information on parliamentary privilege and the protection and obligation of witnesses giving evidence to the Senate has been provided to you. Is that correct?
Yes, that's correct.
Excellent. For the Hansard record, I'll ask you to state your full name and the capacity in which you appear today. But before I do, I'm just going to alert everyone to the fact that there is a videographer in the room. The videographer is here with Senator Steele-John, and the material that's being captured is for his own personal use. It is not connected to the Senate proceedings in any way. We're all comfortable with that filming occurring, but it is entirely up to the witnesses. If any witness, and I will remind people as we get to each individual witness, any witness who is not comfortable with that filming occurring should please just let us know. There is absolutely no obligation, and Senator Steele-John is happy to not film those sections where people are not comfortable. So back to you, Michelle. If you would like to state your full name and the capacity in which you're appearing before us today, that would be lovely.
Michelle Moss, Chief Executive Officer, Queenslanders with Disability Network.
Fantastic. Do you have an opening statement that you would like to make?
I do.
Thank you. Please go ahead.
Thank you. I'd like to begin by acknowledging the traditional owners also, and to thank you, Chair and members of the committee, for the opportunity to appear today on behalf of Queenslanders with Disability Network. QDN is an organisation of for and by people with disability, and we represent more than 3,000 members and supporters across Queensland, including people living in rural, regional and remote communities and people with diverse disability. QDN supports the long-term sustainability of the NDIS and recognises the importance of integrity, quality safeguards and effective stewardship of the scheme. However, QDN does not believe that this bill should proceed in its current form. Our members have consistently told us that they are not opposed to reform. What they are concerned about is reform that removes supports, weakens safeguards, limits review rights, and shifts the scheme away from participant-centred principles on which it has been established. And our members, over the 2 weeks that they've had to consider this bill, have shared with us about the proposed forms and the uncertainty, confusion and fear that this has created for them and their communities. A key concern for QDN is that this bill significantly broadens Commonwealth powers while reducing opportunities for genuine consultation, negotiation and co-governance with states and territories. And certainly the bill in enabling the Minister to reduce funding for categories of supports across scheme through determinations, including those powers to apply percentage reductions to that without consideration of individual participant circumstances and without agreement from states and territories, and unlimited parliamentary scrutiny is one of concern. We see that these are not minor administrative changes. They are substantial reductions to supports that many people rely on to participate in community life, maintain independence and avoid isolation. And we certainly have heard strong feedback from our members in the Queensland disability community that they are incongruent with the 2009 shutout report, as well as the recommendations and findings from the Disability Royal Commission. Our members have consistently told us that supports for social participation and capacity building are not optional extras. They are the supports that enable people to volunteer, work, maintain relationships, build confidence and participate in their communities and to be safe. The bill also enables the Commonwealth to introduce those transitional rules without agreement from states and territories, and this impacts upon the states and territories' ability to negotiate safeguards, to advocate for their stakeholders and adequately plan for the impacts on state-based systems and services. Also, members have raised around the new eligibility requirements and also the requirements to around eligible impairments, and participants and people with disability have raised their concerns about losing supports where needs arise from where they have multiple disabilities, and members have talked about that people with multiple disabilities don't experience one specific disability need and impact in isolation of those other disabilities. And people are seeing this as a move away from whole of person assessment and the original participant-centred intent of the NDIS. Another concern particularly raised by members living in rural, regional and remote communities is around the permanence and treatment requirements that are outlined in the bill, and the bill explicitly stating that financial circumstances and geographical location may be irrelevant in determining whether that treatment is considered appropriate. And members have talked about that people should not be denied support because they cannot access expensive, unavailable or geographically inaccessible treatments. And this is particularly for Queenslanders and the geographical disbursement of where people live. Further concerns that have been raised by QDN members include the removal of rollover of unspent funds, the renewed plans carrying forward reductions made through those ministerial determinations, the limited review rights of those renewed plans, and the obligations being placed on participants for that debt and record keeping obligations. So taken together, all of these things are not isolated technical amendments, and our members are concerned that it risks the scheme shifting away from that participant-directed framework to a more centralised, administrative and fiscally driven model. QDN is also concerned that many of the alternative systems intended to absorb demand are not yet operational, adequately funded or consistently available. And people are worried that they will lose supports before replacement systems are ready. So QDN is certainly not arguing against reform, but that reform must occur in the right sequence, and that they affect whether people can participate in community life, maintain employment, sustain relationships, avoid crisis and exercise choice and control over their lives. So QDN is asking the committee to ensure that the bill is amended to strengthen those safeguard and review rights, retain those whole of person assessment principles address the issues around those ministerial powers and strengthen co-governance with state and territories, and to the sequencing to ensure that alternative systems are operational before exclusion occurs, and of course the very important engagement and co-design with people with disability and their families and the sector as this is implemented. Thank you.
Thank you, Ms Moss. We appreciate that. And thank you for your submission. It was very comprehensive. We'll go first to Senator Steele-John.
Thanks very much, Chair, and thank you for your evidence today, Ms Moss. Just to confirm before I begin, you are comfortable with the videographer recording your session?
Yes, that's fine.
Excellent, thank you. My first question would be, you've said very clearly in your statement that the bill should not proceed in its current form. What do you think the impact would be for Queenslanders if the bill was proceeded with in its current form?
Well, I think, Senator, certainly the feedback from our members would be particularly the impacts around social and community participation have been very explicitly described by our members that would limit their ability to work, to volunteer, to be in safe environments where they are supported well and to be part of community. Certainly some of the requirements, as I've said, around the permanence and treatment requirements, requiring people to demonstrate that they've exhausted all appropriate treatments before qualifying for support, is one of significant impact, because we know that for many people living in communities across Queensland, that access to the cost, the availability and where people live mean that there are those options around exhausting all those appropriate treatments before qualifying for support. I think, there's a whole range of fundamental shifts from the scheme that members are concerned about, and we certainly want to ensure that people can participate in community life, that people are able to maintain their work, to be able to be part of community and to have access to the ordinary support that they need to live their day-to-day life.
Thank you. And could I ask you to go a bit deeper on what your concerns are in relation to how the bill defines permanent disability in regards to the need to have exhausted all possible treatments?
Yeah, so certainly members have talked about the lack of clear safeguards about what treatments will be included in those appropriate treatments. There's been a whole range of feedback from our members about different academic or perceptions by different medical professionals that may not sit with people's choice and control around those treatments. There's also, I guess, broader impacts on people from First Nations and cultural inaccessibility of mainstream treatments in those remote communities that we have in Queensland, and that is a real structural barrier for First Nations people with disability.
And what about your concerns around the Minister's ability to make unilateral decisions to cut funding for a whole group of supports with no consideration for individual need? What are your concerns there?
Well, certainly, Senator, I think this ability to apply a broad-ranging percentage to a category of support has significant impacts on individuals, their ability to understand and have that that level of support reduced will impact on whether they can have a shower, whether they can go to the toilet. We're already seeing and hearing that feedback from members about having to ration and plan very, very basic fundamental support needs and the impact that has on people's day-to-day lives, I don't think can be underestimated or understated.
And can I just confirm, does QDM receive any funding from the Commonwealth Government?
So QDM receives funding under the ILC, Information Linkages and Capacity Building, to operate our peer support groups and our peer support network, our Emerging Leaders program, and we're delivering a range of Inclusion Matters forums. And we also receive funding under 2 other programs under that ILC around with a focus on conscious and unconscious bias in mainstream systems, as well as supporting people to look at employment pathways and exploring living and home and living where they want to live, and they're all under the ILC.
Okay, fantastic. If you wouldn't mind just taking on notice just if you could provide us with the total value of the funding you receive under those programs from the Commonwealth, that would be great. And that's I might just pass over the call to my fellow committee members at this point. But thank you so much for your work and your advocacy and the work that you do for disabled Queenslanders and our families.
Thank you very much, Senator Steele-John.
Thank you, Senator Steele-John. We'll go to Senator Askew.
Thank you. And thank you, Ms Moss, for your appearing today and for your extensive submission. I just wanted to go a little bit further into the exhausting all options of treatment discussion that Senator Steele-John touched on. I'm just wondering if you could give us your thoughts further around that and whether or not it does conflicts with a person's right to refuse treatment under Australian law.
We would certainly put forward that potentially that does impact on people's ability to make informed decisions about their treatment, and it would really need to be considered around the Convention on the Rights of People with Disability and the Charter of Healthcare Rights when the committee is considering this.
It sort of really does limit people's options if they end up not being able to access it without having the clarity around, the fact that they have to do treatments that they may not choose or may not suit them, just to be able to access the system.
Yes.
Your submission also has quite a few recommendations, 22 I think is the total. Can you go through what your top 1 or 2 would be in that you would really, would really want to see implemented?
That's a very hard question to answer, Senator, but certainly I think our recommendations broadly range across under those each areas that we've identified around eligibility and access, which includes the treatment exhaustion permanence test, the functional capacity threshold, and the service eligibility. Certainly, we see that some of those things around the integrity, governance, and pricing will be really important to the broader co-governance arrangements that I think that need to be considered in unilateral decision making by the Commonwealth has flow-on effect to the states and territories and the services and systems that operate. And I think it is really important about the decision making framework for that, and as these reforms and transitional arrangements are put into place. We certainly think that as I said, the eligibility and access and supports assessment and adequacy is critical to the individual experiences of Queenslanders with disability and the potential impacts that this legislation could have.
Okay. And just on the current, currently within the system as well, do you believe the current level of red tape within the scheme is appropriate, or do your members report duplication and excessive regulation requirements?
Certainly, people with disability report, excuse me, the impact of the red tape or the requirements that they are. Sometimes people describe it to us as it's like having being on the NDIS is like having a full-time job just to deal with the NDIS and their supports that they need. And we certainly think that it is important to make the system more user-friendly from the perspective of people with disability and their families. We think it is important to reduce red tape, but we also see that it is critical to have the right safeguards and the right settings and the right monitoring in place for people to have those protections for the risk of exploitation or abuse.
And are there any areas that you could see that would be best to actually to streamline or to simplify the process that you can see?
Well, I think, Senator, there's certainly been a whole range of engagement and feedback, from very hands-on sessions that I know many of our members have been part of over many years. And I think the information is there about what can be done to help streamline and to help make that more straightforward. I know the agency has certainly been looking at and listening to some of those things and feedback by people with disability to help improve the system and the way things work. But I think it's also, I go back to those critical safeguards, and it is about getting the balance right to ensure that people are protected and the safeguards are there.
Okay. And obviously the consultation is going on, so hopefully there will be some other areas that are being streamlined as well. Just finally from me then, what amendments do you think would need to be made to this bill to be able to actually get it through the Parliament?
I think there certainly needs to be some areas around the review rights. I think the ministerial powers is something that needs to be addressed and looked at, and what some of that co-governance mechanisms could be. I think that there needs to be some focus on the exclusions that might occur and what provisions need to be undertaken around that. Certainly the single eligible impairment and removal of the whole of person assessment is something that needs to be considered, and what impact that has on understanding people's functional needs. The exhaustion and permanence test is also probably one that is really important.
Yeah. Okay, thank you for your evidence. I'm getting the look from the chair, so I will pass back to the chair. Thank you.
Thank you, Senator Askew. And we'll go to Senator Ananda Raja for one question.
Thank you, Chair. And thank you, Ms Moss, for your detailed submission. I just want to draw out something you did discuss, which was the red tape and the bureaucracy, and how we can better streamline processes. I just wondered whether you could comment on what you think about the proposed digital enrolment system. This is designed to have providers supply minimum data about their business, I guess, and care details, and it's designed to be fully rolled out by December of next year, 2027. And it's also designed to cut red tape, reduce paperwork, and strengthen integrity in the system. Do you have any thoughts on this particular system?
So I think what we've heard from members, and certainly how this impacts as well on plan management and the continuity of support, is that people are concerned around when mistakes are made, and I guess the impact on people with disability and the expanded debt and record keeping obligations that participants will experience through this is something that has been raised by our members, and I think it is something that warrants. Again, it's about the safeguards that can be put in place, and where there are those mistakes, because we know that occurs now, and certainly we don't want people with disability to be in positions where they have, in good faith, purchased a range of services and end up with debt and things because of a digital system that hasn't been able to manage effectively the different touch points of the delivery and approvals for that service category or delivery of that particular service. So I think it is important to look at that area.
Thank you. I think the digital enrolment system is designed to be a safeguard, so those insights are valuable. Thank you.
Thank you.
Thank you so much, Ms Moss, for joining us and for taking the time to provide us with a submission. We do thank you very much for your evidence. I think you agreed to provide one piece of information to Senator Steele-John. I wonder if you could provide that to us by close of business on Friday, the 12th of June, if possible. If not, please just talk to the Secretariat and we can work something out. But thank you so much for your time, and we'll let you go now.
Thank you, Chair, and thank you to the committee.
Thank you. But I would like to welcome representatives from children and young people with a disability. So we have Ms Skye Kokoschki-Moore with us in the room. Thank you so much for joining us. It's nice to see you. I'll just check in with you on a couple of those things. Are you happy for filming for Senator Steele-John's videographer?
Yes, I am.
Fantastic. Thank you so much. Now, I'm just going to check. You've had information on parliamentary privilege and protection of witnesses?
Yes.
Yes, you have, even though I know that you're fully across such things. So I'll get you to state your full name and the capacity in which you're appearing before us today.
Skye Kokoschki-Moore, CEO of Children and Young People with Disability Australia.
Fantastic. And do you have an opening statement?
I do.
Please go ahead.
Thank you. My name is Skye Kokoschki-Moore, and I'm the CEO of Children and Young People with Disability Australia, or CYDA. CYDA is the national representative organisation for children and young people with disability aged 0 to 25, their families and their caregivers. We're not a service provider, but rather systemic advocates. Over 70% of our staff and 100% of our board have lived experience of disability or as the parent or caregiver of a child or young person with disability. I'd like to pay my respects to the Wurundjeri people of the Kulin Nation and to any First Nations people here today. I'd also like to acknowledge the disability community and the advocacy they have engaged in for decades, including the advocacy that led to the establishment of the National Disability Insurance Scheme. Thank you for the invitation to appear before the committee today to provide perspectives on how this bill will impact children and young people with disability and their families. This bill represents the biggest changes to the NDIS since it began. for the nearly 1 million people with disability aged under 25 in Australia, and for the nearly 476,000 NDIS participants in this age group, it represents much more than that. It represents a move away from the fundamental rights-based principles on which the NDIS was founded, that people with disability are entitled to individualised supports delivered by those that they choose in order to fully participate in the community. In SADA's submission, which was endorsed by the Enabled Youth Disability Network, the Youth Disability Advocacy Service and the Youth Disability Advocacy Network, we highlight some of the key concerns our community has about this bill, including the requirement for a person to undertake all appropriate treatment to meet the definition of permanence, the reliance on parental responsibility and informal supports as alternatives to properly funded and skilled supports, the reduction in funding for social and community participation, and the centralisation of power with the Disability Minister of the day. On paper, these reforms are designed to achieve billions of dollars in savings. In reality, they will push more families into crisis, result in cost shifting to already oversubscribed or even non-existent services, and lead to poorer outcomes for people with disability. As we sit here today, I ask you to imagine this. You are a parent who lives 1.5 hours outside of a small regional centre. You've had to quit your job to care for your 6-year-old with severe school refusal and what you call violent meltdowns. You cannot afford the private OTs and psychologists out of pocket that your child needs, and you are terrified your 1-year-old infant is going to be left without any early intervention under the new rules during that window in their life when it is most critical. Or imagine you're the parents of a young man in his early 20s with complex communication and support needs who requires 24/7 support. Because of these cuts, his support needs are likely to be pushed to non-existent informal supports, and his right to live independently is under threat. Or imagine you're a single parent counting on 2 skilled support workers whom you trust to keep your young children with complex neurodivergent and trauma needs safe. You're scared that if the NDIS labels this work of a 3-person team as ordinary parenting and strips it away, it will leave your children highly vulnerable to physical danger. Danger like running away from home or into oncoming traffic, which is something you've had to step in and stop before. These scenarios do not need to be imagined by these families, who are real. They have bravely shared their lived experience with us because they're terrified of what the future will look like if this bill passes unchanged. But now I'd like you to imagine this, that the NDIS is secured for future generations, not by ripping funds for essential supports away from children, young people and their families, but by better fraud controls and a guarantee that non-NDIS funded supports will be available to those who need it, regardless of where they live or what they earn. And imagine that a child diagnosed at birth with a lifelong disability living in a low-income family in a regional area is not forced to take days off of school to travel for hours to attend treatment their family is not convinced will address what they need and that they can't afford, and the child isn't forced to trial medication before accessing NDIS support. And imagine that a young person who is blind finishes school and is able to get a job because the social and community participation support they received reduced their isolation, staved off mental health crises, and gave them the confidence and independence they needed to secure employment instead of being on job seeker. These scenarios could become a reality if the bill is amended. These amendments would ensure that a person's geographic and financial situation is taken into account when determining whether treatment is appropriate, and a person isn't required to undergo chemical restraint through medication before getting access to NDIS support. The bill is amended to ensure that parental responsibility is considered in the context of the whole family, with an understanding that tasks like dressing, bathing and transport can be anything but ordinary when children have complex behaviour and communication support needs. And the bill is amended so that social and community participation for budgets, so that social and community participation budgets for children and young people support them during life's key transitions. and that the bill that passes Parliament ensures people with disability, their families, and indeed the Parliament are confident that decisions made about the NDIS can't be made by a single person, but are instead made by people with a deep understanding of the disability sector, especially people with disability themselves. There is no one more invested in a sustainable NDIS than people with disability and their families. The community stands ready to work constructively with the Parliament to ensure this bill genuinely does secure the NDIS for future generations. Thank you.
Thank you. We'll go straight to Senator Steele-John for questions.
Thank you, and thank you so much for your evidence today. Very powerful and informative. Can I kick off by asking you quite a direct question? You flagged a number of concerns in the bill. In its current form, should the bill proceed?
If the bill proceeds in its current form, it will represent some very dangerous changes that would impact the lives of people with disability. So therefore, we would not recommend that it passes in its current form.
Thank you. In what ways, in your view, will this bill impact people under the age of 18? I know you've taken us to some quite concerning potential case studies, which I want to go a little bit deeper on. But first of all, could you go kind of a little bit into more detail around the general impacts on this age cohort?
When we look at the age cohort of 0 to 18s, it represents an enormity of experience, because during this time you have a child who might be starting kindy or kinder, going to school, going to high school, and potentially leaving school to enter further education. They're also likely to get their first job in this time. When we take away support early, and so I'm talking about very much in the early years when early intervention is most critical and it has the highest success of setting children up for a life with lower support needs, then once that early intervention support is taken away, it will make it more difficult for that child when they become a young person and their family to ensure that they're engaging in ordinary community life. We're particularly worried about the impact that this bill is going to have on parents, particularly parents where there are a number of children in the family who may or may not currently be on the NDIS or eligible for it, but when their needs are taken separately, they don't qualify for any formal support. But when you take them together, it creates a situation where the parenting that they're required to do can't be described as ordinary. And when we look at this bill from the perspective of young people, when you think about somebody who's in school, they're going through their adolescence, they want to be out there making friends, the last thing they want is, in order to go out and hang out with their friends, is for mum and dad to have to be the one to come along. Support workers play a really crucial role in fostering that sense of independence that young people need in order to build their confidence. And so when the responsibility is shifted more and more towards parents, not only does that have an adverse impact on the young person directly, but it likely has an impact on the family unit, because we've already heard from parents that they're concerned that they will be required to reduce the number of hours they're working or leave employment entirely. And seeing as we're already in a cost of living crisis, the lower income families have, the deeper that crisis is going to become.
Thank you. And on the question of parents, have you got any reflections on how this bill, as it is currently written, will impact the ability of kids to attend school?
Yeah. We've already heard from families and from some young people that the support that is provided through the NDIS, as simple as it may sound, so just getting to school or getting ready to get out of the house to get to school, is so critical. If a child isn't supported in the morning with their routine, it's less likely that they're going to be able to attend school, and then attend school in the right frame of mind to learn. The NDIS doesn't provide supports in school, but we know that school is one part of the equation, but getting to school is just as important. We also know that there's a lot of children with disability who experience school can't. That's not only the fault of the NDIS. There's a whole range of reasons, why children with disability aren't feeling welcomed and supported at school, but we have a responsibility to remove any barriers that we can to make sure all young people can realise their right to an education.
Thank you. Now, the bill changes the definition of parental responsibility. Have you got any reflections that you'd like to share on the impact that this could have on both disabled children and parents?
The NDIS already takes the responsibilities of parents into account through operational guidelines, but this bill moves to legislate that consideration. What we know is that parents of children with disability, particularly those who have complex communication and behaviour support needs, require more support in the home. We don't yet have a definition or clarity over what that threshold is. When does parenting go beyond what is ordinarily expected? And expecting a parent to single-handedly provide the same level of care and support as a team of skilled, qualified, experienced support workers risks putting that family into further crisis and may lead to increased instances of carer burnout. We've already heard that when we gave evidence to a parliamentary inquiry last year. We reflected on the impact of eligibility reassessments and how families had already been told by NDIA staff that if they weren't able to fulfil their parental responsibility, then they would be referred to Child Protective Services. So what we're really scared will happen here is that that kind of position is going to be taken more often, and that more families will feel under threat because they're reaching out for help because they're not able to cope, but by doing so, it may indeed place them in a position of incredible vulnerability.
So you're concerned that this bill would leave disabled kids without the support that they need?
Absolutely.
Yeah. Now, the government's seeking to remove children under the age of 9 from the NDIS and to place them into the Thriving Kids program. From what we know at the moment, we've got some ideas that the government has put forward around the supports that might be provided to kids and parents, some conversations about Medicare items that may or may not be delivered. What are your reflections on what the impact could be for this cohort of kids that might be removed from the NDIS and placed in the quite vague program that the government is proposing for some point in the future?
The sequencing of reforms is critical if we're going to get them right. We've known about Thriving Kids now for a while. The rollout of Thriving Kids isn't expected to start until October this year, and it's supposed to be fully implemented by the 1st of January 2028. That doesn't leave an awful lot of time for those supports to be available and active in the areas where they're going to be needed most. We would also really value more information about what kinds of targeted supports are going to be delivered through Thriving Kids. We already know from the model that's been published that Thriving Kids will provide a range of tiered supports, so right from information and advice for parents about developmental delay and concern through to those more targeted supports, which could include one-to-one or small group allied health sessions. It remains to be seen how many sessions a family might be able to access and whether or not they will be expected to access a certain amount of those sessions before they're able to apply to the NDIS. That's one of the issues with the all appropriate treatment provisions of this bill. It's not clear what appropriate means. Appropriate according to who, and how long will it take for somebody to demonstrate that they have indeed undertaken all appropriate treatment?
Thank you. Now, could you confirm, as you are one of the DROs funded by the federal government for disability advocacy and representation, how much money did you receive from the Commonwealth in the financial year 25-6?
So in the current financial year?
In the 5-6.
5-6, yeah. So we received funding that we call our core DRO funding, and that's our funding to engage in systemic advocacy and information sharing and gathering with the community. We also received funding by way of an information linkages and capacity building grant. We are halfway through that 3-year grant program. And we've also received funding to attend the United Nations Conference of State Parties to the UN. Yes, COSP. I'm sorry.
Thank you. If you wouldn't mind just taking on notice what that precise figure was, that would
Absolutely.
be great. And I'm right in thinking that in the federal budget there was some additional money given to DROs that was allocated. Is that correct?
We understand that there is additional funding on top of the sort of core funding that we received, but we haven't been advised yet how much that is or how long that will be for.
And that's to support the government in communicating with the community around these NDIS reforms. Is that right?
I would say that communication is a two-way street, and so it would be our intention to use any additional funds that we're able to receive to make sure we're providing accurate information to the community, and in turn providing accurate information back to Parliament about what the community's views are.
Yes, but that in terms of how it was described in the budget, it was, I think, communications around these NDIS reforms. Is that right?
I would have to have a look at the budget
If you
papers
could go
again.
and have if you could tell us just how it was described to you on notice and what the quantum was for CIDA, that would be great. Just before I pass to my colleague, you mentioned something I just can't get out of my head. If I've understood you correctly, you've said that the legislation, as you read it, could require a child to have undergone chemical restraint as a treatment before then having access to the scheme. Is that correct?
Yes, so based on our reading of the bill and what we've been told by the Department of Health, Disability and Ageing is that the definition or interpretation of treatment is quite broad. And when I asked whether or not that would include medication, the department advised yes. And so when we think about medication, we know that chemical restraints or a chemical restrictive practice can occur when somebody is forced to take medication as a way to suppress particular behaviours or conduct that either they wish to or the people around them wish to, and that's what we're really concerned about for children in particular, is an early adoption of chemical restraint as a way of satisfying appropriate treatment before non-chemical or medical or medication support is available to them.
Gosh, it's quite a scary thought to think that you would have to do that. I'll pass back to the chair.
Thank you. And we will go to Senator Askew.
Thank you, and thanks very much for being here today and for that enlightening introductory statement. It's actually very good. And I've just got some further questions in relation to that. One of them, you mentioned the definition of functional capacity, for noting that children aged 0 to 25 that can change as they grow, and that was all throughout your submission as well. So what impact do you think this change would make, and what changes to functional capacity should be addressed when planned reassessments occur as the children age? So if you could give us
It's critical that someone's functional capacity is considered in the context of who they are and where they live. We know that for example, a young person with an intellectual disability may physically be able to walk to their local bus stop, but would they be able to walk to the local bus stop to get on the appropriate bus to get to school is another question. And so when it comes to functional capacity assessments, it's going to be critical that whatever tool is used enables that understanding that there is some nuance, particularly for children and young people who are developing. When the bill was introduced, CIDA was able to run a focus group with young people with disability in order to get some initial reactions and reflections. And as part of that, we asked them about functional capacity assessments and used the example of the HUDAS, which is a tool that has been used in the past. On notice, I'm really happy to provide a bit more information about what we learned through that focus group, because we intend to be able to provide further advice to the Parliament on this.
That would be excellent. If you wouldn't mind, that would be fantastic. And you've also, your organisation's previously raised some concerns around the thriving kids and lack of consultation, the rush timeline, and also the concerns about lack of capacity in schools that will be required. Do you share the same concerns with regard to the current reforms that we're inquiring into, and also what supports need to be in place before we actually proceed with the bill?
I keep thinking back to a phrase that I'm sure many of us have heard before, and that's that when the NDIS was built, it felt like we were flying the plane as it was being built. And what I'm worried is that we haven't learnt from that, and that we're continuing to fly this plane while it's undergoing a massive renovation and being rerouted to a different destination. What we really need to do is to slow things down. We're incredibly grateful to the committee secretariat for the hard work that they've had to do over the last couple of weeks in order to get submissions in, reviewed, public hearings held, because this is such a critical reform for the community that I think it was about 2 weeks to make submissions. I'm not too sure how many have been published now, but the disability community, I think, is resounding, I suppose, in its wish to have meaningful contribution to what this bill looks like before it passes. What we would really like to see is this bill paused in order for appropriate consultation to take place on things like the definition of appropriate treatment, how will parental responsibility be defined and applied, what will the functional capacity assessment be, and how can we ensure that any big decisions made about the scheme can't be made by only one person, but that rather those decisions are made by people who have expertise in disability, including and especially people with lived experience of disability themselves.
And that's vital that there is that input and consultation. As with other stakeholders, you're not alone in this one, you've raised concerns in regarding to the increased ministerial powers. You've suggested it should be done by the Disability Reform Ministerial Council in consultation with the NDIS Reform Advisory Committee. Why do you feel that this is the best and most appropriate way to make decisions?
Yeah. We know that due to the nature of the NDIS, a number of the rules require sign-off by the states and territories as well. So we think it would be appropriate for that body to be tasked with understanding what changes need to be made and then designing them in a way that will have the desired outcome without jeopardising the lives of people with disability. And by including the Reform Advisory Committee in those deliberations and in those discussions, we will see more lived experience included in that decision-making process. So I think that that will lead to better decisions and better outcomes.
And so what would you see as the main risks if the decision-making power was to remain with the Minister?
Yeah. Due to the nature of our Parliament, we will never have the same disability minister forever. Like, that's just the way that our Parliament works. And so by leaving important decisions up to people who we don't know who they are yet, what their views on people with disability are, then I think that that is a risk that we've identified and that can be appropriately mitigated. So where we've identified that risk and there's ways to mitigate against it, I think it's entirely sensible that we do.
Okay. All right, I'm just conscious of time, so I'll hand back to the Chair. I'll hand back to the Chair.
Thank you very much. We'll go to Senator Deliga for one question.
Thanks very much, and good morning. Thanks for coming along. You mentioned to us that Thriving Kids will provide supports for children and families with low to moderate support needs. Why do you think it's important for children with higher support needs to access the NDIA for generations into the future?
Yeah. I think it's important for all children to access the support needs it's important that children are able to have their support needs met, no matter where on the spectrum those support needs are described. In relation to children with high support needs, it is of course essential that they're able to access some of those more intensive supports in order to really make the most out of their early intervention window. But the same can be said for children with low to moderate support needs as well. A support need not met puts a child on the backward step and takes them further away from being in a position in the future where they will have lower support needs and will be able to participate in the community without heightened or additional support needs that will need to be funded from somewhere.
Exactly, yep. All right. Thank you, Chair.
Senator Ananda Raja.
Thank you. Look, I just want to revisit this issue of chemical restraints, which you've referenced a few times. This will obviously fall under a technical advisory group, which will be multidisciplinary. There will be participant experience on that as well, and it'll be guided by medical as well as ethical considerations within a broader framework of autonomy and control. And I'm just concerned that there may be a narrative circulating in the community. You've raised this a few times. Where is this narrative originating from when that is clearly not the intent of the bill nor the intent of anyone in this community?
Yeah. I think the narrative is coming from a place of a lack of information. And so we know that there is a requirement for somebody to undertake all appropriate treatment. And when asked, the department said that appropriate treatment would be defined very broadly. Based on that, it's reasonable to suspect that treatment could include medication. Until the government is able to explicitly rule out a requirement for any person to have to take medication as a precursor to accessing the NDIS, that concern will remain.
Okay, just to clarify, and this is for the benefit of for a lot of people who are listening, the issue of chemical restraints is not it's not going to be done on a frivolous basis. It will be absolutely part of a technical discussion with an expert advisory group with representation from clinicians, participants, and others. So we just need to clear that up. And to be honest, chemical restraint is not a thing. It should be about a tiered approach to treatment, and really only at the end there should be a consideration of last resort as to whether restraint is needed at all. And then there should be a suite of solutions. So I think it's a much broader discussion that's going to be had. Yeah. But thank you.
Yeah. Chemical restraint is real, and it does happen when somebody is required to undertake medication.
I'm medical as well, so yeah. I do know it is there, but it's not. I just don't want to give the impression that this is going to be something that'll be willy-nilly prescribed.
Okay.
It'll be part of guidelines. Yeah.
Thank you. And totally take on point the issue of information. We'll certainly look at that. Senator Steele, John.
Thank you. Just to clarify, though, because I want to be clear, in your meeting with the department, you gave them multiple opportunities, by the sound of it, to explicitly rule out chemical restraints within that definition, and they didn't do that. Yeah. That's correct, isn't it?
When I asked, could this include a requirement for somebody to take medication,
yes.
They said yes.
And so your point to us today is that until the government amends their legislation to explicitly exclude chemical restraints, for example, the legislation creates that pathway, correct?
Correct.
Thank you.
Okay, thank you. Ms. Kokoshimo, thank you so much for your time. We appreciate both your time, your submission, and your advocacy for children and young people with a disability. Thank you so much for joining us today. Now, we will call Villamanta Disability Rights Legal Services. I believe we have Miss Naomi Anderson with us in the room. I understand that information on parliamentary privilege and the protection of witnesses and obligations of witnesses has been provided to you. Yes. Great, thank you. For the Hansard record, Let me start with, how are you comfortable with the video? Yep, okay, excellent, thank you. If you could please state your full name and the capacity in which you're appearing before us today.
Yes, my name is Naomi Anderson. I am Legal Practice Manager at Villamanta Disability Rights Legal Service.
Thank you. Do you have an opening statement?
Yes, I do.
Please go right ahead.
Thank you, Chair. I thank the committee for the chance to speak to you today and to help explain the likely impacts of the bill before you. In commencing, I acknowledge the traditional owners of the country and disabled people who guide our work. Villamanta is a community legal centre based in Victoria. We're a statewide service and we focus on disability rights issues. Unlike some of the DROs that you're speaking to, we deal with people at the pointy end. So the DROs represent the broad sector. We represent people who are under appeal at the tribunal, people for whom everything has gone wrong, people for whom the gaps have opened into chasms, people who are struggling to get through the process. So our perspective is always a little sharper because we're dealing with people who have had the imagined difficulties turn into a real problem in their life. I'd like to just take a quick look back, if we may. When Parliament passed the very first bill back in 2013, they made a promise to the disability community. You want safe and reliable supports to live a good life? We've got you. You want to see if you can have a better life, maybe have a job, study, volunteer in your community, expand your horizons, have more independence from your family? We've got you. They also made a promise to unpaid carers supporting people with disability. You want to balance the care of a family member with opportunities that others have. Maybe have a job, study, have a life of your own. We've got you too. Yes, it was going to cost money, but for every dollar invested, the research says that $2.25 was returned to the economy. Fewer welfare recipients, more taxpayers, but most importantly, acknowledgement of the rights of people with disability. 13 years later, here we are. Many of the good things have started. Many of them are still in their early stages for those whose isolation and exclusion was severe. Many jobs have been created, many businesses started, people with disability are more visible than ever and are active members of the community, and these are great things. That said, the NDIS is not working as it should, and while the government is focused on fraud and rorts, I would like to start by talking about the consequences of these failings for NDIS participants. I learned recently that about a third of the coronial findings in Victoria relate to the death of an SDA resident. The vast majority of these are 5 to 6 pages in length and conclude that the person died of natural causes. Every now and again, there is a person where more context is provided, and we can see the risks associated with supports being delayed, withheld or withdrawn. I will use pseudonyms, but I want to talk to you very briefly about actual cases. In the case of Fiona, when her condition deteriorated, she required equipment for mobility, absent which she was bedbound for months. The service manager provided a statement to the coroner. It was very challenging to deal with the numerous failed applications for increased funding for Fiona. It was challenging to witness her deterioration at such a young age. We all knew what Fiona required, and it was heartbreaking to see that the NDIA did not approve what she needed to improve those final months of her life. The approval of her funding being announced 2 weeks prior to her death was the final blow for me. I found this very difficult to accept. Fiona died in June 2025, aged 48. In the case of Lee, the NDIA cut his funding in November 2024. Whereas previously he'd been receiving 24-hour care, his funding was cut to 8 hours a day. After a fall in January 2025, Lee was taken to hospital. Although no injuries were found, he was not discharged from hospital due to the medical staff forming a view he could not be safely supported with only 8 hours of care. Although Lee's carer was trying to have his funding reinstated, Lee deteriorated quickly in hospital. Lee died of pneumonia on 24 January 2025, aged 64. Felicity, whose guardian had sought nursing support, died 19th of August 2024, aged 45. Sarah, 2023, aged 58, and on they go. Not everybody has the details in the coroner's inquiry. It's only those who had somebody to speak for them, only those who had somebody to talk about what happened in the months prior. It wasn't on the day that this went wrong, it was the months and months before. We expect that the introduction of the NDIS has increased life expectancy of people with disability due to the provision of supports that maintain health and wellbeing, assist with access to healthcare and promote community inclusion and activity. But we note the increasing trend of mortality rates for those with high support needs and relatively high budgets from the Sustainability Report of 2024-25, for which the actuary has raised their forward estimates of mortality. This cannot be the only response when more people die than expected. In this period of rapid change and significant reform, there must be consideration of the negative consequences. Unexpected increases in mortality rates surely count as negative consequences. The bill before you has the potential to exacerbate the increase in unexpected mortality by increasing timeframes for reassessments when things have changed, removing deemed decisions which allow participants to have the matter reviewed if the legislated timeframe is not met. And I note in the case of Felicity, at the time timeframe was 21 days, but the agency was taking 110 days. So should we expect the 90 days they now propose to blow out to 450? Preventing people other than the participant or nominee requesting a reassessment. If you think about all of these people who are winding up in hospital and subsequently dying, they're not in a position to be requesting a reassessment. Allowing suspension of supports if a participant has not been contactable in 90 days. Again, if they're in hospital, if they're bedbound, who's checking? Implementing renewals instead of rollovers, meaning that a participant who's been in hospital and is trying to plan their discharge with a plan of using higher supports first and then tapering off may find the unused funding they were relying on has now disappeared from their plan. Entirely foreseeable that they could be discharged from hospital and a week later their funding disappears. A 50% reduction in funding for community participation for all participants will be felt in the hardest of ways. While the media have run stories that imply this funding is being used for things everybody has to pay for, a coffee, a haircut and so on, this is simply not the case. Community participation funding serves two important functions for those who need support to do anything outside of their home. Firstly, it makes the person a visible part of the community. People talk about the coffee van they go to and the staff know their order. These small moments of being seen are the beginnings of inclusion. Somebody has seen you enough times to know something about you. The broader community spends a significant amount of their time in either education or employment. These are both places where people get to know each other through repeated interactions and shared interests. Many NDIS participants are unable to engage in either education or employment, and community participation funding provides the means for the development of an identity within the local area. It allows for people to try things out, discover what they like, which can lead to meeting other people who like those same activities, maybe join a club, make some friends, maybe even a romantic partner. Be invited to drinks, a party, a wedding, maybe start a small business, have a stall at the local market, volunteer at a local business or organisation. Save up the funding for a big ticket item like the hours it takes to get to a concert if you live regionally. The second thing is the necessary tasks of life. Shopping for food, clothes, getting your hair cut, going to the dentist, appointments with doctors, specialists, scans, pathology, go to the gym, access therapies, whether NDIS funded or not, all the things everybody else does when they leave the house. Cutting this support in half is short-sighted and does not in any way improve the NDIS, reduce frauds and rorting, or achieve anything but helping the federal budget. This is a massive cost to ask people with disability to shoulder and a complete reversal of what the NDIS was designed to achieve. If you ask NDIS participants what they think is wrong with the scheme, they will tell you the stress they experience when dealing with the agency, which has terrible communication channels. They will tell you the extreme anxiety caused by seemingly random decision-making, while funding being cut for no reason, and people's lives being put on hold for many months while they work through the review and appeal process. I note that the majority of people who do this have a positive outcome, and suggest that the $60 million in legal fees being reported by media is not the worst cost. It is the loss of opportunity for the participant and their family while they go through this awful process for seemingly no reason. They will tell you the changes only ever seem to penalise them, and they do not make the agency better. Our submission talks to the significant shift in obligations away from the agency and onto participants and their families, and they will tell you it is the uncertainty. The NDIS was supposed to give people with disability and those who support them confidence that they can build a life with the security that the supports they need will be there. This bill does the absolute opposite of that in so many ways.
Thank you. We'll go to Senator Steele-John for questions.
Thank you very much, Chair. And before I begin, Ms Anderson, can I just confirm you're okay with my videographer filming the submission? And we've also had another camera come into the room since you've begun. Thank you.
I think just on that, it is a public hearing and the media have advised us that they will be attending at various points through the day. If anyone does have a problem, please let us know.
Awesome. Thank you, Chair. So, Ms Anderson, you've spoken in your opening statement about the risk to the safety of disabled people. You've used quite strong language around mortality. Is it your view that the bill should pass in its current form?
Absolutely not.
Absolutely not. Okay. Thank you. Your submission speaks also to the impact of the government's decisions to cut community participation funding. From your experience, what do you think the impact that will have on the safety of participants?
People who need support to access the community need that support regardless of whether it's there or not. So people who have that support removed will immediately be at risk. For some it will be isolation, for some it will be being unsafe in their home because there is nobody to support them. For others it will be increased reliance on family members who they may or may not have great relationships with. It pushes that need for support out everywhere else. It's also going to push that need for support into the hospitals.
Into the hospital?
We have clients who are hospitalised when their support needs aren't met because they are not safe in the home. The hospital then tries to discharge them because they're not sick, but it's unsafe to be at home. It's unfair on everybody. There's people waiting for hospital beds while there are people taking up beds but not receiving treatment.
And what do you think the safety risks are, or the broader risks of people being removed from the NDIS before alternative systems exist?
Same. The support need is still there. If there is no other system to provide that support, what's the person going to do?
So what you're saying to us is, does it seem to you as though the bill as it's currently written kind of seems to imagine that disability disappears if the NDIS doesn't see it?
It seems to rely on the fact that lines can be drawn about who does and doesn't meet the access requirements, and if you're not in our field of vision, then you're someone else's problem. But there is no other system that is going to pick them up. There's nothing out there.
Nothing out there. What are your concerns about the way in which the bill defines permanence of disability?
I was having a look at the explanatory memorandum on that topic. I just don't understand why there's a proposal to put every single NDIS participant through this process when there's no data to confirm what sort of numbers we're talking. The NDIA themselves say moderate at best, and yet all NDIS participants are going to have to be reassessed to see whether they meet the requirements. What about people that were diagnosed with an intellectual disability in their childhood, went to an institution and now in a group home? They have no evidence. All of the appropriate treatments, I wish I could show you the letters we received from doctors when we're at the tribunal, and the agency is asking over and over more and more questions about, have you tried this, have you tried that? And doctors come back with scathing responses of, who's the doctor here? Do you actually think I'm not treating this patient to the best of my ability? Do you actually think this person doesn't want to get better and instead wants to rely on supports? The underlying assumptions here are foul.
It's a bit of a case of government thinking it knows better than your doctor.
Correct.
Yeah.
If they had identified a cohort where this is a problem, if they had identified that there are large numbers of people who are clearly simply not wanting to have treatment for something that is safe and available and will yield good results and would reduce the numbers of people on the scheme, we'd be having a different conversation. But where's the evidence that this is actually necessary? And for a population that have traditionally had forced procedures, re-traumatisation is just cruel.
Yeah. What are your concerns about the financial and geographical factors not being taken into account here when the government decides whether a treatment is appropriate?
Also important, but who's making these lists? Who's deciding what treatments are and are not appropriate in the first place is the first round. The cost and availability is the second layer, but I take objection to the first layer because I've seen the sorts of lists that come out of the technical advisory group. It may well be that the technical advisory people making up these lists know exactly what they're talking about and are giving sound advice, but they put that in the hands of people who don't. That goes to corporate lawyers, that goes to case managers, that goes to planners who don't have the education or the expertise that a doctor has. That's not their job. And the intrusion into a person's privacy to determine why a particular treatment is not available or not appropriate for them, unacceptable.
Your submission, if I read it here, it goes into quite a lot of detail about the concerns you have in relation to the NDIS. The NDIS bill basically granting broad transitional powers to the Minister of the day, and also powers around making certain determinations, enabling the cutting of support funding. And it seems to enable this to be done without parliamentary approval being required. Can you explain how these powers could be used in practice and why participants are concerned, as well as their families, with the scope of these new government powers?
So the ultimate power, the one in the last schedule that a lot of people have been called Henry VIII clause, I personally think we've got a more modern example of somebody who likes to go around Parliament and just make judgment calls themselves, and that would call it a Trump clause. We don't need that.
Yeah.
Parliament is a place for providing the evidence, having the discussions, making sure that what is being proposed is safe, is necessary, is appropriate in the circumstances. It's too much to put in the hands of one person. We don't know who that person will be in future. We don't know what their budget priorities will be. We're basically giving them the PIN number to their bank account.
Yeah. Particularly, have your members expressed concerns about not only what these powers could be, how they could be used in the hands of the government we have right now, but also the governments that we might have in the future. They could be of different political parties. It could be a one-nation government at some point in the future.
Of course.
With the current policy. Is that a concern that you're hearing?
That's what legislation is for, so that if you're going to change it, you need to go back to Parliament and not just undermine it by giving the minister all of the powers to go and do things by themselves.
Yeah.
Any future minister could use those powers for all sorts of things.
Absolutely. Thank you so much. I'll pass back to the Chair.
Thank you, Senator Steele. John, we'll go to Senator Askew.
Thank you. Thanks again for being here today and for your evidence. You mentioned earlier, and I just wanted to go back to that first, that you're highlighting the concerns around cost shifting to other systems such as hospitals, but also the welfare system, aged care, and back to the families and carers. You've seen this beginning to occur already, even since the beginning of the starting of this discussion, and if so, what impacts and risks do you believe it will have on participants?
We certainly have been seeing people being hospitalised.
Yep.
We certainly have seen adults who have ageing parents have concerns about what this means because they can't shift that back to their parents. We've seen those parents also saying, we're in our 80s, we can't. There is nobody else. People are having very difficult conversations. People are having conversations about very awful options.
Yeah, I must admit I've been getting those sorts of emails as well. So the risk is obviously there, and you started your discussion today by highlighting the unexpected mortalities and so on like that. Do you see that there would be an increased risk of that?
Absolutely, and the actuary has simply adjusted the forecast upwards.
Okay.
So they're assuming there will be more.
Okay.
They've adjusted the forecast up.
Already
Correct, on the basis of the increase.
in the budget.
So
Is that-
In the sustainability
sustainability.
report, it confirms that.
higher levels of death.
Yep.
Higher levels than expected.
So, okay. You outline you believe the rights and obligations of participants are significantly increasing, which we've discussed already, where that's coming back. compared to what you believe is reducing expectations on the agency. In what way and what impact do you believe that will have, and what key changes should we actually be looking at making?
I'm not sure if the committee is aware, but the NDIA have lost data about people. They've also lost documents. So our concerns about decision making based on data, for example, the nature of the disability, it's frightening. The number of appeals that we see when the root cause of the problem is that a disability has been end-dated in the system and the calculation of funding necessary therefore has been incorrect. The participant doesn't know anything about that until they get to the tribunal. And in the most recent one that we've had, we then sent an FOI to go back to the beginning and get the materials, and the materials are lost. So the evidence that was provided
has an end date. Something that's a permanent disability has an end date.
And the disability didn't end date.
No.
So it's just disappeared from the system.
Okay.
It's there, but it's end dated.
Okay.
Oh, it's end
so it's actually listed as a disability, but it has got a...
Correct.
It's, as
and
if
there
it's
was
been
a
resolved, that
cluster
matter
of
has been resolved.
acquired brain injuries a couple of years ago.
Okay.
Where the ABI just dropped off, and so they were treated as having, say, a psychosocial or an intellectual impairment, but not the ABI. At the moment, we're seeing a range of other impairments that have dropped off, and then when we ask for the documentation from prior to that happening, it's nowhere to be found. Now, it obviously existed because the person got access on the basis of that evidence.
So is there an explanation from the agency on that? It's just lost.
Just lost.
Okay, we might have to look into that further.
So the onus on participants to retain documents and materials, participants who are going into hospital because their support needs are not met, who have unstable housing, who are having mental health crises, who have strangers in their home providing support. It's not easy to keep track of every single piece of paper, but a lot of them upload it onto the portal and then the agency can lose it.
Okay.
That seems skewed.
It does, very. I've just got one final question before I hand back. I know the Chair's going to be looking to me shortly, but I just wanted to touch base on something in your discussion paper about where you highlighted within the SIL, particularly around rosters of care and the costs associated for supports that may not be delivered. In addressing this issue, what proposed amendments are needed in your opinion?
The roster of care should only be charged according to the staff that were provided. At the moment, there is an incentive to put a roster of care in that looks great, but which the provider cannot actually staff. And participants have no control over that, so they receive less support than everybody believes they're receiving. And the provider's still being paid.
So that needs to be an amendment that needs to be
absolutely
in place to fix that. And all right, so I'll take note of that. I'm going to hand back to the Chair because I'm very conscious of time, but look forward to investigating that other aspect very well. Thank you.
Thank you. I think there's a range of things that you've raised today that I think are maybe not the intent, but we will prosecute those issues that you have raised with us today with the various departments and such like that we're seeing later in the week to get further clarity around those issues. But thank you so much for your evidence. We do appreciate the time you've taken to submit and to appear in front of us today.
Chair, could I just ask them to take one question on notice? If we're going to...
Certainly, and I will just advise that questions taken on notice, we kind of need the answer by Friday. So if that's a problem, please come back to us because I know that's a very short time frame. Please, Senator Steele, John, go ahead.
Thank you, Chair. Just, I like my colleague, read your section of the submission on ROC roster issues with great interest. If you're able to provide us with any additional information on how you see that play out from the case studies that you have, and any amendments that you've thought of previously to address that issue, providing them to us on notice, if you could, that would be very, very useful, because I think it is an area that we need to look more deeply into. Thank you.
Great.
Thank you very much.
Thank you so much. We will now let you go and we will take the opportunity to have a short tea break and we will return at 10:45. Welcome back. Yes, it is okay to take the photo.
Oh, thank you.
Thank you. Appreciate it.
I would now like to welcome representatives of the Allied Health Professionals Australia. Thank you very much for appearing before us today, and thank you for your submission. I understand that information on parliamentary privilege has been provided to you. Is that correct?
Yes, it has.
Excellent. For the Hansard record, if you could state your names and the capacity in which you're appearing before us, that would be very helpful.
Thank you. Bronwyn Morris-Donovan, CEO, Allied Health Professions Australia.
Philip Herman, Senior Policy Advisor, Allied Health Professions Australia.
Thank you very much.
Natalie.
Oh, sorry, and we have somebody online.
Good
Please.
morning. Natalie Stapleton, Senior Policy and Advocacy Advisor, Allied Health Professions Australia.
Great, thank you. Would you like to make a short opening statement?
I do. Thank you.
Please go ahead.
Thank you, Chair, and thank you to the committee for the opportunity to appear today. I would like to acknowledge the traditional lands on which we meet, the lands of the Wurundjeri people of the Kulin Nation. ARPA is the recognised national peak body for allied health. We represent Australia's second largest health workforce, which is a highly regulated sector that is central to the capacity building outcomes the NDIS was designed to deliver. I'd like to be clear from the start, ARPA does not support this bill passing in its current form. We support a sustainable NDIS, and we do acknowledge the government's responsibility to manage a financially sound scheme. But financial sustainability must not come at the expense of the scheme's original purpose as a rights-based scheme built around individual need. This bill does not make modest adjustments. It fundamentally reshapes the scheme, narrowing eligibility, reducing supports, limiting reassessments, and concentrating significant ministerial power with too few safeguards against future misuse. Most critically, this bill opens the door to a future where reasonable and necessary supports are no longer fully funded. Broad percentage-based cuts through support determinations and hour or cost-based caps contradict the very principles of individualised needs-based planning. This is not a risk we can accept. Capacity building supports, including allied health therapy, will be among the first areas affected. These supports exist to maintain function, achieve developmental outcomes and build independence. Cutting them does not save the scheme. It shifts costs elsewhere and reduces opportunities for participants. The clinical expertise of allied health professionals cannot be replaced by standardised algorithms, automated processes or non-clinically trained personnel. Allied health professionals must retain a central role in assessing functional capacity, determining support needs and delivering care. This bill puts that at risk and with it, participant safety. Our submission calls for several important amendments to strengthen participant safeguards and review rights, ensure evidence-based services are properly funded, prevent the exclusion of people with limited means, and require the Commonwealth to build the ecosystem of supports outside the NDIS, including through Medicare, before reducing access within it. The NDIS has been world-leading. It was built on a commitment to Australians with disability that their reasonable and necessary needs would be met and they would have genuine choice and control over their lives. We urge this committee to uphold that commitment and make recommendations that strengthen this bill accordingly. Thank you.
We'll go to Senator Steele, John.
Thank you very much for your evidence today. Before I begin, just checking you're comfortable for your evidence to be filmed by my videographer?
Yes.
Fabulous, thank you. What is the flow-on impact that you see as occurring from further cutting capacity building supports? Do you think this could impact areas such as assistive technology, for example?
Thank you for the question. I think that there are potentially significant flow-on effects. So, as we note in this bill, there is a proposed 10% cut to capacity building supports from the 1st of October this year, and that alone could have significant consequences for individuals within the scheme. I think looking at the explanatory document that runs alongside this, my observation would be that there hasn't been sufficient modelling to help us actually genuinely understand the impact of a 10% cut plus a further cut that could occur down the track.
And what impacts are you seeing currently as an organisation from the basically impacts to the viability of allied health professions and their kind of presence in community from the cuts that we are already seeing, and the plans to say shift so many people, particularly kids, over to programs like Thriving Kids.
Thank you, Senator. Philip speaking. What I was going to say is what we're already seeing now is a real, pause in workforce development and investment within organisations. There's a lot of anxiety and uncertainty about the future. So we're hearing right now, really there are sort of significant changes already happening in terms of, building future capacity and, again, just continuing to invest in those businesses. We're hearing people not replace staff if, somebody, chooses to leave employment or whatever else. And I guess more importantly, what we're deeply concerned about and what we've spoken to, all of the relevant ministerial officers about is, the lack of modelling of the impact on this. If we look at the history of NDIS, we've spent an enormous amount of time trying to identify thin markets and trying to address those. We know we've still got significant underutilisation, and that's something the government has drawn on to try and minimise, the potential impact of these cuts. But that underutilisation has specific reasons. It means, it's most often in those areas where there's a lack of services. So it's not just that every, participant's plan is not being utilised, it's that there are specific areas that have issues. And once we start to take part of the client base in that area away, we challenge the sustainability of that organisation. If you've got a regional allied health business that serves a range of ages, providing disability services, and you're now not going to be eligible to provide most services for children, 0 to 9, because what we're seeing is that commissioning processes are going to preference larger, particularly non-government organisations, rather than the private businesses that make up the majority of the NDIS market. You start to challenge the sustainability of that business. And it's uncertain. We're not going to see the same impact everywhere. Where we are, I think, going to see the bigger impacts are in the thinner markets, are in the areas that are actually difficult to run sustainable businesses anyway.
Can I ask you to drill down a little bit there? What are the concerns that your organisation has about the proposed move to block funding and the impact that could have on smaller local allied health professional organisations and businesses?
If we take the example of New South Wales with regard to the Thriving Kids program, because that's probably the jurisdiction that we understand the best at this stage, the rollout of the expression of interest is open to NGOs. And so if you're an allied health provider and you're employed in one of those NGOs, then you may be required to provide services within the Thriving Kids program at a New South Wales level. But that expression of interest is not open to small or medium-sized private practices. The majority of allied health practices, the majority of allied health providers actually don't work in a hospital setting. They work outside of the hospital setting in the broader community setting in small to medium-sized private practices. So the Thriving Kids program, as an example, threatens the business model that we use to fund and deliver services across the community. Now, it occurs to me that when we look at making changes through Medicare, for example, and making changes to a single item, we will consult extensively before those changes are made to ensure that we preserve the business model of general practice at all costs. Now, this is not about general practice, this is about allied health, but we seem to have a willingness to make significant changes to the funding mechanism that funds the way in which we deliver allied health services across the NDIS, across aged care, and across Thriving Kids.
And just to be clear, what your concern is that this will particularly impact small to medium-sized businesses that may be operating in kind of rural settings or regional settings, for example, with the impact that, are you worried they just basically won't service NDIS?
I'm very worried that they won't service NDIS. But to answer your question, there's actually insufficient modelling to genuinely help us understand the nature of the impact of these reforms across the small to medium-sized business. And that's because the sector, so allied health, does not have a national allied health workforce strategy. I believe at Senate estimates last Friday on the 5th of June, there was some discussion that implied that there was a strategy. That is a draft document that has been in draft for over a year. And what that actually means is that no one has a very strong handle on the distribution of the workforce across the country, including in rural and remote areas, nor the activity. And the last bit, that's fundamental, because allied health, as you know, in the private practice market is funded many different ways. And if we don't genuinely understand the business model that sits behind it, it is very hard for anyone, including government, to make genuine assumptions around the impact on the small to medium-sized business model.
And allied health expertise is... sorry?
Sorry, I was just going to say, it's Natalie. Just to build on that, I was just going to say as well, in the impact analysis, and we've had public commentary around this as well, that there's been commentary that it won't significantly impact the allied health workforce, citing that we have unmet need and demand in other areas of the care, like as aged care and veteran affairs. And at ARPA, though, we feel that's a really overly simplistic view of how allied health workforce operates that doesn't recognise the extensive skills and expertise and experience of these allied health providers who are working in disability. It also fails to recognise and address some of the issues in the other schemes that we're referring to in these places.
And allied health currently, your expertise is central to collecting evidence in relation to accessing the NDIS in the first place. The bill allows unqualified agency workers to make many of these decisions and to conduct the assessments for access decisions instead. What do you think the risks could be of this approach?
It's really uncertain, I think, is the clearest answer we can give now, but I think there are real warning signs. We certainly see plenty of examples in the current system that the planning process and the, role of delegates can often conflict with the clinical advice that's provided, in a way that I think ends up with poorer outcomes for participants, but has also led to a lot of the reviews and issues we have. Again, the bureaucracy, the slowing down. So we know that approach of having, people with perhaps insufficient expertise to make decisions do so is risky in and of itself.
Yeah,
I think also the aged care system is a very different one, and yet there are some real similarities from our perspective in what we're seeing roll out in terms of the aged care assessment process, the potential to have assessors in that system identify potential issues, but what we've sort of heard is not potentially be able to override more automated processes. So even where the assessors have got the skill set to identify perhaps more individualised needs, that system certainly hasn't been able to account for that. Now, we can't be certain, sorry, last thing I'll just say, we can't be certain that that's going to be an issue because at the moment there's still a lot of uncertainty about what new framework planning will look like. And it's essential that we get it right, but there are real risks. Apologies, Senator.
And what are your concerns about introducing automated decision making and essentially taking away the human decision making in this process?
The huge variation in individual needs. We've heard, I think some really passionate advocates this morning give really quite specific examples from, the participant perspective. That's something we hear through providers all the time. There's just so much individual variation in terms of a person's needs. And I think the more standardised an assessment process is, the fewer opportunities there are to consider the influence of environmental factors, personal circumstances. Again, parental capacity is something that's been spoken about. We hear a lot about how much variation there can be in parental capacity due to the parents' support needs, parents' mental health capacity, mental well-being, as well as, just sort of other factors, relationship factors, financial factors, all those sorts of things. And so the more we sort of standardise this process and the more it's automated and doesn't allow, overrides where the assessor is identifying issues, I think the greater the potential risks.
I'll pass back to the Chair.
Thank you, Senator Steele. John, we'll go to Senator Askew.
Thanks. I just might continue on the workforce just to start with, and then I'll go to some other questions that I have. So do you think there is a genuine understanding by the agency or the department in regard to how an allied health practice is operated, or what the range of types of practice? I mean, there's so many different models, and what could we do to actually improve that awareness?
That's a very good question. No, I don't think that there is a genuinely deep understanding of what goes into the making up of a private practice business model. And I think that's because it is much more complex than any other part of the way in which we run outside of the hospital sector. Allied health, as many of you would know, is funded through DVA, through Medicare, through the NDIS, through private health insurance, and there are 14 compensation schemes across the country, 2 in each jurisdiction. So the business makeup of every allied health private practice is a little bit different. So you could line 5 private practices up and they would have a very different model. It also varies significantly depending on where you are located. So if you're in a very remote area, you're probably not having a business makeup that has a high proportion of private health insurance coming through your door compared to an affluent metropolitan suburb. That needs to change in order for us to actually do substantial modelling to help us anticipate how we're going to meet demand. I think what was discussed this morning is demand doesn't go away. Demand is going to be moved outside of the NDIS into that broader ecosystem that sits outside it. And an example of what that would look like is where there's a demand requirement outside of the NDIS, the sector, so allied health, is funded through Medicare. A consumer can have 5 services per calendar year. Now, if there's unmet demand through the NDIS, 5 services per calendar year is going to be woefully insufficient across all of the allied health professions to meet your need.
If I can add just one other quick comment. One is to say it's clear the agency has identified how, little understanding they have. So we've got the quality supports pilot at the moment, which is unfortunately only working with very large providers, but is intending to, close some of that knowledge gap and better understand, at least from a very large provider perspective, what that sort of cost structure is. Our argument is that work is needed in the small to medium space as well. But the other comment I'd make on workforce is the allied health sector is incredibly complex. We've not only got the range of different professions, we've got potentially deep specialisation within the professions. If we look at something like occupational therapy, we've got a specific area of endorsement for mental health. That work is fundamentally different to somebody who's got the highly specialised knowledge needed for prescribing complex assistive technology or supporting home modifications. And that's not just in occupational therapy. We've got that in areas like psychology and speech pathology, the difference between paediatric and adult practice. And again, that's not about those specific professions only. It's something that we find across the professions. So just knowing that we've got a particular allied health profession in a region doesn't necessarily tell us that they've got the skills and focus to actually meet the needs of participants in those areas. That's an issue we've been advocating around for many years now, and we still haven't really addressed that. Again, it comes back to the need, to go back to that allied health workforce strategy and what that identified in terms of the huge data gaps we have to help us actually start to, know where we've got problems, know where we need to sort of invest more.
Yeah. And I think that leads into my next question, and I think you touched on it a bit earlier, that there's an assumption that Thriving Kids has been announced and everybody will be moved from the NDIA to Thriving Kids, and the same people will be providing those services but outside of the NDIA. But from what you've said earlier, which did alarm me a little bit about the fact that the EOIs aren't open to the small and medium business. So can you elaborate a bit on that, but also explain how that isn't going to be as simple as just picking up and moving to provide the same services?
I think we made an assumption early on in Thriving Kids that it would be the same workforce, the same allied health providers that provide services into Thriving Kids and through the NDIS. And that makes sense, because if you've got the expertise in the broad area of disability, that works. But what is playing itself out as we come to better understand the model in each jurisdiction is it's not going to be necessarily the same employment model. So it might not be the same workforce. So, and I speak to that New South Wales example because they are the state that has progressed their Thriving Kids model into the public arena, so we understand it best. But it is unlikely to be the same allied health professionals, which means that we either need to upskill a new cohort of allied health professionals to work in those NGOs to provide services to that disability thriving kids environment, or we're going to find that, particularly in regional, rural and remote areas, if the NGOs don't stretch and have a large enough geographic footprint, we're going to have some serious gaps in access to occupational therapy, speech pathology and psychology, and physiotherapy in particular, that will form the backbone of that thriving kids model.
And I think sorry, you go.
If I can add one more thing, I guess one of our concerns is the primary health network space is a very different one, but it's one where we've had commissioning processes in place for some time now. And what's been really clear, both through formal reviews and the work we've done with PHNs, is that they started out with a model that really focused on very large providers, and often large providers that didn't have a footprint in all areas, who then had to recruit workforces and build up capacity. And what we're seeing more and more is there's a realisation that more nuance is required in the commissioning space, that doesn't necessarily result in the most experienced providers and the coverage that you would want. Some of our kind of engagement with both the Commonwealth and individual states and territories has been to say we need to learn from that. We need to not go into this process, make the same mistakes for a decade and then try and sort of see if we can, patch it. But that seems to be exactly what we're doing. If we speak to New South Wales in particular, what we're understanding is it's not even just small and medium providers, it's even large providers of allied health services that won't be able to participate. The other thing I'd add, if I can add just one more thing, is just that we built this market. We spent, again, I've been involved in this space for a very long time now. We as governments said to the allied health workforce and other workforces, we need you in this private market. We need to build capacity. And it feels as though we're now punishing that workforce for doing exactly what we needed them to do.
So the one thing that I think out of all of it as well is the people actually impacted the most are going to be the participants, especially the children in the thriving kids space. So that move, if there is that change, they're going to be moved from one provider to another, and it's going to be out of their hands or out of the family's hands to do that. So it's a bit of a concern for me, having worked in that space in the past myself. But I did want to touch on one other part of the proposed legislation, and that is what your members' views are on the proposed shift to greater ministerial control over pricing and what that will mean in practice for your members.
We would call for an independent pricing authority, similar to IHACPA, in the same, we don't support that the Minister of the day has the powers and the authority to make recommendations and changing into pricing. I think one of the issues, it doesn't resolve the issues that we've had to date, and they are issues around transparency. And so issues around understanding the pricing methodology that's been applied, understanding the pricing methodology that's applied to small to medium-sized allied health practices and not just large allied health practices. And that's a really fundamental difference. So it's not just that the Minister would have powers to independently influence pricing, it's that there's no requirement in this legislation to reveal and to transparently provide the methodology that sits behind the pricing.
Okay.
And that was clear in the independent sort of pricing review. If we look at some of the work that was done, it was very clearly identified that we've got those significant gaps. And again, speaking about that pilot that's being undertaken with the very large providers, some work is already happening, but we need to build the foundations. I feel like so much of this bill is trying to address issues that it won't actually address because a lot of them are systemic issues. We don't necessarily have the capacity to do the benchmarking we need to. Perhaps we don't have the payment, systems that we need to ensure, I guess, greater ability to sort of track where things are working and so on and so forth. So, yeah.
If I've got time, I'm just going to touch on one other area. In your previous submission to the inquiry into the integrity of the NDIS through the Joint Committee, you note that managing fraud and non-compliance is a key means to ensuring the integrity of the scheme. Based on the changes proposed in the current bill, do you believe it addresses the fraud and non-compliance?
Not sufficiently, no. I think actually we would have been expecting that there was more significant legislative reform around fraud, given that the narrative has been fraud is a significant driver of cost, then this legislation doesn't necessarily go close enough to that. I would also note that we picked up in that previous parliamentary inquiry that ARPA does continue to call for the NDIA to meet with us to help us better quantify and understand the nature of fraud as it relates to allied health.
So is there anything else that you could see that should be done to actually, within the bill, amendments that we could make to actually try and improve that?
There's really three things that I'd like to touch on. One actually sits outside of the bill, and that is to delay any substantial change to the bill until we actually get the ecosystem of supports outside of the NDIS fully established. So the bill as it currently stands, if that passes, it's going to create gaps. And certainly for the allied health sector, there isn't a fully established pathway by which we're going to meet that demand. So that's a significant concern. The second piece relates to what's in the bill around reasonable and necessary, and specifically that's deleting item 66 and retaining the principles for a participants plan outlined in section 31. And then finally, I'd just like to touch on permanence. So we do recognise the need and the importance of demonstrating permanence, and we recognise that that is not new and that this bill strengthens it. But we do request that all appropriate treatment, to include treatments that are readily available, they need to be affordable, they need to be culturally appropriate, and they need to be accessible. So we're very concerned about the strengthened requirement for permanence. It introduces further inequity into the scheme, particularly for people who live in rural and remote areas for whom those treatments just may not simply be available. And also there's an equity component around cost there.
Excellent. Thank you. I better hand back to the Chair. I've gone over time. Sorry.
Thank you. How do you think we would better recognise and include the views of your industry? How would we better engage you in the process?
One of the things we've been talking with the Minister's Office for some time now is the need to have effectively a formal reference group that we think should have some degree of independence from the NDIA, but the connection should be with the NDIA, because we're doing an enormous amount of reform of the therapy support space in all different areas. We're doing it around pricing, we're doing it around functional assessment, we're doing it around evidence and what's appropriate sort of practice, and we have nothing in place. So we have regular engagement with the NDIA, but we don't have the formal mechanisms that those sorts of reference groups have, where there is reporting of information from the NDIA to that reference group. There is formal, talking about what are we seeing, formal advice back to the agency to influence, how decisions are made. This is something for us that does need to sit somewhat across the department and the NDIA because of the fact that the department holds the policy responsibility. So the exact structure, I think, still needs some work. But I think the principle is in place. We're doing an enormous amount of work and will be doing an enormous amount of reform over the next 12 to 18 months and beyond. And we need the mechanisms to formally monitor, to evaluate and provide advice and feedback back.
Okay, thank you. And you referenced the fraud measures being insufficient. Do you have any recommendations about strengthening the fraud aspects of this of the bill?
One of the things we've spoken before, and we know it was raised earlier, is this idea of having enrolment of some sort, really actually ensuring that if you're a provider in the NDIS, you're actually identified by the NDIS. There's an ability to actually track who's receiving payments and for what. For us, that's a relatively basic requirement that we see really in every other scheme. If you want to provide Medicare services, you have to have a Medicare provider number. Now, that's a very different thing from registration. We're not saying to health professionals, you need to get new registration to prove that you're a health professional with, ethical requirements, with standards, all those sorts of things. No, we instead say this is a payment system requirement. This is something where we just need to know who is it that's charging against a service. How can we then use, the various tools we have to assess whether the volume of services you're providing are appropriate. All the sorts of integrity measures that we have in place under other systems are enabled by having the capacity within those sort of payment systems and having that sort of enrolment. But what we keep talking about is registration, as though that will fix it, and our view is that it won't.
Okay, because you think it's insufficiently...
I think it's a very different thing. I think registration has a purpose, and I think it has a really important purpose for non-health professionals. I think where there is not already a regulatory scheme in place that provides the mechanisms to ensure you have the skills and qualifications you need to provide services, there are mechanisms to ensure if there are issues with your clinical practice that those are addressed. And that doesn't just include prohibiting someone from practice. There's a lot of quality measures in place that come way before prohibiting somebody to, again, just make sure that, we're maintaining quality standards. It's about making sure that you are subject to standards and competency requirements, recency of practice, all those sorts of things are fundamental, and they exist across the allied health professions, whether you're an AHPRA registered profession or you're a self-regulated health profession. It doesn't exist for some of the workforces out there, and I'm not going to comment about what's appropriate there, but I do see that where there is no regulatory system in place, there are additional needs. But for me, that registration, that sort of professional practice thing is a very different thing from sort of payment and business requirements, just to make sure that what we're doing is we are actually just, as I said, understanding who we're providing funds to from a government perspective and what we're providing them for, and that we can track back and audit those later if we need to make sure that things were appropriate.
And it's Natalie, just to extend on that, I was just going to say as well, similar to what we see in Medicare, those health professionals have to prove they are AHPRA registered or certified through their relevant peak body for the self-regulated health professionals. And we need to ensure that's happening in the NDIS space, because we've seen examples before, and the report that Stephen Duckett did into art and music therapy showed that we have many more art and music therapists claiming in the scheme than actually exist within the registration program within the professional bodies.
I suppose one of the... sorry. So, Askew, did you want to follow up?
I was just going to do a quick follow-up in regard to the red tape that would be required to register as opposed to doing a provider number, which I really quite like the idea of. But what the difference would be from that, just in comparison, do you think?
Well, I think it's a really massive difference. So if we look at, I guess, the current iteration of NDIS registration, for a start, we went in and actually required, so there are two levels. There's verification and certification. We required effectively a much too high level of certification for a lot of providers based on business structures. We corrected that, but effectively the process is still quite an administrative process to start with. And then we lay on top of that the requirement for third-party audit. And third-party audit has, from our perspective of the current system, not very good protections around it. What I mean by that is there's a lot of capacity for that third-party auditor to determine what level of audit is required for the practice. For example, how many participants need to be interviewed, how much can be done as a desktop audit, how much needs to be done on site, and all of that impacts the cost of that audit. What we've heard consistently since that was introduced is that if you're a regional or a rural provider, you are paying for accommodation and transport, you've got much higher third-party audit costs. We also saw just the cost, I think, driven by demand. We had a massive number of providers having to go through third-party audit. If we were to do that for the 55,000 providers, I don't think we have capacity in our third-party audit system to, in any cost-effective way, audit 55,000 providers over the next few years. So it's almost like there's no possible way for it to work. But again, we also just don't see that it adds anything that increases safety for the participant, because again, if you're receiving an allied health service, you should be protected regardless of whether you're doing so under a Commonwealth program, regardless of what that program is, a state and territory program, or whether you're privately funding it. The same as we expect from our medical health professionals.
Senator Askew, I'd like to add, I think there is an important and fundamental requirement to safeguard participants in the scheme, and that absolutely is paramount. But red tape, I think there's no doubt that if you are a very small, like a single person private practice in a rural area, the overall proportion of patients or participants or clients that you see that sit inside the scheme might be minuscule. So we need to balance red tape with the requirement to pay. If you're paying $6,000 for a third-party audit and you're a sole practitioner in a rural and remote area and you see 4 participants in the scheme, you're probably not going to do it. And so then we exacerbate or we amplify the thin market. So I think we just have to be really clear that we're putting in place mechanisms that solve the problem we are trying to fix, and don't just, registration for the NDIS purposes, it's an expensive process, and we want to be very clear that that's actually going to solve the problem that we are trying to fix.
Thank you. Sorry. Thank you so much for your time. We really do appreciate the time and effort you've put in to assisting with this inquiry. It's much appreciated. we will let you go.
Would you be able to just take on notice for me, though, how many Australians are employed in small and medium-sized allied health professionals?
We will do our best,
Yeah.
noting the data issues we've spoken about.
Noting the
before.
data.
We will provide
Yes.
the best version we can.
The best version that we can.
With all the
By
required
Friday.
caveats.
Yeah, exactly.
And if you could do it by Friday, we'd
Yes,
be very
yes.
grateful.
Thank you for your time.
Thank you so much. We really do appreciate it. I would now ask Dr. Dinesh Palipana to come forward. Thank you for joining us today. We do appreciate your time. Now, I understand that you have been provided with information on parliamentary privilege and the protection of witnesses. Yes? Yes, thank you. Now, this session is an opportunity predominantly for the community to hear from members of the community about their lived experience. So we'll remind the committee of that, and this session is primarily a listening exercise, but obviously we'll invite questions of you after that if you are comfortable with that. I'll also just check with you, Senator Steele-John has a videographer in the room who's shooting footage for his own purposes. It's not connected to the Senate or to this hearing in that sense. Are you comfortable with that? Because it's totally okay if you're not.
Of course, Chair, that's fine.
Okay, lovely. Thank you so much. Would you like to introduce yourself and provide us with your statement?
Of course. Chair and the committee, thank you so much for giving me the opportunity to come down to the very cold city of Melbourne from Queensland and share some thoughts. I work as a doctor in Gold Coast. I work in the emergency department. I trained as a lawyer before medicine, and I have a spinal cord injury. Every day I wake up and I think of the things that I'm grateful for, and one of the things is to live in Australia. And this is because I was born in Sri Lanka. And if I were to have an injury like I do in my country of birth, my life expectancy would be a fraction of what it is here. We're very lucky to have the medical care that we do. We're very lucky to have a scheme like the NDIS. And to put it into perspective, Sri Lanka has a population of about 23 million to Australia's 27 million or so. And we spend on the NDIS about 30 to 40% of their entire GDP. I think we're very lucky to have a scheme like this, and it allows me in this country that has taken me in to live a very fruitful life. I had a spinal cord injury at the age of 25. I was in medical school at the time. It changed my life in ways that I never imagined. I never imagined what it's like not to be able to walk. I never imagined what it's like to be using a wheelchair. I never imagined what it's like not to be able to use my fingers anymore. But also the social devastation that happened around it was significant. My mum and dad split up, and my mum, who is here with me today, as a proud mother to watch this still, even at the age of 42 for me, she has been helping me every single day still with so many things after the accident. I think the contribution of unpaid carers into our system here in Australia is in the billions of dollars. And as we go on about these conversations, I think their contribution should be acknowledged, those people like my mom. Those days we didn't have the NDIS. This accident happened in 2010. And I became a member of the state-based scheme that was looking after those like me at the time. And it was challenging to start with. I remember when I first started receiving care, the funding was given to an organisation that is now controversially shut down. But I was a medical student then. I fought very hard to come back to medical school, and the schedules were crazy. When I was a student in surgery, the hours were long. I used to wake up at 3 a.m., get home at midnight, sleep for a few hours and do it all again. But for the organization that was providing care for me at the time, it was a very prescriptive setup. They wanted to maximize their profits. So they gave me people on the weekends when I perhaps didn't need them to help me. And when we really needed help, it was just my mum around. So she had to work extra hard to get me through medical school. She had to come to the hospital with me sometimes, and it was a tough time. But the NDIS really changed the way I can live and work and function. There are a lot of people in the community of those with disability that will give perspectives on many things to you, but I wanted to focus on just a couple of things. And one of them would be the registration of personal support workers. I work as a doctor today in the emergency department. I worked in the emergency department on the weekend. And my schedule is variable, as a doctor's might be. So for me, having a registered or unregistered support worker has not made a difference. It's actually people who care, who love, who believe in what I do. And these days I have a team who are so flexible, who work with each other, who make sure that I can get the work done, and they swap shifts, they come in at different times, and they work with each other to make sure that I can live the life to the fullest. And really that's what we invest in, isn't it? The NDIS is designed to invest in people to live their life to the fullest. Because of that, I can pay taxes. I can be here today and give you a perspective. I can contribute to the community. I can do all these things. I'm very cognizant of the investment that the public makes in me, and I try to do my best to make that investment worthwhile. But it depends on having a good support team. And for me, having a team of guys that are not registered, but they care and they make life happen. This was especially important when I was going through my junior years as a doctor, when some days I was awake for 24 to 30 hours, but the guys would come in and go out and swap as they needed and make sure they kept afloat. But again, they were not registered at the time, but they got me to where I am. I was at work on the weekend, working in the evening shift, and I came across an NDIS participant then. This participant was supported by a registered provider. Their medical care was completed at about 7 p.m., 8 p.m. by me. And I looked at getting them home. But unfortunately, when we tried to get this person home, I was told that the support workers have left and there's no one to look after them at night, even though they're funded to do so. And so this person ended up with their intellectual disability in a hospital, in a loud environment, surrounded by infections and other risks, to spend the night with us until we can find their care again the next day. So registered does not necessarily mean good quality. Registered doesn't mean better care. What we really need, I think, is more detail about how we're going to work this out, and a continuum where perhaps for people like me, we can have a lesser level of oversight in the registration requirements for support workers. And perhaps for people like my patient on the weekend, we have a higher level of scrutiny. But we're not quite getting that right at the moment. The most vulnerable in our society are still slipping through, and even registered care providers are not held to account at the moment. I think we do have some really good schemes in the country to look to. we don't necessarily, we always think about the NDIS when it comes to disability and care, but we forget that there's the NIIS. And I've done some work with colleagues in Queensland and South Australia, and I find that they're nimble and small enough to provide really good care for the participants that come under their scheme, so perhaps there's something to be learned by them. A couple of final thoughts from me is that I was talking to one of your colleagues from the federal parliament last week, and he said the NDIS was never designed to be a job creation scheme, was his comment, but actually this has created this huge economy for us. It does create jobs for people. There are people like those who look after me and provide services to me, and I think for them it's really important, especially as perhaps single operators, not to have the extra bureaucratic burden. The other thing is, I think we have to look towards the future to look at reducing the costs of these schemes, and perhaps one of those things that the state systems do really well is to invest in research. I run a lab in spinal cord injury research, and the state National Injury Insurance Scheme and the Motor Accident Insurance Commission makes a great deal of investment into this research. So actually when we're talking about exhausting all medical care, they're expanding the gamut of the medical care that is available, so people have more options before coming into the scheme. Overall, I really want to thank you for your efforts in shaping the scheme for better for people like me. I think in Australia we are extremely lucky, and I'm cognizant of that every single day. But at the centre of this all should be the human being, should be the person with the disability. For me, it's been a massive change in my life. Living in this country enables me to live, to work, and to enjoy a full life, and I'm so grateful for that. But I think as we do our work, my mum likes to say that by helping one person, we may not change the world, but we will change the world for them. So while we are shaping our country for the better, we should make sure that the person at the centre of it still has a good world to live in.
Thank you so much. We really appreciate you coming and sharing your story. Would you be open to a couple of questions?
Of course.
Senator Steele-John?
Thank you very much, Chair. Thank you very much, Doctor. I really appreciate your evidence today. Could I ask you, as an NDIS participant, do you have a social and community participation funded in your plan at the moment?
I think it might be, you know what, that's actually a better question for my mother who looks after the plan. But, I just go on about life. And
would you like to join us, Mum?
Yes.
Maybe just for the hand side, if you could just record your name, that would be lovely, if you're comfortable.
Of course. My name is Chitrani Palipana.
Thank you.
And I'm Dinash's full-time mum.
Thank you. Thank you, and apologies for causing you to come up here today. I just wanted to know, in terms of Dinesh's plan, is social and community participation funded within that plan?
Yes, he does.
Yes.
Under the co-funding, he does.
Yes.
Yes.
Okay, thank you. And then I'll default back to you unless you indicate otherwise, Doctor. But so that would mean that some of the support workers that you've described to us, most of them actually, that help you leave the home or do things beyond the home, they would be funded under social and community participation, or funded flexibly when other, through social and community participation when other funding ran out within your plan. That's correct, isn't it? Is that how you currently manage it?
You want to answer that?
Yeah, Dinesh is self-managed.
Yes.
And that's how he actually manages the funding.
Yeah.
And
yes.
Between community access when he's out and about,
Yes.
mostly he's out and about at work and doing other things. Yeah.
So I'm wondering, given that the bill, as we currently have it before Parliament, seeks to make a 50% cut to social and community participation funding for all participants, what impact do you think it would have on your ability to do your job as a doctor and to live as a member of your community if you had to see that kind of cut made to your plan?
I think if it starts to affect the way I live and work, it would be significant. I not only work as a doctor, but I do a lot of other things. I run a research lab. I try to go out and talk to different parts of the community, to children, to schools. Would be in the hundreds now. And I do that out of my own time. But a lot of that would be impacted if this were to be cut back significantly. And I think it's the same for many people out in the community.
Another thing that came to me listening to you speak, the legislation at the moment gives the government the power to prescribe that certain types of supports may only be delivered by registered providers. So the kinds of supports related to kind of personal care and things like that is what's often described. In your view, is it the participant or is it the government that should have the ultimate decision as to who is the most appropriate person to decide who should support you with those tasks of daily living and that kind of very intimate and personal supports?
This is an incredibly intimate thing. I never imagined that, to be completely frank, that someone, an outsider, would see me naked. This happens to people. I never imagined some of the things that would change in my body, and so the things that people do to deliver care is incredibly intimate. It's incredibly personal. I have had registered care providers in the past. I've had unregistered care providers in the past. What matters the most actually is your level of comfort with the person and that person's willingness to understand and to work around your needs and your environment and your life. So I think when it comes to this, it should be the person's choice. And this is what this is about too, isn't it? It's about choice and control. We should all be afforded the opportunity to have choice and control over who touches our body, who helps us with these things, like bowel and bladder care and showering, for example. This should not be prescribed to us in a country like this. So I think it should be up to the person. And on that note, Senator, one of the other things, and I believe that every single one of you on this committee are passionate about this country and the community, and that's why we have entrusted you with our communities. But I grew up in a country that had no checks and balances when it came to the government. I grew up in a country where journalists were murdered, where people were kidnapped. My mum herself rescued young people from being murdered in a dungeon in our town by the government. I think the expansion of ministerial powers is another concern for me philosophically, as a person who has come from a place that was so troubled into a place like Australia where we feel safe. So I think these things, they creep in and we make small concessions and it grows. So I think the matter of ministerial discretion should also be approached cautiously.
And just finally, Dr.
Please, go ahead.
Finally, not only are you a medical professional, but you were also, I believe, an expert legal advisor to the Disability Royal Commission. We've heard earlier in the day concerns that the definition of all reasonable treatments that people must have exhausted before they gain access to NDIS supports within the bill as proposed are so broad as to potentially violate the patient right to refuse care in certain circumstances. Would you as a doctor have a concern about that same issue? Does that strike you as something that could be a problem?
As a doctor, one of the fundamental tenets of our ethical values is autonomy. So if you're asking me about the treatment of people without their consent, I would say absolutely not. I think everyone should have the autonomy to choose the type of treatment and to consent to the type of treatment that they want. I think this is a tricky topic to approach. I think there are people in our community, especially in rural and remote regions, that have difficulty accessing medical care. So this requires a lot more consideration and discussion
than we've currently had. Yeah. And with all of that said, Doctor, with the bill in its current form, do you think it should pass?
I think this is one of the NDIS is one of the most important social systems in the history of our nation, and it is one of the beacons in our world. I think it's an example to other nations. For any change, I think it needs to be approached cautiously with a great deal of care and thought. I would urge you to at least take a bit more time to think things through and to work out the detail.
Okay, thank you. Thanks, Chair.
Thank you. Senator, ask you
I just wanted to
one
say
quick
thank
one.
you. I don't need to ask any further questions because Senator Steele-John asked my questions. However, I just really want to say appreciate you coming today to Melbourne. I agree it is cold, but I come from Tasmania. But it's been great to hear from you and also to have your mother here as well. So thank you for coming, both of you, and we really appreciated your evidence. Thank you.
Senator, thank you so much. Thank you, committee, for your work.
Thank you. We really do appreciate it. The lived experience and the lived experience of carers is critically important in how we shape the scheme and how we look at this legislation. So thank you so much for your time.
Thank you, Chair.
I will just take a moment to remind people within the room that it is not appropriate to take photographs of other people in this room. If you wish to take a photograph, you need to seek permission from the committee. Thank you. I would now welcome representatives from Inclusion Australia. Do you know who it's with? It's probably Jordan's. Okay, thank you very much for coming along to join us. We have Ms Maeve Kennedy and Mr Luke Nelson. Welcome, thank you for coming. I understand that you have received information on parliamentary privilege and the protection and obligations of witnesses.
We have. Yes.
Excellent, thank you. For the Hansard record, could you both state your full name and the capacity in which you're appearing?
Thank you very much. My name's Maeve Kennedy. I'm the Chief Executive Officer of Inclusion Australia.
And I'm Luke Nelson. I'm a Policy Officer with Inclusion Australia.
Fantastic. Do you have an opening statement?
We do.
Please go ahead.
Thank you very much. Chair and committee members, thank you for the opportunity to appear today. As you just heard, my name is Maeve Kennedy and I'm the CEO of Inclusion Australia. We're the national peak body representing people with an intellectual disability and their families. I'm joined by Luke, who's an experienced advocate and policy officer with our team, who will speak after me. Inclusion Australia supports the intent of NDIS reform. The scheme has transformed lives and it needs to be sustainable, but the detail of the bill matters and we don't think it currently gets the balance right. At the centre of our evidence is the Disability Royal Commission. It found clearly that social isolation and exclusion increase the risk of violence, abuse, neglect and exploitation, and that connection to community is protective. That goes directly to the impact of this bill. For many people with intellectual disability, particularly those in supported independent living, social, community and civic participation supports are not supplementary. They're how people maintain relationships, participate in ordinary life and stay safe. Reducing those supports does not remove cost, it shifts it into health systems, crisis services and onto families and carers who are already under sustained pressure. It also increases the risk of people becoming isolated and less visible in our community, exactly the conditions the Royal Commission identified as unsafe. We're also very concerned about the scale of ministerial powers in the bill. As drafted, they would allow broad reductions to supports through legislative instruments with limited safeguards, limited transparency and no pathway for independent review. Decisions of this magnitude should sit with Parliament and be subject to scrutiny and accountability. The proposed permanence test also raises a serious and specific concern. As the committee has heard already this morning, there's a real risk that psychotropic medication used as chemical restraint could be considered treatment for the purposes of scheme eligibility. The Disability Royal Commission was clear about the harm caused by these practices, which disproportionately impact people with intellectual disability. The presence of a technical advisory body to support the development of an assessment framework for functional capacity, in our view, does not mitigate this risk. The legislation should explicitly guard against that outcome. And finally, the process matters. Accessible information is not a courtesy, it's how people exercise their rights. Easy read materials were available for just 7 days before the submissions closed. There was no exposure draft of the legislation and very little time for the community to work through its complex and far-reaching changes. Inclusion Australia wants to work constructively with government to get this right, but in its current form, we don't support the bill passing. At a minimum, we ask that the inquiry timeframe is extended, safeguards and review mechanisms are strengthened, and the impacts on social participation and safety are fully considered. The NDIS needs to be sustainable, and it needs to remain true to its purpose to support people to live safe, connected and meaningful lives in the community. I'll now hand over to my colleague Luke, who'll speak to what this looks like in practice.
My name is Luke Nelson. I am a Policy Officer at Inclusion Australia. I have been on the NDIS since 2013. The NDIS has changed my life. It means I am able to live independently and go out into the community. I have been able to do some amazing things for my work, contribute to society and earn a living. Because of the NDIS, I know that support will be there if I need it. But the changes in the bill make me afraid that I will not be able to get up in the morning. I am afraid that somebody won't be there to support me to get ready to leave the house. I need support to be part of my community. The NDIS was designed for people with disabilities to live an ordinary life. I live an ordinary life because of the support I receive from the NDIS. If these cuts go ahead, I am afraid that people with an intellectual disability and their families will lose their human rights. Thank you very much for your time.
Thank you very much, Mr. Nelson. Appreciate that. Appreciate you sharing. That's really, really helpful. We will go to Senator Steele, John.
Thank you very much, Chair, and thank you both for your evidence this afternoon. You've said really clearly that in your organisation's view the bill shouldn't pass in its current form and that there should be an extension of the inquiry. Have you got any suggestions for us as to what a reasonable time frame for that extension would be?
Thank you, Senator. Not a specific time frame at this point, but to an organisation really in the community, we are calling for an extension. We need time to go through the detail and to be able to work with legal experts. The Justice and Equity Centre do a fantastic work. You heard from Villamanta earlier today. We need time to really understand the unintended impacts. As a community, we didn't see the bill until it was tabled in Parliament. We had a headline. We had the headlines of the announcements, but not the detail, and it's far broader than we were anticipating. We understand the impetus for change and the impact of these reforms on broader government initiatives and direction, but we are really asking for more time to go through the detail. And from our perspective, we generally, as a rule of thumb, would appreciate at least a month for consultation to allow us to do really deep work with our community. And we also feel worried for the committee about how you will manage the 4,000 submissions that you have received and still be able to report in a week's time. Thank you.
Thank you. Now, you've raised in your submission really clearly a concern about the ability of this law to be used to require the use of a restricted practice, a medical restraint, as part of the process that you might be asked to go through to demonstrate that you have exhausted kind of all other options before the NDIS will then grant you access. Can you tell us a bit more about the risk that you see of granting a government the power to potentially ask that of people?
Yeah, thank you, Senator. Do you want to speak or do you want me?
I can speak a little.
I can do it.
Yeah. I think from my perspective, people are really, really scared about what this will happen, when this happens. But also, all they're asking for is a chance to have true consultation and also just be listened to. They're worried that if the law goes through, people, they feel like they're not being listened to. They feel like the government is just saying, you will do this, without saying that. Yeah.
Thanks, Luke. That's exactly right. And I think to Dr. Palapana's point earlier about autonomy as well, that's incredibly important for, as a community with people with intellectual disability, decision-making and support for decision-making is crucial. People have the right to make decisions about their own lives. The Disability Royal Commission had a specific public hearing about the use of psychotropic medication, and it clearly found that there are disproportionate impacts on people with intellectual disability. It was one of the earliest hearings that they held, number 6, because it is so clearly an issue. It was in the first year or two of their work. So the Commission heard evidence that the number and dosage levels of such medications administered to people with an intellectual disability are sometimes so significant in themselves they constitute abuse. It also showed that this happens disproportionately to people with intellectual disability, and then again more to people with complex support needs. And there are communication barriers there, so people can really struggle to exercise their right to make their own decisions about their life, particularly when there's pressure from government. We know that the medical system is already very inaccessible to people with intellectual disability. The government supports a National Centre of Excellence in Intellectual Disability Health. There's a dedicated program of work to addressing these inequities. The risk is that we are entrenching that, and we are therefore, and I think we understand that's not the intent of the legislation. We're worried that it's an unintended consequence and that we need to safeguard it. We know that people putting NDIS processes into practice don't always have the same understanding of the government about the intent. And the risk is that at a workforce level, even with people having the best of intentions, they will interpret it as meaning that people need to take really severe medication with really big side effects that's essentially sedation in order to prove that they have, quote unquote, treated their disability.
Yes, and we heard in estimates last week that the agency is already using the terminology of cure when it communicates with participants and their families. In the context of intellectual disability, what are your concerns about what seems to be an increasing emphasis on the idea of cure in relation to disability?
Yeah, thank you, Senator.
Can I just say, I from my personal experience, I have cerebral palsy, okay, and I don't mind disclosing that to the committee. Now, yeah, legend. There is no cure for cerebral palsy. So I feel that people will feel quite insulted by the agency by saying, you know, what is your cure? What is the cure for your disability? Will your disability go away? Well, my answer to that is, the answer is no, it will not go away. This disability is for life. This disability is a lifelong disability.
I really can't say it better than that. Thank you, Luke.
Thank you very much. I'll pass back to the Chair. Thank you.
Thank you, Senator Steele. John, we'll go to Senator Askew.
Thank you, Chair. Thank you for evidence today and for coming along. First question I want to touch on, in your submission you outlined concerns regarding the functional capacity definition, which excludes environmental and personal circumstances, which is assessed separately. You've highlighted the risk that is that important contextual factors are excluded to decision making. So with reference to the WHO ICF framework, does the ICF require environmental factors to be considered when determining eligibility for a disability support scheme, or simply when understanding a person's overall functioning?
Thank you, Senator. I'll just pull up my notes.
You're right.
We were looking at this because we understand that the department's submission to the inquiry referenced the ICF as well. So we're definitely, excuse me just a tick, I can't concentrate well on two things at once.
Take your time.
Thank you. Okay, thank you. Here we go.
Aaron, Maria also has a question.
So that's just coming up now. I think from our perspective, broadly, there's a risk that separating, so again, we can understand the intent in looking quote unquote objectively at a person's needs separate from their contextual factors. The issue is that one of the issues is sometimes those needs are only evident in certain environments, and so looking at something distinctively from a person's context won't pick up the full contextual factors. And the other issue is going to inequity. So understanding that it's intended to be separate from financial means as well, which is a good aspiration, but it's not consistent with the way that other parts of the bill are applied, particularly in terms of not funding, so a support or class of supports to your to the conversation last week, being deemed as reasonable and necessary, but then not needing to be fully funded, and the expectation that people will then pay out of pocket. So there's an understanding of separation from financial means in some parts of the bill, but not in others, which we find inconsistent. More broadly to the functional capacity assessment, so the department and the agency have said that it's compliant with the WHO ICF, which distinguishes between capacity and performance when assessing function. So it takes capacity to be a baseline depiction of physical function, stripped from context and support, and performance to be a more practical examination in a person's lived environment. The department says the bill only implements the capacity assessment to ensure things are equitable. Most applications of the tool consider it as a whole. It's unusual to take just one element. So any effort to limit the scope of the assessment, as this bill does, in our view, wouldn't produce the most accurate results about who needs support. That's why functional sits alongside capacity. It's more grounded in lived experience of disability rather than medical models alone.
Okay. So where you mentioned earlier that there are differences within the bill, if you were happy to provide us something else on notice, if there is any clarity around that, that would be great. We would be interested to see that.
Thank you, we can.
Your submission refers to people where their capacity varies depending on support relationships and routines. How do you believe assessors should objectively measure those variations without creating significant complexity or inconsistency in their decision making?
Yeah, thank you, Senator. I think this is one of the critical questions for our community, and I'll be honest, we can't answer it in the detail we'd like to now because of the time constraints, but we are thinking about the different elements of it. So, for example, we would not like to see a situation where somebody is currently living the kind of life that they want to, and that is only because of family supports or primarily because of family supports, and therefore they are assessed as not needing the level of support that somebody without that family access would need, because that's not fair, and we know that there's a lot of pressure already on families, but also parental responsibility, which comes through and is strengthened in the bill, does have complexity for our community, and we are really worried about the impacts that that will have. We're worried, I guess, and this is quite in the weeds, but in seeing, we are able to see some of the detail of the testing of the current support needs assessment process already by the agency, and understanding that is different from the functional capacity assessment for eligibility. It is still a really complex tool that is being rolled out at scale and that we need to test with community. It's early days, and we know that they will test with thousands more people this year, but it's not adequately picking up the support relationships yet. So it is, some of the examples that we have heard are relying on having the supporter, for example, a parent, in the assessment itself to be able to add context. If people don't have a parent who is engaged, who is able to give that time, who is as engaged as Dr. Palapana's mum, who gave evidence this morning, which was amazing. If people don't have that, or people don't have the financial resources, the educational resources, or we talk a lot about health literacy in health, what about administrative literacy here? It is so complex. It is so difficult. Yeah.
I just wanted to go quickly to the submission outlines concerns regarding the ministerial changes to ministerial directions and the power that it gives to the minister. Why do you believe it is, and I quote, stark contrast to the Disability Royal Commission's findings?
Thank you. There's a few reasons. So one of the things that's been curious to us is that the supporting materials do say that the bill and the reform direction is shaped by the Disability Royal Commission. We can't see evidence of that at the moment, and that's what we feel worried about. So the submission from the department to this committee mentioned the Royal Commission in the introduction and then no further. It doesn't cite any specific recommendations that this will support implementation of, or any evidence that was before the Commission. The social and community participation cuts are a clear example of where the move is specifically contrary to evidence and findings about the importance of community access and inclusion for safety. We're worried that the language in the bill about have regard to safety in support determinations is not strong enough, and that safety at the moment is only being conceptualised in terms of physical supports and personal safety in that sense, not about the protective mechanisms for broader safety and prevention of violence. We are also, our team is so wonderful, they have a list here for me. We are also concerned that this legislation might be contrary to other specific recommendations. So, again, increasing the use of restrictive practices. This was in Chapter 6 of the Disability Royal Commission's report, recommendation 6.40, around, and then the social and community participation cuts directly reflect on recommendation 7.41, and then also on employment recommendations, which our colleague from Down Syndrome Australia will speak to more after lunch. But there's actually a really important role for social and community participation funding and supports in enabling people's access to employment. Luke has spoken a little bit about that already, and I'll come to you in just a tick. But that's recommendation 6.30 as well, about employment supports. And we're hearing more and more that there will be potential impacts on the employment of people with disability themselves, their ability to meet their employment obligations, seek employment, maintain employment, but also flowing on to families. So we're already hearing from our members who employ a lot of people with intellectual disability and a lot of family members, that family members are worried about needing to reduce their hours or give up their jobs in advocacy, in our work promoting these rights, because they have adult children with disability who will need support, who will lose that through the scheme. Yeah.
I'll hand back to Chair, conscious that Senator Kovacic wants.
Yes, we will go to Senator Kovacic, who is online. Please go ahead.
Thank you so much, and thank you for your time today. I just have a follow-up to some of the evidence to Senator Steele-John, particularly regarding requiring people with lifelong and permanent disabilities to repeatedly prove conditions that will not improve. And what are the associated impacts of that in time, in fund depletion and administrative effort, not just to participants, but to carers and to the broader system as well?
Thank you, Senator. I'll ask Luke. Luke, would you be happy to talk about the impact of having to prove over and over again that you have a disability? And then I can speak to the broader carers.
So from my perspective, it's very tiring. It's like you've been judged to actually prove that you need support, as we've been talking about. But also, I would feel embarrassed because I have to prove every time that I have a disability, that I have a right to get up in the morning, that I have a right to go and have a shower. Now, as we all know, everyone has a right to have a shower. Everyone has a right to get up in the morning. So people with disabilities, we're humans and we're part of the community. We're taxpayers, we're part of the Australian community. So to do this is very, very harsh.
Thank you, Luke, and exactly right. And I think to add to that, Senator, your question did touch on really important elements about the need for additional assessments, the need for additional reports, the cost of those things, the time burden of those things, but also the administrative complexity. And pretty much across the board in any system area, employment, disability support pension, NDIS, the number one piece of feedback that we hear from families is the amount of time that it takes to administer these services and supports. People regularly tell us that supporting their loved one with their doing the NDIS part, not the support part, doing the NDIS part of that feels like another full-time job already, adding on the extra reporting burden.
And just to confirm, the cost burden of those additional reports all actually come out of the participants' funds. So we're actually using the NDIS funds to re-verify conditions that are lifelong. Is that correct?
That's absolutely our understanding.
And one final question, again, a follow-up to an answer to Senator Steele-John. Can you confirm for me that you actually believe that there will be co-payments? Is that your understanding that the NDIA will introduce co-payments with participants?
I think that's such an important question. We're not sure of that. We can't definitely say that at the moment. What we can say is that the mechanism is being set up where a level of support might be deemed as reasonable and necessary for a participant, and also the NDIA may genuinely and lawfully not need to fund that full level of support. So there will be a gap. The expectation, therefore, is that for an individual, if they would like to access the level of support that has been deemed as reasonable and necessary and is not being fully funded by the scheme, they will need to pay out of pocket for that gap. Okay,
so for my own clarity, it's not overtly been stated or made clear, but by the design of the mechanisms, it's obvious that that is something that is likely going to happen or potentially could happen?
It potentially could happen because of the way that the mechanism is being introduced about the support determinations and focus by the Minister on scheme sustainability and scheme finances, that there might be decisions made to that end that mean that participants are not able to get the level of funding that will fully allow them to have the level of support that was deemed necessary. I'm sorry, it's so confusing.
No, it makes sense to me. Thank you. Thank you, Chair.
Thank you, Senator Kovacic. Just on that, the Department of Health submission says there is no gap. I appreciate completely that what we have heard is that people don't have sufficient levels of detail from the bill, but there are a range of issues that have been raised that I can see very clearly would cause a great deal of concern across the community, and we will seek in our report to unpack those and provide that evidence where those causes for fear should dissipate, but totally respect exactly how you come to these conclusions. Thank you so much. Really, really appreciate your time. Senator Steele.
Could I just ask one follow-up?
One cheeky last question?
Thank you.
Off you go.
Look, thank you so much for your evidence on that. I'm concerned as a member of this committee that we might be entering an area of wordplay in relation to gaps and co-payments that is not helpful to the community. I sat with the department for hours on Friday and got them to confirm that what you have just described to us is the structure they've created, and then they just do that. Well, but we don't say gap in that, and therefore it's not a gap, it's a voluntary, nonsense. So if you wouldn't mind just providing us on notice just a little bit more of a fleshed out understanding, as you've just verbally given us, of what that structure could practically require of a family of an intellectually disabled person or of an intellectually disabled person themselves in terms of additional financial contribution. Because getting away from the label, it's the additional financial burden here that is the concern. And then we can understand that as a committee. Thank you.
Great. Thank you.
And we will, with a lot of the issues that have been raised, we will raise them with various departments that we're seeing later in the week to get further clarity on those issues that are causing levels of concern as well. So thank you so much for your time. Really, really appreciate it. Really appreciate all of your engagement in this inquiry. It's really, really valuable. Thank you so much. Now, you have taken something on notice.
Yes.
We are asking for it by Friday, but please talk to the Secretariat if you're going to have any issues there, and we'll see how we can maybe assist in whatever way we possibly can.
Thank you.
The committee will now suspend for a lunch break, and we will return at 1:15 p.m. Thank you. Recommence our hearing this afternoon with Protect Our NDS Alliance. And I thank you for taking the time to be with us today. I understand that you have received information on parliamentary privilege and protection of witnesses. Excellent. Now, we'll start with an introduction, if you wish to state your name, and I know that each of you have a few words you wish to say. I'll leave it to you to determine who wants to go first.
I'll go first. I will give a full introduction in the opening statement, but just as a brief start, I'm Aurelia Williams. I use they, them pronouns. Please do use those throughout the hearing. I am from Mianjin. I'm an NDIS participant myself.
Thank you.
I'm Andrew Brotherton, he, him. I'm a NDIS participant, disability advocate. I'm autistic and I have severe myalgic encephalomyelitis, and I can speak on the impacts of these reforms for people with fluctuating, complex and chronic disabilities, including concerns regarding foundational supports, functional capacity assessments, eligibility and participant rights. I also have lived experience of homelessness and medical abuse in hospital systems.
Thank you.
And I'm Nicole Moran. So I'm autistic and ADHD. I am also a parent of a disabled child, and we're both NDIS participants.
Thank you.
So I would like to start by starting our opening statement.
That would be me.
So
we're going to go to Grace.
As I said, my name is Nicole Moran.
Yeah. Hold on just 1 second, Miss Moran.
Sorry, Nicole. We're just going to introduce Grace first.
Please go ahead.
Yeah, sorry.
I'm Grace Bell. I'm a disabled volunteer with the Protect Our NDIS Alliance. I'm autistic with ADHD and several usually invisible physical disabilities. I was transferred automatically to the NDIS from a community support program in January 2018. Despite several attempts to have my physical disabilities recognised, the NDIS had categorised me solely under unspecified psychosocial disability until I received my formal autism diagnosis in late 2024. I live with my housemate who is also my carer. My disability support needs have factored into the homelessness and ongoing housing insecurity our household has experienced for the last 3 years, which has significantly reduced both of our independence and capacities.
Thank you.
Nicole's just going to finish the introduction and stuff.
Certainly.
Yep. So my name is Nicole Moran, and I must start by acknowledging the empty chair in the room. My child's disability access needs, as well as my own, stopped me from attending in person today. We are both NDIS participants in Littlewina, Tasmania, and unfortunately, with less than 11 hours warning before the hearing started at 9 a.m. today, we learnt that there would be no video conferencing available for speakers presenting evidence, even though it was originally promised. This is in direct conflict with the directions provided in the email to the Alliance that the Alliance has received. Disabled advocates across the country have had to rapidly try to arrange travel from Naarm to Melbourne. But the reality is, for myself, a disabled single parent to a disabled child, it makes this process inaccessible, as for many disabled people in our community. It is not gone unnoticed that our access needs, even specifically recorded in our Hansard witness forms, are being directly ignored when we are being asked to give input into the bill. I am a disability and community inclusion student at university, and this directly conflicts with everything I have been taught.
And I'd like to give our formal opening statement as well. So, yeah. I'd like to start with the NDIS bill must be rejected in full. And before we begin, I also would like to acknowledge the traditional custodians of the land we are meeting on today, the Wurundjeri, Wurrung, Burrung, Bunurong, Bungarong peoples of the Eastern Kulin Nation. We also acknowledge the traditional custodians of the lands I and others, and one of our speakers, Nicole, come from. I come from the Yagara Turrbal, land of the Yagara Turrbal peoples of Meganjin, Mianjin, Brisbane, and Nicole comes from the land of the Palawa peoples in Luita. We pay respect to the elders, past and present. I would also like to acknowledge any First Nations peoples who may be engaging with this hearing, and sovereignty was never ceded and always was, always will be Aboriginal land. I'd also like to pay respects to the history of the disability community. We acknowledge the trauma our community has historically experienced and communities continue to endure. Remembering our past and telling our stories as it is important to try and prevent history being repeated and our experiences being forgotten. I'd like to introduce myself fully and formally as well. I'm Moriella. I'm a proudly disabled Lebanese non-binary lesbian from Meganjin, Mianjin, Brisbane, and I use they, them pronouns. I'm an NDIS participant with high physical disability and psychosocial disability support needs. I'm a full-time power wheelchair user living in supported disability accommodation, supported independent living, and also known as SDA SIL. I need support with all personal cares and activities of daily living, including toileting, showering from daily caregivers. When the government thinks of what a disabled person looks like, they think of someone like me. They think of someone who is in a wheelchair, and that is an equation that we have seen recently within the media. But they don't think of someone like our other speakers, like people with invisible disabilities. Disability is and always has been more than wheelchair users. We are speaking today on behalf of the Protect Our NDIS Alliance, a volunteer grassroots alliance of disabled people and allies from across Australia. We activated thousands of people in every state and territory across Australia who turned out to oppose the cuts to the NDIS with less than 14 days' notice. We obtained endorsements from 60 organisations across Australia who supported our demands. One of those key demands is stop the cuts. Don't put a price on our rights. You can't put a price on our right to exist and our right to dignity. The proposed NDIS bill must be rejected in full. Proceeding with the bill is an irresponsible and dangerous course of action with real risk and harm, including death, which is a guaranteed outcome. Our submission goes into detail about many of the harmful impacts of the bill, and our speakers are happy to take questions and elaborate on that further today. While we have gathered different lived experiences and expertise in our speakers here today, all directly impacted by the bill, one experience that we do not have in the room today is that of a First Nations disabled person. We note that no First Nations disability organisations and no multicultural disability organisations have been invited to give evidence on any of the 3 days of hearings. That is, to me and the Alliance, is unacceptable. We provided a written statement from Jetta Patton, a proud Gunai woman, which we should have handed out to you guys there. There's
yes, we have.
For everyone.
Thank you very much.
Yeah. But to close, I'd like to say again and repeat that the NDIS bill must be rejected in full. Thank you.
Thank you. We'll go to questions now, and we'll go to Senator Steele, John.
Thank you so much, and thank you for your evidence and the work you've taken to be either with us or virtually with us today. The committee is very interested in hearing precisely how we could improve our general processes to hear from disabled people, and I think that's firming up to be a section of its own within the overall report. So thank you for being so clear about what your access needs have been in this process. You've been very clear about your view in terms of the bill and whether it should pass or not, so I don't feel the need to ask you all of that individually. So I'll go straight to what your concerns with the definition of permanence might be. We've seen the agency use the language of cure in communications recently. That was discussed in estimates. What are the concerns that you hold for your communities of the government moving towards a requirement to demonstrate that you have done all things necessary to cure yourself before even being able to think about accessing the NDIS?
Sure. So I have ME/CFS, also known as myalgic encephalomyelitis. I've kind of been a victim of this, trying to get onto the NDIS initially. I spent about $20,000 in lawyers and doctors and everything just to prove I'm disabled enough to get on the NDIS. In the MECFS community, we found through Freedom of Information requests that the NDIS were paying a controversial researcher to help deny people with my disability access to the scheme. And one of our fears with this bill passing is that will also be perpetrated on the community again. Part of my experience with that was I had to prove that I'd tried all reasonable and necessary interventions to get onto the scheme. One of those reasonable and necessary things were an abusive therapy called GET and CBT, where I liken it to a conversion therapy program where I was over-medicated on amphetamines to the point where I was getting the shakes and withdrawal symptoms. I was gaslit and told and blamed for wanting to be sick. I was told I shouldn't connect with community because they wanted to believe and stay sick and they didn't want to get well. And in my kind of experience with the NDIS, even though I had done these abusive programs, they were asking for more evidence that I had done these programs to qualify for the NDIS. So my fear is that we're going to have to redo this and have to go into these abusive therapies, or even worse, that it will be touted as a cure, because it's often touted as a cure, as a foundational support. But, you know, my community has 9 times the risk of suicide. And I've had friends who had supports cut that have attempted that. So it does have a real human cost.
Nicole would like to add something as well.
Yes, please, Nicole, go ahead.
Yes, so when I was originally seeking access to the NDIS, I knew that I needed access and that I needed support. However, I didn't know exactly what that was for. I had a childhood diagnosis of ADHD, and I had tried medication as a child and then grown up and been told several years later that I had apparently grown out of my diagnosis, even though we now know that that is not actually possible. So for me personally, what happened was that me being able to access support looked like me asking for support, being denied access and told that I had to go and get a new diagnosis, only to be rejected and be told that I had to trial medication, even though I had done that as a child. And then even once I went back to the agency with that proof that I had trialed medication, I was given access for an autism diagnosis, but not also for an ADHD diagnosis. This is quite significant when 20% roughly of people with ADHD do not respond well to the first medication that they try. And for me personally, medication is not an appropriate option because my body doesn't respond positively to it. So it massively extends how long people go without support, which then puts people at significant risk.
I'd also like to add quickly as well, my concerns also sit with the with trialling all sorts of treatments to gain access to the NDIS is restrictive practices in place in terms of especially chemical restraints. We have seen that a lot in myself as who does do peer work and does do lived and living experience work and has done stuff with the Queensland Mental Health Commission. We have seen a lot of people actually go through treatment authorities and things that may not actually be beneficial, and they may actually need that community-based support through the NDIS, and then there is no other system that they can actually fall back onto to actually receive adequate support as well. So then they are forced to undergo chemical restraints and medications and treatments that are harmful and may not be beneficial to them.
Thank you. Now, a lot of the bill has quite vague language in it, but there are areas where it gets very specific. And one of the areas where it gets really specific is the sections that mean the government does not care, it's not relevant to the government whether a treatment is financially accessible to you, appropriate for your context, or available in your geographic location. These are not factors that they take account of in the legislation. What are your concerns about this approach?
Nicole can speak in terms of geographical location, 100%.
I was just popping a message to Brodie to say, so I grew up on the northwest coast of Burnie, which is, depending on the model that you use, it's either classed as rural or regional, and it's a known service desert. So the supports that I received as a child that was identified with developmental differences prior to the NDIS was that I got support to see a paediatrician, and that was it. So we have these massive gaps of service deserts, and that even includes in the Greater Hobart area. So I had surgery in December late last year, and it took approximately 2 months for me to be able to receive supports at home after my surgery, which included basic supports like having assistance with showering through the public system. So it has a really great, huge impact, because often there aren't services available. And I mean, even diagnostically, I am unable to receive a diagnosis for one of my disabilities in Tasmania.
Will anyone else to add to that?
Yep. So I'm someone who has quite complex presentation where the intersection of my my neurodivergence and my physical conditions mean that it's actually quite difficult to communicate my experience verbally. I've had doctors not believe when I describe my experience. I've had practitioners to my face say one thing and then write notes to that recommending further care that say something completely different, and that doesn't match up with what's actually recommended. It took a lot of years to build a relationship.
In a teleconference, and they're just going to say my name. So we may as well call this number from the computer if that's possible.
We've got some feedback from Nicole.
Sorry.
That's all right, just continue.
Sorry, I can't process and think at the same time. So you have quite a limited amount of time in doctor's appointments that you have. You have to really be able to focus. You have to have the support in order to try all the different supports. And when you get there, you might get an answer that is, oh yes, well actually we have people who are specialised in this, but they do not know how to work with a neurodivergent person, so you cannot access this support, this service. You cannot access this treatment without not being able to fully engage. Sorry, I'd lost the middle of that thought.
No, that's okay.
Sorry, I'm just double checking through the captions. So I've had, one of my practitioners recommended a whole bunch of really sensible treatment and then medically retired. They are the only person in Victoria who was able to even diagnose me correctly because they had that experience with the intersection. And so it took quite a number of years for my medical team to actually build up the rapport and understanding of how I exist as a person, and be able to then correlate that with how the DSM is written so that I could get a formal diagnosis instead of the informal diagnosis we've been all working under the assumption that it was quite obvious to everybody. But under rules like what's being proposed is even though I have pages of lists of things I've tried and engaged with, all it would take would be one doctor who wasn't up to date on the literature for that to make me ineligible.
And the government has also announced a 50% cut to the social and community participation funding that people are able to access under their plans. It will happen regardless of your individual circumstances. It will be an across-the-board cut. Now, what do you believe the consequences of this funding cut will be? And as you answer, I wonder whether you could assist us by talking about, if you are participants with this funding in your plans, the ways in which it supports you to go beyond the home. Because although I very much understand the way in which plans are used flexibly and that this delineation actually doesn't exist in practice, what we're hearing from the government is, don't worry about showers and those kind of things. We'll ring fence that, but they are very clear about it impacting activities beyond the home. So if you could go to that, that would help us understand that aspect.
Yeah, I can take this one. So I'm someone with very high support needs physically. I'm someone that is a hoist transfer and requires 2 assists of caregivers daily. If I'm without ADL funding, which is activities of daily living, and if I'm without community access funding, I can't leave the house, nor can I actually access the ability to have a shower. And that is a vital way that I need to exist and live my life as a disabled person. I would perish. I would cease to exist. And many participants are in the same position. And that extension towards community access and participation funding is, I utilise that funding to be able to go grocery shopping, to be able to be here with you today, to be able to do doctor's appointments and basic medical admin that come in conjunction with being disabled physically. And there are a lot of complications that come with myself having a high level of physical disability. I'm someone who has a full-time catheter. So it's like I need management, I need adequate support, and to be able to get to those appointments physically in person, be assessed by the medical team and be serviced properly by the public health sector, I need to access supports through the NDIS to do that. Without that, I can't exist. I would end up in hospital. I, in 2024, spent 5 months in hospital awaiting the access to the NDIS for my physical disabilities. Prior to that, I was funded for psychosocial disabilities and funded for my autism. And we met, we hit a wall with the hospital liaisons that work directly in the health care system with the hospital treating team. And the issue that I faced was there was such a lack of understanding in how my funding within the hospital system of how funding is actually utilised. And there was an expectation of just go home and just go and use your funding in this way. I didn't have the funding adequately as someone who was funded only for psychosocial at that point to be able to be discharged safely and adequately. So we waited 5 months, and that at the time I was a manual wheelchair user. I needed someone to be able to propel me and push me around and get around safely. And I was not able to do that safely. And I had so many falls with not having the right AT and the right equipment. But the only way for me to be able to get out of the house at that time as someone who can't propel a wheelchair themselves was to utilise social and community participation funding, which is a vital part for so many of our lives. I think Nicole would love to add on to this one as well.
Yep, go for it, Nicole.
Yeah. So I would love to add on from the perspective of being a parent of a disabled child, because there are times where neither of us would be able to get the supports that we need without that funding. So there are times where my son might have a medical appointment, for instance, that I need to take him to. However, because of my disability, I find that to be a really stressful and high intensive environment, and it's not safe or appropriate for me to be able to drive. The way that I maintain being able to drive is knowing when it's safe for me to drive. So it doesn't just have an impact on the individual participant when it comes to disabled parents, it also has an impact on the child as well, to ensure that they're able to get their needs met. It means that we're able to go and essentially participate in normal things that everybody else generally takes for granted, like having somebody, if I'm overwhelmed, be able to pick up groceries.
Fantastic, thank you.
Sorry, I'll just add to this. I'm actually using my community participation today, and a lot of people on the NDIS, they aren't adequately funded for their disability, so sometimes they'll use that community and participation funding to kind of help with their disability and extend that funding and support further.
Do you ever use it flexibly as they're allowed to, and in fact encouraged to by the agency?
Yes.
Yep. And
to be very clear.
Yes, and I'm worried that the removal of this will mean we see less disabled people out and about in the community because we just don't have the funding there. And in a place where Victoria, where transport's accessible transport's still being delayed by more than 10 years or something with the last report, a lot of people will use that community funding to get to their appointments and stuff. Or that might be their only accessible way of getting to places like this today.
Yeah, thank you. That'll do me, Chair, and I'll pass over to my colleague.
We'll go to Senator Askew.
I just have two questions, if that's right. I'm conscious of time. So thank you for evidence and coming along today. I know it's been a big effort to get here. I just want to ask, first of all, do you accept that the NDIS requires reform to remain financially sustainable? And if so, what alternative measures would you propose to control costs?
So in the bill in its current form, we of the Protect Our NDIS Alliance believe that it must be rejected in full. In our submission, we have stated if the bill is not rejected in full, amendments, and we can take that on notice of if that is directly in our submission, but we can take that on notice and further answer that one a bit more directly. But in regards to sorry, could you repeat the question?
That was about the reform to remain.
Yeah,
I have got another part you might want to take on notice as well.
Yeah.
So do you want me to give you that?
Well, I do believe that there should be reform for sustainability of the NDIS, but reform should not be rushed, and reform should not come without collaborative co-design from disabled people. We are the ones at the brunt, facing the brunt and the forefront of these cuts, and then also as well, there needs to be a high consideration of the allied health professionals in this sector that are going to lose jobs. We are going to lose so many skilled support workers that are valuable to our daily living, that are valuable to our lives, and are valuable to keep the scheme running. If those support workers lose hours, lose jobs, lose participants, we're not going to have a functioning scheme in the first place. How are we going to reform a scheme that isn't functioning already? And it needs reform. The disability community has been asking for that for years, but we can't do that without us in the room, without us in the picture, and without us speaking to the people directly in charge of this. So.
No, that's fair enough. The other one part of it was what amendments would you make to the bill to strengthen participant protections? No, sorry.
No, just excuse me. Sorry. From the previous part of the question. So the bill is not accurate. So the current research says that that $2.25 worth of value is created for every dollar spent on the NDIS. That is keeping the economy afloat. That is valuable. That is real. Like it's not unsustainable. It's only unsustainable if you're looking at things in very isolated blinders on buckets of funding. Where when we look at the whole system, if you take away NDIS support, as this was the original intent of the scheme, in fact, is to overall reduce costs by intervening early, and this is backed up by research, by data. This is not something that you can just magic away. Like, disability needs don't go away. It is so expensive to have people in the hospital, to have people with inappropriate levels of support who then will need further care and will deteriorate, potentially needing further intervention. It's expensive for carers. You're burning through your formal and informal workforce by forcing them to do jobs that they were never trained or supposed to do or should have to do, while also putting participants in danger.
Yeah, Nicole's just going to quickly add on something there.
Yep. So if we actually look at the original intention of the scheme and how it was designed, the NDIS was intentionally designed as an insurance scheme on the basis of providing support up front as well as early intervention, which was specifically designed into the scheme to ensure the long-term sustainability. And so with that, it looked at different approaches, such as in Tasmania, we've got the Motor Accident Insurance Board, which everybody pays into when they pay their registration. And then there's a pool of money, essentially, that provides that support. So the thing about ensuring that we provide appropriate and reasonable necessary support as per the current legislation that is already in place is about reducing the long-term costs. And because the NDIS is the first of its kind in the world, we haven't actually seen the outcomes of that from research fully yet. And we actually know that from research that by providing, hang on, give me just 1 second, I'll pull up this thing because I've got it written down.
Andrew, just going to finish the answer to that question, we'll come back to
Right here. So we actually know from evidence-based research from both Australia and internationally that support self-directed individualised funding packages such as the NDIS. These study findings show better outcomes in comparison to block-funded services for disabled people when certain criteria conditions are met, such as those that Australia has used in the past and continues to use for some state-funded services. Evidence-based research shows we require individualised and adequate funding, information and support to make informed decisions, as well as creative support, welcoming communities and appropriate services to meet our individual needs. So it's not just disabled people saying that this is stuff that we need. It's stuff that is based around the research, and the research very clearly states that it is integral to the NDIS and to services as a whole that we provide adequate services in the beginning, because it safeguards people. People are in the community, visible, people are more connected to notice when something goes wrong. And then on top of that, by properly funding the NDIS to begin with, it reduces the long-term costs. So when we remove funding from the NDIS, it substantially increases and shifts onto other services such as hospital, justice system, removal of children from their families. There's so many different and varied areas.
Thank you. Okay. Sorry, I think
I can answer the second part of your question. So we don't actually get access to the money from the plans. It's the providers that get access to that. If the bill is looking to crack down on providers and frauds and rorts, it should be focusing on that and not cutting participants' plans.
We should not be directly impacted by these cuts in our plans and the way that we access the community, the way that we live our lives and are supported. This is not something that should be, like, if fraud is about 2% from what I'm on recollection, and that is from recollection in line with Medicare, in line with other government services. So yeah, this is the biggest cuts to any social service in the country ever. So why is this being targeted at such a vulnerable group of people that many of us are privileged to be able to stand here and sit with you today and speak as a disabled person, but many participants may not have the ability to do that.
Thank you.
And like I brought the MECFS thing up before, they spent over $100,000 consulting a practitioner that our community says is harmful. Maybe make some cuts there.
All right,
Thank you. Thank you so much for joining us and for taking the time to share your experiences and your perspectives. It's really, really valuable. So thank you so much. Can I ask whoever's filming up the back to please stop? It's not appropriate to take photos or film in this room without permission. There are people who may not wish to be captured on whatever it is that you're doing. So please, 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 to everybody, please check, please ask.
If there are any further questions that would like to be answered from anyone here, we're happy to take them on notice and happy to answer them.
Thank you so much.
Thank you.
Really appreciate it.
Thank you all for your time. Thank you. And to clarify, folks, you can take pictures if you've asked us and we've said okay. That's okay. You just got to ask us first. That's all right.
There are a lot of people in the room and not everybody necessarily feels comfortable. So we need to respect everybody's perspectives here. I do appreciate that people want to capture certain things and we're not trying to stop that, but we do need to respect everybody in the room. Thank you. So I would now ask the representatives from Disabled People Against the Cuts to start making their way towards the front of the room. Oh, okay.
Sorry.
Oh, good, all good. Welcome. Thank you very much for coming along. Now, I do believe you've been provided with information about parliamentary privilege and rights and protections of witnesses.
That's correct.
Excellent. Glad to hear it. If you would like to introduce yourselves, your name, the capacity in which you're appearing, and provide any opening statement, that would be great.
Right.
I'll leave it to you guys to direct with amongst yourselves as to who goes where.
Excellent. All right. My name is Stevie Langhausen, and I'm appearing here today for Disabled People Against Cuts. Disabled People Against Cuts is a grassroots campaign network by and for disabled people. We oppose cuts and punitive reforms to the NDIS and to other disability support systems. We support individualised support for disabled people, independent living, and the attainment of our rights under the United Nations Convention on the Rights of Persons with Disabilities. Disabled People Against Cuts have been campaigning nationally against the cuts to the NDIS. We have supported disabled people and their families to take action right across Australia, from Toowoomba to Melbourne, from Sydney right through rural and regional Australia to Perth, over 12 days of action in the lead up to the federal budget. Today, Disabled People Against Cuts is represented by Samantha Connor AM, by Peter Gregory, who is online, and by Marika Jonkers, who is also online, and myself, Stevie Langhausen. We're here today, fresh from a community forum where 150 disabled people got together to share their fears and what they are concerned about in relation to this bill. What we're going to share with you today is drawn directly from those experiences. I want to stress that our community is united and unequivocal in their opposition to this bill. The NDIS is an investment in all Australians. It is a promise to every single person in this room that if any one of us has or requires a significant and permanent disability, that we will continue to be able to live our lives and access the support we need to have good, ordinary lives. This bill breaks that promise, and that is what our community wants to communicate to all of you today. This bill, there are a lot of ways that the NDIS could be made stronger or fairer, but this bill proposes a very specific strategy for cost cutting. They're going to limit our supports based on an arbitrary way of framing our disabilities and cutting us up into little pie graphs and trying to decide which part of, our impairment is caused by which thing in what could end up being endless contests about what causes what. They're going to start defining our functional capacity, not by looking at what we actually want to do, but by trying to imagine what we could do potentially, based on not actually looking at the circumstances we find ourselves in. We're going to find funding being set based on how much government wants to spend rather than what people actually need. And we're going to see wholesale cuts to the supports that disabled people need to live ordinary lives. I'm now going to pass to Sam, who's going to summarise what came out of the forum last night and what our community's specific concerns with this bill are.
And then I'll throw over to Peter and then Marika. Thank you so much for having us today. The people who spoke last night...
I'm sorry, if you would just place on the Hansard record your name and the capacity in which you appear, that would be really helpful.
So Samantha Connor, I'm appearing on behalf of Disabled People Against Cuts and also belong to a number of other groups for disabled people. And I'm a very old disability rights activist. So the people who spoke last night were very, the same things that have come out in your 4,500 submissions we hear. Good luck reading them. It sounds like fun. The same messages, exactly as Stevie said, people were absolutely against these changes and cuts. They said that it was regression and not progress. It was unwinding decades of hard-won independence, employment, community connection and health stability. There was carer burnout cited and family collapse, divorces, ageing and exhausted parents already at their limits, unable to absorb further cuts to formal support. There were people who had been rendered homeless by the cuts and also talked about institutionalisation. They said that these changes were a direct downstream risk and that there were forced returns to group home settings, especially with rules like 1 to 3 supports. People talked about suicide and mental health crises as a direct and foreseeable consequence of losing supports. And participants and carers who work, pay tax and reduce government costs in other systems would lose that capacity with their economic contribution erased. That's aside from the 204,000 workers in the disability sector who are proposed to lose their jobs with the cuts to the NDIS. The decisions that are made without us, there are people already seeing plans being changed without notice, assessors with no knowledge of disability making life-altering decisions, domestic violence and family safety. The removal of community access increases risk for people in coercive control situations. This is a very gendered issue, and reduces DFE exit pathways. And a broken NDIS administration. Reports aren't read, ART orders are ignored, there's AI decision-making, unqualified staff. People can't believe that there's a plan to remove people from the NDIS if they're not able to be contacted. Ask any blind participant who has received a letter or any deaf person who's received a phone call. It happens every week. And last but not least, there's the algorithms and the black box that is being proposed by harmonising the disability, aged care and veterans sector. It turns disabled people into a monitored test population for algorithms, punitive debt traps and permanent surveillance. If you can imagine getting a Medicare service and somebody saying you need to keep your receipt, and if you lose it, then you'll have to pay back that service. That's essentially what is being proposed for disabled people. There's no appeal. Tribunals can't properly override it. There's robo-debt Royal Commission recommendations that are being ignored, and there's a whole bunch of different changes around pushing people back into block-funded, one-size-fits-all services and wrapped all up in a digital ID system and payment system that tracks every purchase and can block spending in real time. These are horrifying dystopian measures that should never be introduced to any Australian, let alone the most vulnerable in our community. I'll pass over to Peter Gregory.
Good afternoon, Senators. My name's Peter Gregory, and I appear as a contributor to Disabled People Against Cuts and also the co-author of a 380-page submission with my colleague, Mr. Daniel Flynn. I spend the vast majority of my life with people regarded as having very complex support needs who require 24/7 one-on-one support. I've spent many, many hours, thousands of hours over the past 50 plus years exploring with these people and their families what it takes to ensure they have access to the same opportunities and experiences as those enjoyed by their fellow citizens. These are the opportunities, the very opportunities enshrined in the UN CRPD. In our submission, Daniel and I outlined the history of disability care and support legislation and service delivery in Australia and the historical conditions that ultimately led to the need for the Productivity Commission report that, of course, was the pathway to the NDIS. The Disability Royal Commission also identified how these conditions led to exploitation, abuse and neglect and violence towards disabled people. Our submission analysed the current amendments to the legislation and clearly demonstrated that these amendments will create, not may, but will create the same conditions that led to the necessity of establishing the Royal Productivity Commission in the first place. Last night, when we met with members of our community, these fears of a return to an institutional past for people with very complex needs in receipt of home and living supports were articulated strongly and clearly, including a fear of a return to institutional and congregate care, loss of individualised and person-centred support, fear of physical harm, medical neglect and death, emotional trauma, distress and loss of identity, loss of community participation and ordinary life, concentration of power with the NDIA and the Minister, loss of review rights and legal protections, distrust of large provider-controlled systems, and exhaustion, grief, and the burden of lifelong advocacy. And finally, the members of our community reinforce that this is their lived experience on a day-by-day basis now. These amendments are already in practice. Thank you. Maraiki, over to you.
Can someone unmute me?
You're not on mute.
We can hear you, Marika.
Senators, my name is Maraiki Yonkers. I am Australia's first ever female para-triathlete, a three-time Paralympian in the sport of swimming, former president of PWDA, and a co-author of the submission you would have received from an organisation called Sporting Dreams. Today I'm here to address you on the topic of social and community participation and integrally linked percentage cuts to therapy funding and mandatory registration of providers who give personal support, because that occurs in the community, not just at home. But I'd like to address the situation of how this Senate inquiry has been conducted, to use it as a case study of social and community participation not quite being accessible for people yet. The intention today was to participate via WebEx. I am currently sitting here with a ring light, wearing a t-shirt that says Defend Our NDIS. I'm not in the room with you today because even though we found out this was being turned into a teleconference at 11 p.m, my support workers scrambled to start packing a suitcase and drop their lives to bring me to Melbourne, but the only aeroplane big enough to fit my powered wheelchair, which I use, was going to land in half an hour's time. With wait. Well, that's my story, because the fact that people today cannot understand, because there's not a interpreter for the DPAC forum, and that we don't have the opportunity for people like myself, who are supposed to be at the heart of the NDIS, to be there, shows what the Royal Commission told us, that there is a roadmap for building an accessible, inclusive society for people to be part of. But when we haven't implemented that yet, cutting people's funds for having help to navigate the inaccessible world doesn't work. And that matters, because we are cutting those by 50% for participating in the community, which is a fancy word for leaving the house. Most of you did that today. And the other parts of cutting therapy and support registrations, these are only the figures now. They could change. This noise, I hope you can hear banging, is a gold medal. It's mine. When you celebrate one of these won by a Paralympian, you're not just celebrating that Paralympian. Kurt Fernley, Dylan Alcott. I don't expect you to all be old enough to remember me. My point is, you're not just celebrating us. We got there because of having the equipment and the support to join sport at a grassroots level and be there in the first place. So when you cut our social and community participation, so we can't join the local sporting club, a kid cannot go to music lessons and perform with their local band, the adult who's newly injured can't get their peer support by being part of their community, guess what you're also doing? Bang, 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 bang. You are cutting the medal count of Australia at the 2032 home games. I can't see a more blatant hypocrisy in the budget than throwing money at Australia's performance in the next Paralympic Games while cutting away the grassroots level that allow those Paralympians to actually stay alive. Because we're not performing monkeys outside of sport. We need to eat, have assistance to go to the toilet, accessible living environments, study, and to be part of our community too. Community participation isn't just about sport, of course, because it lets us to work, pay taxes, make friends, avoid isolation. And personal care, it's still required, whether in the house or we are out in the community. So it's actually costing the same. What we're not measuring here is the outcome. And that outcome is the difference between people telling us in our forums an existence or a life for the exact same amount of money. The bill is also cutting therapy, yet therapy is often what reduces long-term costs, things like physio, psychology, occupational therapy. With someone having the right correctly fitted prosthetic or wheelchair, for example, they could maintain or increase their independence. But with cuts by percentages that could increase to that area, suddenly you find people rationing it to the bare minimum to survive, as opposed to using those funds to trial new equipment or types of support and modalities that can increase independence and improve community participation.
Thanks so much, Meraki. I think we need to move to questions now.
I have a question for the Senate to Vinit Stevie.
Okay, do it.
In summary, what economic modelling demonstrates that reducing community participation and therapy support actually saves the NDIS money in the long term? Thank you.
Thank you very much. I think, as we've said throughout the day, there's a range of assertions and there's a range of perspectives and there's a range of areas where we don't yet have the facts. Thank you for your question. We will put that we'll be putting the questions that we develop over these few days to the various structures and departments that can help us better understand the finer detail. So we will go to questions. Thank you so much for your contributions so far, and we'll go to Senator Steele, John.
Thank you all so much. I really want to recognise the effort that you've all put in to either be here with us online or to join via teleconference. And I said to the last group of witnesses, your feedback on how this process could be improved to actually meet people's access need is greatly welcomed. And I'll be very surprised if it's not a section of reflection of the report, because it sounds like we need to invest in other technologies and processes to do better. We are running a little bit behind time at this point, so I'm going to limit myself to 2 questions in areas that you've mentioned in your opening statements, but we haven't kind of covered them earlier in the day. So first of all, this bill allows for the creation of plans and decisions around the allocation of funding to be made through computer automated processes. What these explicitly processes without the need for human decision making. What are your concerns about the risks of that approach?
You might have noticed that the aged care the group is currently with the Ombudsman for exactly the same thing. You know, they started a little bit earlier in 2024, I think, and they noticed that consistently the amount that came out of the magical black box, as we call it, was less than it usually is for people's funding and care and support. So where people might be getting 3 or 4 showers a week, you know, they all talk about showers, now it's 1 or 2. So the black box idea is that people will be put into little categories. It will no longer be based on their goals, it's based just on their impairments, and the Administrative Review Tribunal's power to directly vary plans is removed, so it just refers you back to the NDIS for reassessment. There's a whole bunch of changes. The unspent funds aren't carried over when the plans end scheduled reassessment dates. There's support determinations where they can just ad hoc reduce funding for groups of supports with ministerial instruments. And I did notice you're talking about co-payments. It is implicitly written into this bill that co-payments could be introduced. It gives the Minister extraordinary powers to change the lives of people with disability for the worst. And when you look at automated decision making across the world and you look at the laws that protect people, not just people with disability, we don't have those laws to protect our privacy, to protect our lives. So it's a really big concern.
And my final, would anybody else like to jump in on that, Mr. Gregory or
Yes.
Ms. Johnson?
Yes, Senator Peter Gregory here. I'd like to respond and expand on what Sam had to say. There was indeed a time when I too believed that with my bright, shiny occupational therapy degree in the early 80s, that simply conducting a standardised assessment would lead me to understand comprehensively the support needs of individuals, only to find, to my severe embarrassment, that there was no alternative to sitting with the people, understanding the circumstances that they find themselves in, and together and collaboratively co-designing the solution, utilising some standardised assessments, but categorising, exploring, nuancing those with deep insight into the circumstances that people find themselves in, and then as a consequence of that, designing together what is the optimal service that would deliver on superior community-based self-directed supports for them. So, Senator, I categorically say under no circumstances will you get outcomes that are person-centred and individualised through some sort of black box individual needs assessment.
Thank you.
Senator, can I just add one thing? This is Stevie Langhausen again. I just want to really quickly say that any kind of automated decision-making tool relies on the data that is being fed into that tool. I encourage all of you senators, even if you support this bill, please ask the witnesses that are going to come here and anyone else you can, ask them about the integrity of the NDIA's data. Because the integrity of their data has massive problems. And even if you back every single thing that's in this bill, theoretically, the actual execution of these automated decisions is going to rely on a data system that does all kinds of interesting things, that lists people's disabilities as things that they don't have, that puts their disability in the name field, that sends letters to blind people, that forgets, what people's communication preferences are. And if that is what we are building an automated decision-making process on top of, there is enormous potential for harm.
Thank you. I'll leave it there, Chair, just in the interest of time.
I'll just ask one question, just as a follow-up to that in particular, actually. You actually mentioned in your opening statement, I think, about there was stronger and fairer ways to improve the NDIA. So have you, obviously, if you set aside the bill, you stated quite openly that you opposed the bill. What are the stronger and fairer ways that you would
what I said was...
We've just given it. It was the Disability Care and Support Productivity Commission Inquiries Report, 1 and 2. Mr Les Cope has hung on to it since 2011, which is remarkable. All of the costing is in there. I remember Patricia Walsh and the other productivity commissioners who put it together and did all the costings at the time, and there were big chunks left out. There's a blueprint that's here that was supposed to be filled out, and the scheme was sabotaged and narrowed. And did you have any more ideas, Stevie?
Yeah, I think what I would say is that we're not going to be able to get the NDIS on track or sustainable for future generations or any of the potentially laudable goals that a government might have if the administration of the scheme is fundamentally faulty. And that is the situation that we find ourselves in. The way that the scheme is actually being run on a day-to-day basis is producing harm. And it's not just producing harm, it's producing absurd outcomes. I mean, I've presented to some of the people in this room before talking about my own experience at the Administrative Review Tribunal when I applied to the NDIS, because of this whole situation. I'm gesturing to the wheelchair. I was given speech therapy and behaviour support, probably as a result of an automated decision. So there's a lot of stuff going on in relation to the actual running of the scheme that could deliver enormous, not only benefits to disabled people, but enormous benefits in terms of sustainability, people getting the right support without having to go through long appeals or, you know, a bunch of, you know, 60-page reports, you know. There's so many things that could just be addressed in that area alone. And I think that until that level of the administration of the scheme is made functional, then any reform is just going to be papering over those cracks and delivering outcomes that are ultimately, if you're the government, if you're the treasurer sitting there and you're saying, I want to achieve this goal, you're not going to get the goal. Because the way that the goal has to be executed is through a system that is not working and that is not producing the outcomes that it is meant to produce.
Thanks. Ms. Collins, just one thing. The issue of co-payment has been raised a few times. I've sought some assurances about what that actually means, and I can't find... There's a reference in the EM. Would you be able to provide that for me, just to help me unpack that?
I'm really happy to provide a supplementary, because we've got so much data now.
Yeah.
But that in particular, I'm really happy to, because there's a...
Because I can't find it.
Oh,
and I've looked and I've sought assurances because, you know, it is obviously a concern that people have raised, but I just thought you sounded very specific. So I thought, oh, I might just take advantage and get you to provide me what you've seen to help me out. That would be really, really useful.
No problem.
Just on a fundamental level, one of the key things that the bill does do is it takes away the idea that if a support is reasonable and necessary, it needs to be funded in full. That's what the current NDIS law says. Now they're going to be able to effectively determine that they're going to provide funding at a level that does not cover the full cost of that support. So where does the full cost...
I think we need some clarification on that.
There is already, I mean, you could ask some questions.
Provide it on
Well, you could also ask some questions of equipment providers, for example, probably not Martin Laverty, but, you know, actual equipment providers. And you know, they've already capped equipment. So this wheelchair, for example, which is one from Melbourne, actually, which I've had for probably too long because it's falling apart, was $16,000. It's no longer funded because, you know, it's now a cap of $15,000 on manual wheelchairs. And we're now looking at going to block funding for all equipment providers. Stevie and I are both using a Bartek today, which are these little things that you can fold up to the size of a piece of origami and put in the back of a car. If you don't have a dirty great wheelchair van that costs, you know, $90,000, which the NDIS has never funded, by the way, you know, it's a lot easier just to be able to hop into a taxi and you don't have to, you know, Marika can't get into an aeroplane because of the size of her wheelchair. And so there's those sorts of things where choice and control, which was the original mantra of the NDIS, is so important. We're able to save money, you know, by having choice, having control, and making sure that we've got reasonable and necessary supports.
But if you had your chair now, if you went for your chair now, and it was over $16,000, you would, and that was the chair that you needed and was medically necessary for you. You would be looking at a gap payment of about $1,500 between the $15,000 that you
That's
can
your
get
co-payment.
as the cap. That's your co-payment is that amount on top.
And there's also potential for a support determination to be made in relation to equipment, for example. So if they could, for example, say that for a custom wheelchair, you're no longer going to have the full cost of that provided by the NDIS, the minister could say we're going to cut those budgets to 80%. So in the same way as community participation is going to be cut to 50% of what's funded, they could say for your custom wheelchair, it's now only going to be funded at 80%, at 50%, at whatever.
Or perhaps ABA therapy. You might be making choices about how much therapy your autistic children, you know, some people are very fond of ABA therapy, which is very expensive and very time-consuming during a week, that, you know, that costs a lot of money. If they only funded 50% of that because the minister's made a decision, then, you know, it's now a lifestyle
I get the
choice.
anxiety. It's very speculative because equally the way it's written, the minister could decide in completely the other direction. So I think that's where we need the clarity.
I think it would be speculative if he hadn't already cut 50% of social and community budgets.
But but I guess what I'm particularly mindful of as we're going through this process and we're trying to build where are the key anxieties and concerns, and how do we get the level of detail that's required to genuinely understand them, understand where there may be things that are highly problematic, or understand where the fears are not brought to bear, and that we can get the kind of detail we need to understand that. And I think that's the balance that I'm trying to look at here, so that we can understand, where the challenges may be and where the challenges are not, because I'm very cautious about spreading an awful lot of fear before we unpack it.
I guess what I'd say to that, and I totally understand, and we take really seriously that we don't want to be encouraging anyone to be worried about anything that they don't need to be. But what this bill does do is this support determination power, the Section 50 support determination powers, allows any minister to reduce any category of support by any percentage up to 99.9%. Now,
would never do
that is any
we might wrap it there.
Yeah.
And roll our aspersions out in another forum.
It's my political bias.
Is it possible for me just to make a final comment before we wrap?
Yes.
Yes. Go ahead.
Yep. Obviously, from what I've said, I'm a strong advocate for very personalised and individualised service design. As far as I'm concerned, we have now decades of practice history about how to sit and collaboratively design supports around people with complex needs that deliver on superior outcomes at a lower cost than the same services being delivered in traditional ways. As a consequence of that, the opportunities that we have missed are that we have also had now 15 years of determinations to decisions within the ART about what are reasonable and necessary supports. So if we were able to aggregate that information, we would get a very clear picture of what should be in scope, what should be out of scope, and what is marginal depending on people's circumstances. But I put before the committee that unless we can move away from the thinking that responses are standardised to thinking that we need to engage with people with disabilities on an individualised and personalised basis, we will not ever reach that point where people are experiencing full citizenship. My final comment would be these fears are not unfounded. Around Australia today, people are in receipt of letters that are telling them that their funding is being cut and that it has been determined by the NDIA that their supports will now be based on 1 to 3 shared support, and they've got 6 months to change their living arrangements.
So they have to go
and that simply is not the promise that was given to our disability community.
Thank you. I'd like to thank you all for sharing your experiences, for bringing your expertise. We do need to move.
There was a question about ways to improve the NDIS. We've had a lot of forums, and it would appear that the majority of issues that we hear about, and I believe MPs are hearing about in their offices and senators, aren't coming from a legislation level. They've got to do with what Stevie was mentioning, things like getting calls from a block number, or having to call a 1-800 number back to find out what that person wanted. But the 1-800 number doesn't have the authority to do something. A decision being triple-handed by a lack, then it goes to somebody else, and that person isn't a delegate to make a plan for over $100,000, so a third person is triple-handling it. And then if there's a cut and paste error in that plan, the only way you can make a change to it is you have to go to court, and you've got legal expenses added in. So it would seem, from having listened to so many stories, that if we ran the NDIS under legislation that already exists efficiently and appropriately before we made more changes, because this sector is getting slammed with so many changes, it's hard to keep up with at breakneck speed, we may well find a lot of cost savings for better outcomes, with less stress for people like yourselves listening to the stories and the participants living through it. If this was a business, we would not be meeting our KPIs in outcomes or being a productive, efficient way to run a system. So I guess we might look for a different way. That's all I have to say. Thank you.
Thank you very much. We really are going to have to wrap this session now. Thank you so much. We really appreciate your time and your effort and your expertise and coming and sharing with us today. Thank you so much.
Thank you.
Now, just for the elements you said you'd come back to us with, the alarming time frame for you would be ideally by 15 minutes would be great. By Friday would be, on Friday would be lovely. Thank you so.
In the room. We're very fast.
Very focused. Thank you so much. Upsides, right? I would now like to welcome representatives from Down Syndrome Australia to come forward. Yeah, no rush. Don't take your time. Can I have a go? Okay. Welcome. Thank you very much for appearing before the committee today. Can I just confirm that you have received the information on parliamentary privilege and the protection and obligations of witnesses?
Absolutely. Yep.
Excellent. Glad to hear it. If you would like to state your full name, the capacity in which you're appearing, and then provide any opening statement that you may have, that would be lovely.
No problem. Thank you very much. My name's Darryl Steff. I'm the CEO of Down Syndrome Australia. And thank you, Chair and Committee, for the opportunity to appear here today. As a disability representative organisation, we represent people with chromosomal variations, including Down syndrome. That's people who have lifelong and permanent disabilities, the exact people the NDIS was designed to support. So it is very concerning to see the impact of this proposed legislation would have on these communities. We don't support the legislation in its current form, but it's not that we don't support reform, it's about doing that reform properly. One of our fundamental concerns is that this legislation prioritises financial sustainability, but at the expense of safety and rights of participants. For example, if the legislation is passed, the Minister will have the power to reduce or cap funding across entire support categories or entire cohorts of participants at levels below what is deemed reasonable and necessary. Powers like these need strong safeguards and appropriate review rights, but they don't currently exist in the legislation. So for people in our community, the support determinations that allow for cuts to social, economic and community participation supports are a particularly stark example, and I'll focus here briefly. The impact statement that accompanied the legislation suggests that this area was chosen because it would not affect the health and safety of participants. We don't agree with that statement. This funding is at the core of what the NDIS is for so many participants. The funding is essential to employment and to the day-to-day supports that help people stay safe, connected and well. The impact of reducing this funding is significant, with community members telling us the impacts on mental health, social isolation and having to choose between attending work or taking care of their own health and fitness. I want to briefly give you a few real-life examples. We've heard from a 13-year-old who uses the funding to play mainstream hockey. She's supported to train and to play competitive games, and she belongs as part of her local hockey community. A 15-year-old who uses the funding to attend a Friday night social group. This is his only connection outside of his immediate family. This group has increased his independence, confidence and social skills. A 21-year-old who uses the funding to increase her independence from her parents by doing shopping, attending appointments, travel training and catching up with friends. A lady who uses the funding to be supported to travel to her paid employment where she earns full wages in open employment in a job that she loves. A 26-year-old who uses the funding to attend both the day program and supported employment for his well-being and mental health, building his work and life skills, building his social skills and friendships. And we've heard from many people who say, well, hold on, I've just been through a plan review and I've had a 50% cut. Surely these cuts won't apply to me. And they will, which just goes to show the inequity of applying across the board cuts without the consideration of personal circumstances. The other thing I'd note is that support needs don't disappear just because they're no longer funded. Participants and families will bear the brunt of these cuts at a significant cost to their own well-being, their economic participation and to the broader economy. And then when there's no family to absorb that pressure, the risks to the person are even greater. The Disability Royal Commission emphasised the strong connection between low participation in the community and an increased risk of harm. This cannot be ignored in the pursuit of sustainability. So let me be clear, we do support reasonable reform to improve the NDIS. You've heard many cases today that the NDIS is currently imperfect. But the changes in this legislation are far-reaching and there's been no consultation with the disability community. We were given 2 weeks to engage with this legislation and there was no consultation prior to any of these reforms being announced. So our message is simple. Slow this down, extend this inquiry, consult properly with the disability community, remove the overreach of ministerial powers that circumvent appropriate consultation, due process and the consideration of participant safety. Put the supports outside the NDIS in place before reducing or removing the supports that people rely on now. And consider the interaction between NDIS supports and the other support systems. Thank you, Chair.
Thank you very much. We'll go to Senator Steele.
No,
we'll go to Senator Askew.
We'll mix it up.
Now you've confused me.
I was going to say.
Sorry about that. I just could touch on some of the things out of your opening statement there. You said that the impact analysis reported that one of the most impacted groups is likely to be people with Down syndrome. If that's the case, where will they receive support to participate in the community or maintain employment if their budgets are cut?
It's a great question. They will be faced stark choices as to what supports they give up. That's some of the concerns I reflected from what we're hearing from our community. They're going to have to make that decision around, can they keep that job? Can they keep working? Can they keep playing hockey? Can they keep going to those social activities? I'm not sure being part of a hockey team works if you can only turn up to every second training session and every second competitive match. So that's exactly the stark choices people will be faced with.
Okay. So and you also mentioned that it sounds like the support needs won't change and yet budgets will. So is it possible then that the longer term outcomes for people with Down syndromes could end up being worse or detrimental?
That's absolutely our fear. I think the importance of all of the NDIS supports, but in particular capacity building, social and community engagement supports for that cohort, where often that's their only opportunity to engage beyond their immediate family or their immediate living environment. They're often what builds the capacity to then go on to employment if they're not in employment, to be able to make those connections outside the community. And as the Disability Royal Commission pointed out, having access to those supports in the community is also a really core and key way of ensuring the safety of those participants. If they don't have the same level of funding to access the community, they're going to be at home or in their group homes, and they're not going to be as visible in the community, and they're not going to be as safe.
You've also named in your submission some cost shifting out to other services. Can you tell us more about how you see that happening and across what services?
Yeah, look, I think it's really difficult, as other witnesses have said, to just purely think about the NDIS with blinkers on. To give you an example, it may make sense, to somebody in government to cut a particular participant's funding by $20,000 because there's a $20,000 savings from the NDIS bucket. But if that's a participant who has a single parent, that single parent now may need to make a choice about the hours they're working. They might now be contributing less income tax. They might now be entitled to a carer payment. Other siblings might be entitled to other supports. So by cutting something within the NDIS, yes, you might have ticked a box in terms of a saving in that area, but it doesn't consider the broader costs to government systems, as well as to the well-being of the individuals involved.
Good point. Given your significant impact, the impact that this would have with people with Down syndrome, was your organisation involved in designing the NDIS reforms or in drafting the legislation? I know you said before it was without any consultation, so you were not aware of it at all?
No, there was no consultation on the design of these reforms with our organisation or any other disability organisations, as far as I'm aware, including the government's own Reform Advisory Committee.
Okay. And your submission talked about the unintended consequences of the legislation. Can you share some more about the risks that you can see?
Absolutely. I mean, I think the complexity of this legislation, the number of different initiatives and aspects that it has to it, there are going to be unintended consequences, some of which we've started to see already. We've spoken about, I've just spoken about the consequences of removing social and community participation supports. Earlier witnesses spoke about the fact that those social and community participation supports are able to be used flexibly. So people might be using them for getting out of bed in the morning, having their showers, everyday living costs. It's important to consider those. And there's no mechanism within those ministerial determinations to consider individual circumstances as part of any of these cuts. And there's no consideration of the safety or risk for those individuals. I think another example would be that within social economic and community participation is that support line item. And as I said with a couple of the examples, that's support that people are using to work, to go out and engage in paid work, and they're going to have to now cut that back. How can that make sense as a saving to the NDIS?
You mentioned your concerns around ministerial powers. What amendment could be put in place to correct that or to fix that?
I mean, look, our preference is that level of power sitting with the minister is removed. I don't think those sorts of powers should sit with a minister because there is no opportunity for any review, any consultation with the community. There's no requirement for impact assessments of any great degree. So we would prefer they be removed. There's no time limits on those determinations. There is, as I said, there's no requirement to consult with the community, and there's no opportunity to look at the individuals as those across-the-board determinations are implemented. So there needs to be better oversight. There needs to be better.
Just add.
Is that all right? So if you were, where would you put that decision-making? Where do you think that should appropriately sit?
I think if you're going to make decisions like at that type of level, cutting supports across the board, that needs to sit in primary legislation as a starting point. So there is a proper method for
the pricing in the primary legislation.
If you're going to make cuts across the board to support categories, to cohorts of participant, that should sit in primary legislation.
Or shouldn't have.
Or preferably shouldn't have.
Okay.
Am I still going?
Yes, sorry.
Sorry, okay, I just didn't know if you had another one. So also you raised concerns regarding the changes to permanence requirements and requirement for treatment, and how would that impact your community with people with Down syndrome?
I think the main concern around the all appropriate treatment is the complexity of applying that in practice and what would be allowed to be taken into account. It's very unclear in the legislation how that would be applied. There could be the need to pursue all appropriate treatment, even if the incremental improvement to functional capacity is incremental. It moves very much back to a medical model of disability and a medical way of looking at disability. And we would also support the comments that the committee heard earlier from Inclusion Australia about the use of psychotropic medications and how that could be an inadvertent consequence of that.
Okay, I'm nearly done. I know we're about to run out of time. You just mentioned before about the process and the fact that there hadn't been consultation. So what would normally happen in regard to consultation on other bills, and how would that impact your organisation?
Well, even just looking at previous NDIS bills, the consultation periods have been significantly longer than 2 weeks. I think they were 6 and 10 weeks in previous bills, and I understand the kind of standard recommended by the law reform is 6 weeks. So time would be the key thing. As I said before, it's not that the disability community does not want to engage in reform or that we do not believe reform is necessary. We do, but we would like to be involved up front. We would like to be involved before legislation lands on a table that we then need to engage with.
Okay, I'll leave it there, Chair. Thank you.
Cool. Senator Steele-John.
Thank you, Chair. Look, thank you for your evidence, Mr. Steph. First of all, can I just clarify your submission on the first page says really succinctly for us that Down Syndrome Australia's consortium supports reasonable reform, but does not support the legislation in its current form, which is what you said in your opening statement. You also say that you recommend that the bill not proceed. So I'm just checking that that's the evidence you're giving to us today.
In its current form, absolutely.
Yes. Look, I want to thank you. You're the latest in a long line of disability organisations that have had the clarity and the courage to be decisive in their answer, which hasn't been always the easiest thing to do in a Senate inquiry context. In answering my colleagues' questions, you've gone to a number of the questions that I was going to ask you, so I've only got a couple now. First of all, just in terms of the impact on parents and families of this bill, which makes up a large part of your a significant part of your submission, can you talk to us about the impact that you feel this will have on families?
Yeah, absolutely. So I think it comes in a couple of ways. One is as a result of funding cuts that would happen if this legislation was passed in its current form. Families cannot continue to be treated as an inexhaustible substitute for formal supports. So the burden shifting onto them, like I said in my opening statement, the need doesn't disappear, and it's those families and carers that will pick up that burden of support at significant cost to themselves, to their own employment situations and ability to contribute to the economy, and their mental health. And I think outside of the impact on families, the burden would also shift to health systems, crisis systems, etc. And then I think the other impact on families is the increased emphasis on parental responsibility that comes in the legislation, and as other witnesses have testified, it's really inappropriate to continue to just assume that parents will pick up that responsibility. Any level of responsibility, even to the extent where it might require 2 or 3 very well-trained support workers to do that work. And then probably the last point I would raise would be that when you're talking about people with Down syndrome and intellectual disability and chromosomal variations like the group we represent, parental responsibility isn't something that finishes when a child turns 16. When they have an intellectual disability, it's a parental responsibility for life. And that creates significant compounding impact on those parents and those families. And it's not just the parents, it's the siblings, it's the broader family group as well. And our real concern is that this legislation doesn't give that proper credence and proper respect, and that burden will just increase if the legislation passes in its current form.
And how, in your view, will the cap on support for different classes of people, maximum support ratios, these are parts of the legislation, how will that impact on people with Down syndrome in Australia?
Yeah, look, I think, again, again, as other witnesses have mentioned, it's the second way that this legislation introduces the concept of not being funded for your full, reasonable and necessary support. So it allows funding to be reduced beyond that level. And it also, the use of caps and ratios disproportionately impacts those with the higher support needs as well. So if they were, to bring in an example, if they were to cap allied health supports, for example, at 12 hours a year, then if someone has moderate support needs that's maybe only at that 12 hours, they're not impacted by a cap. But if someone has been assessed as a reasonable and necessary support of 24 or 26 hours of support, then they are going to be disproportionately impacted. So it's not an equitable consideration when you're talking about caps.
And with support ratios, which is often relevant for your community, do you have concerns about the way in which an across-the-board determination in relation to ratios might drive harmful impacts?
Absolutely, and unfortunately we see it happening already where determinations are being made that, you know, I understand you've been supported at 1-to-1, 1-to-2 previously, but we're now only going to fund you at 1-to-3. So that has a significant and varied outcome. We've heard examples of where that means participants can no longer attend the same programs they were attending because a 1-to-3 support does not work for them. They might need to change their accommodation provider or move housing. They might need to just cut the level of support they have and end up being more isolated by not being able to have the level of support they need. If they need 1-to-1, they need 1-to-1. You only funded 1-to-3, you can only go out a third of the time or be supported a third of the time that you were otherwise. That doesn't make sense.
Or be forced into a group setting, is that also the concern?
Absolutely, yep.
Yeah. And just finally, what are your concerns with the changes around the definition of permanence that we see in the legislation and the introduction of the functional capacity assessment process for the Down syndrome community?
Yeah, look, I think we're already seeing challenges of applying the support needs assessment that's part of the current new framework planning process, applying that to groups of people like those with Down syndrome who have impairments across a number of different categories, so from intellectual to physical to sensory, etc. And we're seeing those challenges in the support needs assessment process. We can only see them compounding and having further challenges when you try and look at it from a functional capacity assessment to try and accurately assess those with high and complex support needs. Therefore, I think, you know, the time needs to be taken to do this properly to ensure that there actually can be a fair assessment of functional capacity for everybody in the scheme. And the other concern we have around the definition is the application of the definition to Section 25, early intervention access. Yes, okay, lists are being removed. That was the NDIS review recommendation, wasn't to completely remove the lists. It was to look at functional capacity but not ignore what a diagnosis might tell you about someone's disability. And so Down syndrome and other chromosomal variations are a great example. What we don't want to see is that someone who has Down syndrome cannot access the NDIS until they have a functional capacity that is severely impacted, because they have a diagnosis that tells you they are going to have a functional capacity that is impacted. And the whole purpose of early intervention is to minimise that impact.
Yes.
And the whole purpose of the NDIS is to minimise that impact. So the definition and the application of the functional capacity to early intervention must allow for the recognition of a diagnosis that tells you something about future functional capacity.
Yeah. Okay. Thank you very much. If you could just take on notice for me the amount of, if any, federal government funding you received in the 25-26 financial year, and whether you are the recipient of the additional funding announced in the budget for supporting the government in communicating and implementing these reforms. I've asked it of a couple of your other organisations.
I understand. No problem.
And they'll have to go back to us by Friday.
Yep.
I know it's a bit of a tight turnaround. Thank you.
No problem. Thank you, Senator.
Lovely. Thank you so much for joining us. We really do appreciate the amount of time and effort you've put into engaging with us. It is great. Thank you so much for taking something on notice. I know the timeframes are really short. Thank you so much. I would now ask the Disability Advocacy Network to make their way to the table. Good afternoon, Mrs. Benison. Thank you so much for joining us. I believe that you have received the information on parliamentary privilege and the protection and obligation of witnesses giving evidence. That's correct. Excellent. Glad to hear it. For the Hansard record, would you be able to provide your name and the capacity in which you're appearing today?
Sure. My name is Emma Benison. I am the Chief Executive Officer of Disability Advocacy Network Australia.
Fantastic. Thank you so much. Do you have an opening statement that you'd like to provide?
Yes, I do.
Please go ahead.
Thank you. So, as I said, I'm Emma Benison, Chief Executive Officer of Disability Advocacy Network Australia, or DANA, which is the National Representative Organisation for Independent Disability Advocacy. I'm also appearing today as a blind person, as a long-time disability advocate, and as someone who, like many Australians with disability, has spent much of my life navigating systems that weren't designed with people like me in mind. DANA's submission sets out our detailed policy concerns regarding the proposed reforms, and so I'm not intending to repeat all of those today, but what I do want to focus on is what we believe is really most at stake here. So I want to say quite clearly at the outset that we're not opposed to reform. We understand that the NDIS needs to evolve, and we support efforts to improve consistency, transparency and long-term sustainability. We support addressing fraud and poor practice, and we acknowledge that many people's experiences of the scheme are already far from ideal. But reform done to people rather than with people creates fear, uncertainty and harm. And across the disability community right now, we're hearing deep anxiety about the changes that remain unclear in both design and implementation. Many people still don't understand what these reforms will mean for their daily lives, for their supports, for their housing, for their relationships, or for their futures generally. And that uncertainty isn't an abstract, it's real life. In recent weeks, I've spent hours navigating dense policy material, inaccessible processes, compressed consultation timeframes and significant uncertainty, whilst also trying to fulfil my responsibilities as both a CEO and a participant in these reforms as a blind person. And I say that as someone with decades of advocacy and policy experience, someone who's got strong organisational support and a high level of familiarity with government systems. For many people with disability, particularly those without that privilege, participating meaningfully in reform processes like this can feel really overwhelming, exhausting, and at times really is impossible. And the fact that we've had 4,500 submissions to this inquiry, I think, is something really important to note, because it tells you just how disturbed the community is by where we're heading. And at the same time, demand for independent disability advocacy is increasing significantly already. Across the country, advocacy organisations who are supporting people who are trying to understand highly technical reforms, whilst also managing fear about what those reforms might mean for their everyday lives. And that's while they're also supporting many, many people, an increasing number of people, with NDIS appeals. Many people are contacting advocates because they don't know where else to turn for clear, independent support. And at the same time, we have the disability advocacy sector itself under considerable pressure. That's partly because the new Disability Advocacy Support Program tender process is also currently underway, which is creating additional uncertainty for organisations that are already operating at capacity while responding to escalating community need. Independent advocacy isn't an optional extra during reform processes of this scale. It's essential infrastructure. And if governments want people with disability to engage constructively with significant system reform, then people need to have access to trusted independent support to understand their rights, navigate complexity, raise concerns safely, and participate meaningfully in decisions that affect their lives. Without strong advocacy, the risk is not only that people will struggle to navigate change, but that important systemic issues and unintended consequences will go unheard until harm has already occurred. One of Dana's central concerns is about sequencing. We cannot move people away from existing supports before alternative supports, safeguards and community infrastructure are genuinely in place. To do so risks transferring uncertainty and system failure directly onto people with disability and our families. We're also concerned about the lack of clarity regarding foundational supports, review mechanisms, algorithmic decision-making, and how consistency will be achieved without creating new forms of rigidity or exclusion. I also want to acknowledge that on the surface, many aspects of the reforms might sound quite reasonable to members of the public who aren't directly interacting with the disability support system. Concepts like consistency, sustainability, assessment and clearer boundaries around supports can appear really quite sensible and proportionate when they're discussed at a high level. But we, as people with disability, don't experience reforms at that level. We experience them through the practical realities of daily life, like whether our support workers turn up, or whether assistive technology is funded, or whether people can actually leave their houses, maintain employment, participate in education and care for their children, or remain connected to communities. And many people with disability also carry lived experience of systems that have historically been difficult to navigate because they're inconsistent, under-resourced or experienced as adversarial, or in some cases even abusive. And that history really shapes how these reforms are being received by our community. And it's why the detail, safeguards, transparency and genuine co-design matter so deeply to our community. I also want to acknowledge the broader impact that the public discourse about this legislation is having on many of us. Policy discussions about sustainability and cost are really important, but when people repeatedly hear public narratives that frame us primarily through the lens of economic burden, fraud or system pressure, that has a real impact on people's sense of belonging, safety and inclusion in the community. Many of us are not simply responding to legislative change. We're responding to the cumulative emotional impact of feeling that our value and legitimacy are increasingly being questioned in public debate. And these conversations aren't occurring only in policy spaces anymore. They're occurring around our family dinner tables, they're occurring within our friendship groups, they're occurring within our workplaces, in our communities, and they're often creating fear, tension, and deeply personal conversations about people's worth, about their contribution, and about their future. And I know that because I've been having some of those conversations myself in the last few weeks. And I have never had the kinds of conversations about disability in my life that I've had in the last few weeks. And at the same time, people with disability are being told that these reforms will strengthen inclusion and community connection. But for many people, that rhetoric just simply doesn't align with their lived experience of exclusion, inaccessible systems, workforce shortages, discrimination, and communities that were never fully inclusive to begin with. I am old enough to remember what it was like before the NDIS, and I can tell you I do not want to go back. It was terrible. And we can't assume that the community is automatically able already to just provide the safety, accessibility and support that people need, simply because policy language says it should. That's just not how community works. And this context really matters when you consider the level of fear and anxiety that many people are currently experiencing. People with disability are being asked to trust systems that are just simply not there. They're not defined and they don't exist. And trust can't be built through urgency alone. It must be built through transparency, co-design, accessibility and genuine engagement. The disability community has repeatedly demonstrated our willingness to engage constructively and reform. The joint statement from disability representative organisations reflects that shared commitment, but it also reflects a shared concern that the pace and structure of these reforms are outstripping people's capacity to participate meaningfully and safely. At its core, this is not simply a policy discussion. This is a discussion about whether Australians with disability can live with dignity, certainty, autonomy and inclusion in our communities. The decisions made through this process will shape people's lives for decades to come. So Dana urges the committee and the Parliament to ensure that reform is careful, transparent, accessible and genuinely co-designed, because when systems fail, people with disability carry the consequences. Thank you.
Thank you very much. We'll go directly to questions and we will start with Senator Steele-John.
Thanks, Chair. Thank you for your evidence today. First off the blocks, could I ask you, does Dana have the position, in accordance with many of the other disability organisations that are giving evidence today, that the bill in its current form should not proceed?
Absolutely.
Okay. Thank you. We are running a little bit behind time as a committee, so I've looked through my questions for you and I'm going to narrow them down to one. The legislation makes significant use of increased ministerial powers in the form of direct ministerial powers, legislative instruments, regulatory powers, all of which have not been written yet or made public. What are the concerns that your organisation has about this approach?
Well, the ministerial powers are over and above what we would support. We would not support those powers in their current form at all. We strongly believe that any decisions about disabled people and about that are going to impact our lives need to be made with disabled people. And unless the Minister is planning to employ a whole tranche of disabled people in his office, which I find very difficult to imagine, but if that were the case, I might feel differently about this. But the fact is that in the absence of that, and in the absence of a proper consultative and review process that puts people with disability at the centre, we would not support those powers because they could have serious unintended consequences for people's lives and cause just untold uncertainty and anguish in the community. So absolutely wouldn't support that.
And I've found the right section of the budget this time, so I can ask the question properly. So in the budget papers, there was $15.9 million allocated from 26-27, as well as $6 million ongoing for disability representative organisations to support community engagement in design and implementation of reforms, with the costs to be partially met within the current budgets of the department and the agency. Was Dana the recipient of some of that money?
Not at this stage, but I can give you on notice the figures that
the broader Commonwealth figures of how much funding you've received. But you didn't receive money from that particular element of the budget?
No.
Okay, thank you very much. I have many other questions, but in the interest of time, I'll just pass back to the chair.
Thank you. And we'll go to Senator Askew.
Thank you. I'm just trying to, I've got quite a few highlighted here too. I'm trying to prioritise a couple.
Okay.
How do you believe the proposed changes to review rights and reassessment pathways would practically affect a participant trying to fix an unsafe or inadequate plan?
Well, it's going to be much more difficult. I think that's pretty clear. But people will not have the same opportunities to be able to fix plans that are wrong in the first place. So, you know, I think it will mean that people will not have the same access to choice and control. That will be the flow-on effect of this, and it will also mean potentially that people will not be able to exercise their right to appeal in a meaningful way, in a meaningful sense. So it could very, very well mean that people get a plan that's you know, essentially inadequate, that doesn't meet their support needs at all.
So, and you mentioned in your submission about recommending that the bill should be amended so the 90-day timeframe doesn't apply to urgent matters.
Yeah.
I specifically asked that question in estimates on Friday and was reassured by the agency that, you know, it would be triaged and the urgent matters would be, you know, dealt with as quickly as possible. Can you give me an example of what you would define as urgent and what threshold would need to be met?
Well, I think you know, if somebody desperately needed a review because their circumstances had significantly changed and they were at risk of harm, that would be an example. And I think, you know, the important thing is that we need the pathways for those reviews to happen, and we need to know what the underlying kind of rules and instruments are that will underlie that, because you're right about the time frame. It's very hard to know kind of how that would be applied, but I mean, I think the real issue is that a right to appeal, you know, is only useful if the practical remedy exists, and if that remedy disappears, then you can appeal as much as you like, but it's not going to change the reality of your plan. So that's a real concern for us.
My concern when I asked those questions on Friday, when 88% of the reviews were unscheduled ones, was that it was still that most of them were done within, you know, 50 days instead of the 21. What's it going to blow out to from the 90 days? So I did put that to them.
I did hear. I watched that.
Thank you.
It's very good.
So do you believe the current level of reporting reporting requirements, red tape and regulation is unnecessary and burdensome?
Yes, I think you're referring particularly to the documentation and record keeping that's required. Is that what you're referring to? Yes. Yeah. I mean, look, it's really concerning because people with disability, you know, could potentially be blamed or made to pay debts in some cases for issues that were not, you know, the fault of the person with disability. So that's a real concern. But also, you know, we need to think about proportionality here and risk, and really think about, you know, why are we asking people to keep, you know, such rigorous records, and whether that's really necessary. And again, this is why it is so important that these reforms are co-designed, because people with disability have been solving problems for ourselves for years. We're actually pretty smart, some of us, and so I think we can probably help. We could probably help create a better system. So I think we're saying that we want to amend the bill to protect participants from debt and compliance action where people are not at fault, and including where those failures arise from providers or systemic barriers. Because obviously we know fraud needs to be tackled, but people with disability shouldn't be punished for system failures that are not our fault, or provider behaviour that's not our fault. That's really the long and the short of it.
So just on that, do you think there would be a need for a red tape review to reduce excess and red tape and requirements and the administrative burden?
Well,
would that be something worthwhile?
I have been saying to anyone who'll listen for a long time that actually I think that's the first thing we should do. Before we even go down the path of passing new legislation, why don't we actually fix what's there at the moment? Why don't we actually fix the system so that it works optimally for people with disability and our families and for providers? I actually think that's where there might be some real hidden savings to be made.
Okay, thank you. I'll leave it there. Thank you, Chair.
Thank you very much. Thank you so much, Mrs. Bennison. Really appreciate you taking the time.
Can I just make one final comment?
Sure.
If that's okay. Sorry. It's just something that I forgot to say in my opening, which is this notion of treatment and appropriate treatment. I just want to say that as someone who's a very proud blind person and takes disability pride very seriously and has worked very hard to overcome internalised ableism for many decades, I would say that this notion of appropriate treatment is terrifying to me personally, because if someone said to me tomorrow, you can have your sight back, I don't know that I'd want it, but I also want the NDIS, and I think I should have the right to choose. And secondly, for people who have acquired their impairment recently, who are grieving, because it is a grief process, and who are often traumatised, to be asked those questions, to even be asked those questions, is deeply, deeply distressing for many people. So I just implore the committee to really think about this and to think about the slippery slope that we're going down, because be in no doubt, we are going back to a medicalised model of disability if we let this pass. So that's all I wanted to say. Thank you for indulging me.
Thank you so much for your time and your expertise and investing in this process. We really do appreciate it. It does make a big difference. Thank you so much.
Thank you.
With that, we will go to a quick break and we will recommence at 3:30. Zoom. Would our lived experience witnesses like to make their way to the table? Welcome, Jasmine and Michelle. Thank you so much for agreeing to come and share your personal stories. This will be a listening exercise, so we'll just go to each of you in turn and give you the space to tell us of your experience and your perspective. So who would like to start? Jasmine, are you okay
Sure,
with that?
I can start. Yeah, that's fine. Okay. I'll just move this, sorry. Okay, you ready for me to begin?
Yeah, and I will just remind everybody that it's best not to disclose too much private information in terms of full names, dates of birth, addresses, any of that sort of stuff when you're talking about yourself or other people.
Mm-hmm.
And because we are being broadcast live, but we're very much appreciative of you sharing your stories. Jasmine, please go ahead.
Are you all right for my video to stay in place as well? Thank you.
That's fine. No worries at all. Thank you to the committee for the opportunity to give evidence today. My name is Jasmine. I am a 27-year-old disabled woman. I am a postgraduate student, and I also run Babes with Mobility Aids, a social media platform that celebrates disabled joy and shares educational content around disability. I would like to begin by naming something that I've been sitting with in the lead up to today, and I think it's the most important thing that I can offer this committee. I am sitting here in this hearing because I am privileged. I am privileged because at 27, my parents still house me, which means that my basic survival does not depend entirely on what my NDIS plan does or doesn't cover. I am privileged because I had the savings I could spend on flying to Melbourne, because I decided this inquiry mattered more than what I had been putting that money aside for. I am privileged because I had the cognitive capacity to write the speech, the time and energy to prepare for it, and the physical ability to sit in this room and deliver it. I would implore you all to hold that as I speak, because every piece of privilege that I just named is something that another disabled Australian might not have. That person could not be here today, and that person is the one that this bill stands to harm the most. That person may be the one that it ends up killing. And that's not dramatic, it's unfortunately the harsh reality. I have 3 fantastic support workers, and they are crucial to my life and my functioning. Not just because they support me with my daily living tasks, but because it takes the caring load off of my parents, who already do far more than most parents of a 27-year-old should have to do. That is the reality of my life as it currently stands, and I want the committee to keep that baseline in mind, because what I'm about to describe to you is what happens when that changes. I would like to move out one day, and I like to think that that's not an ambitious goal. It's simply the ordinary expectation that most people my age would hold, that at some point they will live independently. But if I move out, my support needs will increase, because the informal care that my parents currently provide disappears, and I would need the NDIS to formally fund what they have been doing a long time for free. Here is where the bill becomes relevant. Under proposed Section 50A, the Minister has the power to alter any participant's plan at renewal, and critically, that alteration will be deemed not to be a reviewable decision. There is no appeal pathway. If my plan were renewed under that provision and supports were removed or reduced, I could not challenge it at the Administrative Review Tribunal. The legal mechanism we have now to fight back would simply cease to exist. And so when I say I'm uncertain as to whether I could secure the support that I would need to live independently, I'm not describing some vague anxiety about a bureaucratic process. I'm describing a specific legislative reality that this bill creates. If I cannot get that support, the consequences are not abstract. My parents would absorb that caring burden back into their lives. This is without recognition, without compensation, and without any support. And they are not alone. This bill will transfer the cost of care away from the government and back onto the families of disabled people. Their needs do not disappear. The cost simply moves from a funded visible system to unpaid invisible labour, which is carried overwhelmingly by women. Section 9B compounds this further by allowing the Minister to redefine functional capacity in a way that excludes environmental and personal circumstances from assessment. Under that definition, the fact that my parents are currently providing informal care could be used to suppress an assessment of my actual support needs, because my functioning looks more stable than it is. But this bill gives the Minister the power to determine that those circumstances simply do not count. I also want to speak to you as someone who used to sit on the other side of this system, because I think that perspective matters here too. Before my health forced me to leave, I was a paediatric speech pathologist, and I worked with children with complex presentations. I worked with families who were barely making it through each day, who had restructured their entire lives around the needs of their child, and who were constantly fighting for support that should never have required a fight in the first place. When the NDIS was involved in those cases, it was a gamble. That is truly the only word that accurately describes it. It was a gamble as to whether the planner would engage with the reports that I had written and actually use them to inform the decision that would impact that child's life. Too often, they did not. Too often, decisions were made based on assumptions and on internal KPIs and targets, on processes that were never designed to hold the full complexity of a child's disability or the clinical reasoning of the professionals who had spent months building a picture of their needs. This is already the reality, and this bill will make it significantly worse, because sections 59B through 59E of the bill explicitly authorise automatic decision-making by computers, including, and I want to be very, very clear about this because I believe it's unfathomable, for decisions that involve the exercise of a discretion, the formation of a state of mind, or the making of an evaluative judgment. Those are not simple administrative tasks. They are the decisions that determine whether a child receives the therapy that they need to learn how to communicate, whether a person receives the support they need to leave the house, whether someone like me can live independently or must move back home. And this bill says those decisions can be made by a computer. The allied health professionals who write the reports that feed into these assessments spend hours, sometimes days, with a person. They consider context, they consider fluctuation, they understand that disability is not a fixed state. They understand that a person who can stand upright in a clinical assessment room may not be able to get out of bed for the week that follows. No automated system or checklist can fully capture that complexity. The individualised, clinically grounded assessment that allied health professionals provide is not just a formality, it is the evidence base, and this bill treats it as optional. The combination of that systemic dysfunction, the unrelenting advocacy required just to navigate it, and my own worsening health pushed me into burnout. And I left my job, not because I wanted to, but because I had nothing left to give. I want to be very clear about what that means in the context of this bill, because I feel that it is easy to hear the word burnout and understand it as a personal circumstance rather than a policy consequence. The system as it currently exists before this bill already extracts an unsustainable amount of labour from the disabled people navigating it, from the families supporting them, and from the allied health professionals trying to advocate for them. This bill does not address any of those structural problems. Instead, it removes review rights, authorises automation, and narrows access, and calls that reform. My supports are what allow me to work and to study. Because of chronic pain and fatigue, I rely on others to manage the tasks that would otherwise exhaust the limited energy that I have. Otherwise, I have nothing left for work, for advocacy, for study, and for being a person who contributes to society. The proposed Section 34A gives the Minister power to reduce funding for any specified group of supports by up to 99% by legislative instrument without meaningful review rights, with the only safeguard being a requirement to have had regard to participant safety, which legal experts have noted is likely satisfied simply by writing those words. Community access supports are precisely what that power could target. Community participation is not a luxury. It is the mechanism in which disabled people remain connected to their own lives. The Disability Royal Commission found with extensive evidence that isolation and segregation are key drivers of violence, abuse, neglect, and exploitation of disabled people, and that autonomy and inclusion are the primary safeguards against those outcomes. This bill moves in precisely the opposite direction from these findings. It does not just ignore the Royal Commission, it legislates against it. Before I finish, I want to briefly name something about this inquiry process because I think it is relevant to the question of how this bill was designed and for whom. The submission window was 2 weeks. 2 weeks for disabled people managing chronic illness, cognitive fatigue, pain and communication barriers to engage with complex legislation and prepare a formal response. Co-design is a genuine commitment to ensuring the people most affected by a decision have a hand in shaping it, and by that measure, this process has not met that standard. I want to close by returning to where I began. I am here because I am privileged, and that privilege is a source of grief, not pride, because I understand what it means that I am in this room and someone else is not. The person who cannot be here today might have more significant support needs than me, might not have parents who can house them, might not have the energy or the savings or the communication capacity to participate in a process like this one. They might be someone whose supports have already been cut and who is spending every resource they have simply trying to survive. This bill will not affect all disabled people equally. It will fall hardest on the people who are already carrying the most, those with the fewest informal supports, the least capacity to navigate complex systems, the highest barriers to self-advocacy, while simultaneously removing the review rights that would allow them to challenge the decisions made against them. The repeal of Section 31, which provided the scheme's human rights foundation, is not a technicality, it is a clear statement about what this system is now for. I'm asking this committee not just to listen to me, but to the silence in this room. That represents everyone who could not be here today to share their story. I ask that this bill be withdrawn. Thank you.
Thank you, Jasmine. Really appreciate it. Thank you so much. Thank you. Michelle, we'll go to you.
Thank you. I just wanted to say thank you for giving me the opportunity at such short notice to speak. My name is Michelle. I am a single mother of 2 NDIS participants aged currently 7 and 10. Both my boys have the same diagnosis, the same profile, the same parents, and the same family violence history. One received early NDIS access. He is doing well, is currently appropriately supported. The other did not. My son Lennon, now aged 10, first received his plan September last year at the age of 9. My children are the direct comparable result of what thriving kids and removing support for low to moderate needs looks like. You don't need to wait to find out what this bill will do. My children are that lived experience. By the date Lennon received his plan, he had already been chemically sedated twice, once in his own home. He had already been sanctioned under the Mental Health Act by the police twice. He attended emergency departments in crisis multiple times with no support and sent home with no follow-up. He is in the prior 12 months had experienced over 10 police and ambulance call-outs. He has developed PTSD from that chemical restraint within the emergency department for an autistic meltdown. Sorry, a little nervous.
Please, Michelle, take your time.
This bill proposes that families like mine rely on these services without the appropriate measures already in place. It will produce my son's story en masse. You won't have one Lennon, you will have multiples. Our story explains how a child with autism spectrum disorder level 2, ADHD, a pathological demand avoidance, complex trauma history, and PTSD, as well as suicidal ideation from the age of 6, was failed by Australia's current systems. He ended up without any positive behaviour support or therapy access for months and in the care of his father in an unsafe, unstable and inappropriate environment for a child. He is currently living with his father in student share accommodation, sleeping on the bunk bed above his father with no place to stay, no space to play, no space for therapeutic intervention. Support workers have raised safety concerns, not just for the environment, but for his placement there. For months, DFFH said it was the NDIS's responsibility, that we had to wait for the correct supports to be in place. At the start of this year, in the middle of an internal review to try and secure the appropriate supports for my son, I had to make the heartbreaking decision that no parent should ever have to make, and that was the choice between the safety of myself and my youngest or the survival of my other. I had to make the choice for him to go and live with his father because my youngest son has a history of complex skull fracture. In court reports, it was described as shattered glass. I'd been pushed down the stairs. I was lying in Epping emergency in a neck brace waiting for CT scans to see if I had skull or spinal fractures. And it was at that point that I knew I had been screaming for help for over 12 months and no help was coming. I didn't have a choice because had it been my youngest, he would have a permanent brain injury from that fall. And it had almost been him multiple times. This has resulted in escalating risk for us all, psychological harm, loss of continuity of care for Lennon, and prevention of any meaningful interventions. This is what will happen to children on Thriving Kids when they cannot access the appropriate supports. My youngest son, Phoenix, in 2023, 2024, had a stutter. He could not speak very clearly and would often go nonverbal. I think it was 2 weeks ago, his speech therapist has reported no concerns. That is what early intervention and early access does. In 2004, our story thus far was reported in the ACOS Material Deprivation Report, page 56. Parliament was formally notified of my family's situation. Nothing changed. 5 months later, my son was sedated in an emergency room for an autistic meltdown. A child with a family violence history was held to a bed for over an hour, chemically sedated, and then sent home with no support. This bill has been framed to the public as fixing fraud and protecting the NDIS for future generations. What my submission covers is not just the story and comparison of my two children, but a lot of costs that I don't think have been considered. Costs for emergency services. I was directed by Child Protection to rely on health and emergency services whilst waiting for Lennon's NDIS plan. As I said before, over 10 police and ambulance call-outs, 2 sanctionings, attendance to the emergency department, multiple crisis presentations, a full child protection application that was later receded that my children have high disability needs. Multiple court hearings. None of these costs have been accounted for, but in addition to that, costs that may not have been considered is for the training of those first responders and emergency services. I'm not sure if the Senate is aware, but when someone is actively threatening suicide, ambulance don't attend first, police do, but those police do not have mandatory mental health training or disability training. The police that attended to try and help me protect my son on 70, 80 hours of no sleep did not know how to handle an autistic child. They often caused more problems, more trauma. He has PTSD from these services. Additionally, it's the cost to carers, the informal, unpaid supports. From July to September 2024, I underwent fortnightly gastroscopy and dilatation procedures under general anaesthetic and spent months on a feeding tube. In February last year, I was delayed from attending emergency for a medically urgent gastroscopy because I had no one to care for my children. In August, I had the hospital remove me from the clinic list. I could not get overnight care. A separate issue, in May last year, I walked out of emergency department when doctors wanted to admit me for urgent surgery because, again, I had no one to take care of or care for my children. I had to go and collect them from after-school care. The infection and bleeding that urgent surgery was going to fix, I still deal with and manage myself almost daily because I haven't been able to resolve that issue. In 2025, I was investigated for an acquired brain injury because of the severity of the burnout and the complicated mix of my ADHD medications at the time, that it appeared I had a brain injury. Thankfully, that is resolved and now managing, but this is the impact that relying on informal supports and carers that are under-supported has, and what will be replicated again should these cuts go ahead. I have struggled with NDIS submissions in being told to rely on my informal supports. I have provided them letters from community members, families in my children's school, stating that as a community they cannot provide the help for the safety concerns of themselves and their children. I am isolated. I have no informal supports, and increasing the reliance on me as an informal carer of 2 moderate to high needs children. What happens when we can't do it anymore, when we break? As you've already heard, I actually have 3 surgical procedures I cannot have because I don't have respite. I don't have overnight care for my children. We don't even technically have community access. I don't have informal supports that I can say, hey, can you take them while I go into hospital? They don't exist for the safety of their own families. Passing this bill would not only return my family to crisis right as my son's plan is about to be fixed, we have ended up in complex pathways. And whilst the plan that they're proposing doesn't meet the needs that have been stated by all of his therapists as necessary and appropriate, it is a vast increase. The cuts that are proposed by this bill will return us to crisis, and it will mean that I cannot be the mother and carer to my eldest son. My youngest son has PTSD from his older brother's needs being left unmet for so long. So I would ask, do not pass this bill as it currently stands. I have made, I think, 8 or 9 formal recommendations, including requesting that Parliament look at establishing an inquiry around the experience of autistic individuals within these systems that are failing us and have caused so much harm, not just to myself, but to many carers that I speak to. Thank you.
Thank you, Michelle. We really appreciate it. It's a terrible circumstance. Thank you. It takes a lot of courage to come here and share your story. So
thank you.
Thank you.
Good afternoon, everyone.
Hello, Michael. Thank you for coming. We really appreciate your time.
It was a big effort. I had to walk into a motel room upstairs to get here. I wouldn't have been able to speak if I didn't spend the $215. But anyway, it's a third of my pension. It's pretty hard when you're not working. Anyway, dear Senate Committee, thank you for the opportunity to appear in front of you. I'm very grateful for the NDIS funding I have received. The NDIS funding has been very helpful. As I will be voicing my concerns of problems in the NDIS, I will prefer not to use my real name. I'll use the name Nick. As my information technology skills are very poor, I had major difficulties drafting today's speech. If my speech today is disjointed, and I'm repeating myself, this is because of my very poor IT skills. I have major concerns that the NDIS is not a cost-effective system. I've been on the NDIS for over 2 years and 4 months. I have a background in clinical practice and also in health statistics. I will be discussing my lived experience in the NDIS. However, more importantly, I would prefer to comment on how my lived experience can be improved in the NDIS. I am not telling anybody what to do with the NDIS. The speech is my thoughts on the NDIS. If something I say is useful, please contact me if you wish. I'm having major difficulties dealing with the complexities of the NDIS. If a person like me has difficulties navigating the NDIS system, this indicates to me that the system is too complicated and is not cost effective. I find it very difficult to find high quality care in the NDIS at a fair price. Spending in the NDIS appears to be out of control. I agree with the government that NDIS legislation needs to be changed to get NDIS funding at reasonable levels. Capping NDIS funding at $50 billion per year with growth of 2% annually seems reasonable to me over the next 5 years. I have not spoken yet to a clinician employed by the NDIA. The NDIA planning process needs to be run by clinicians. The lack of clinicians in the NDIA seems to me to be the biggest problem of the NDIA. I feel that there is not enough clinicians in Australia which the NDIA needs. I think it is worth considering whether I might help. I think it is worth considering whether it might help getting clinicians from overseas, even if they can't get registration here. As an NDIS participant, I would feel more comfortable if I was under an NDIA clinical panel. The internal review process can only be done by clinicians. A hierarchy of clinical levels is suggested. Overseas trained health professionals would make great support workers. I would suggest at the bottom of the NDIA clinical pyramid sit the non-registered overseas health professionals. It was very difficult for me to understand what the NDIA planner was saying to me during my last planning meeting due to her poor English. I asked her if she was a clinician. She did not respond. I can accept an accent from a planner who is a foreign-trained doctor. I have a support worker who is a foreign-trained doctor. He does not have medical registration here in Australia. He does Uber Eats and other low-paid work. He has so much potential for the NDIA as a planner. I discussed with my medically trained support worker about him working in the NDIA. He's open to the idea. He has a wife back in his homeland who is also a doctor. The English standards in the NDIA are terrible. Year 12 English standards would help productivity in the NDIA. Productivity is at 60-year lows in Australia. I do not want to be on the NDIS. Unfortunately, I'm on the NDIS due to many permanent and severe disabilities. Nobody wants to be on the NDIS. We all have a responsibility to get better outcomes for the NDIS participants. Hopefully, over the next 5 years, we can get better outcomes for the NDIS with the same budget. It is extremely important to have the correct diagnosis in the NDIS. If somebody is told by the NDIS to pursue further treatment options, it is imperative that the diagnosis be correct. We cannot effectively allocate NDIS funding without the correct diagnosis. It is far easier to determine funding allocation within similar clinical groups. The NDIS needs to be simpler to understand. I'm not sure if this issue is addressed by the new NDIS bill. The consultation period of time for the new NDIS bill has been extremely short. I do not feel I have had enough time to prepare my submission. Rushing legislation could result in the consequences of the legislation being different from the intention of the legislation. The government and the NDIA have correctly identified that the functional capacity assessment, soon to be known as a support needs assessment, is extremely important. The NDIA has correctly identified the ICANN version 6 questionnaire as being important in the support needs assessment of NDIS participants. Identifying who needs to be on the NDIS and what type of funding they need are two difficult questions. Further research is required to answer these two difficult questions. Prediction models, also known as prediction algorithms, need to be developed to answer these two key questions of the NDIS. Many things have to be considered to allocate NDIS funding. This requires a lot of original Australian research. Things to consider: 1. The literature review. 2. ICANN version 6 data. 3. Disease-specific questionnaires. 4. Generalised questionnaires. 5. Work capacity assessment. 6. Disability and blind pension data. 7. Clinical reports. 8. Other information from the functional capacity assessment. It is up to the Australian Government to develop its research, development and innovation goals. The Australian Government should consider if the NDIS is a research priority. It is worth considering if the Government is also to make its current research... It is also worth considering if the Government is able to make its current research funding conditional to universities. It would make sense to me that the Government instruct universities towards NDIS research. Large amounts of high-quality research data is required to fix the NDIS. My opinion is that it will take a budget of many millions of dollars per year towards NDIS research to fix the NDIS. Many NDIS research questions need to be answered. We need high-quality data to find fraud and poor quality services. Cost-effectiveness studies in the NDIS will allow us to compare the NDIS versus gold standard public disability sector services in other jurisdictions. Thank you, Senate Committee, for your attention.
Thank you very much. I really appreciate the time you've taken to share that with us. Does anybody have a question? And more to the point, are you happy to take a question?
Sorry, Senator, if it's all right, there was one thing that I forgot to mention that
Certainly,
is that okay?
Please go ahead. Please go ahead.
One of the things mentioned in my own submission, which is quite a significant issue, not just for my elder son Lennon, who hadn't and hasn't had behaviour support intervention, but for a lot of autistic individuals, is the real consequence of not having those supports being the justice system, essentially. I'm not sure if the committee is aware, but autistic children are severely overrepresented in the juvenile justice department. Cutting the funds, as mentioned, will likely increase it, and it certainly doesn't provide that support. It's one thing that I felt important to say because he's right before his 10th birthday actually had an incident that, should he have been over the age of 10, would have been reportable and he would have been held accountable for. So, thank you.
Thank you, Michelle. Senator Steele, John.
Yes, thank you. I'm wondering for Jasmine and Michelle, first of all, thank you so much for the evidence that you've given today and for the energy and the resources you've expended to share that with us and with the committee more broadly, with the Parliament more broadly. A lot of the submissions that we have read to this point have drawn our attention to the risks to bodily autonomy and privacy that come from, or that may come from, legislation that hands so much power to a government minister, particularly in relation to the ratios of support that you might be able to access. So whether you can have one-to-one support, or whether you might be forced to need 2-to-1 or 3-to-1. And there's been a lot of evidence around what that might mean for the privacy of people seeking medical appointments, the need potentially to have somebody else accompany you into the waiting room while you go and see a gynecologist or go and see somebody about your mental health. Would you be able to share with us any thoughts you have on the potential risks that might be created by those types of determinations being made at the kind of the broad just data level, rather than actually case to case based on the human being impacted?
Yeah. I think that we, again, are taking away that choice and control if we're not allowing people to choose the people that they are taking to vulnerable appointments, to, you know, do vulnerable tasks such as personal care. You know, a lot of it, I think, does still come down to those principles which this bill, unfortunately, is looking to sort of move away from. In my personal opinion, well, from my personal experience, I work with my support workers one-to-one, and I would find it incredibly dehumanising if I had to also have other people and other participants with me while that was happening, and while we're doing these things that can be vulnerable and can be uncomfortable. Yeah, I think at the end of the day, yeah, my brain goes to choice and control.
Yeah.
How about you?
I think I would add to what Jasmine has said, and to your example directly, that for participants needing these supports, especially to access things that literally will come under human rights and privacy laws, it really raises the question as to where the line is as to those supports being shared by people that potentially are complete strangers, and how sharing those supports may impact or be implicated by a person's disability. I know you said sort of on a broader level, but drawing from my own children's experience, they're both autistic, they're both level 2, they're both PDA profiles. We describe autism as a spectrum, and I often jokingly say my children are opposite halves of that spectrum, so their disability profiles clash, which causes severe behaviours. Making assumptions that people with these disabilities could share those supports may actually result in extremely unsafe environments where we have people being harmed, absconding, or just not getting the support that they need to be safe and well. Yeah.
To add to that, I think, like, you know, there's a reason why the NDIS was created and why there was a shift away from group delivered supports, because it takes away that autonomy, it takes away that choice of control, it increases risk, and you're, potentially putting two people together whose needs clash, and all of these sorts of things that come together. I just think that, you know, we know from previous experiences and how disabled people were treated in this country prior to the NDIS and how they are treated around the world in different systems. I think it is incredibly important to look back at that history and go, hey, we know that group sort of delivered supports are not necessarily the best choice for disability supports, particularly for, you know, people with higher support needs. So.
Fantastic.
Sorry, I might also actually add the risk that it runs is that 2 or 3 of those participants have emergent sudden safety needs at once, and without having one-on-one support, that actually then puts the carer, the support worker, the clinician, whoever it is, at greater risk. Again, it's a lived experience of mine. My son, PTSD, was stuck in a trauma loop. He thought he was being attacked and back in a situation. He was clawing my face. I had injuries that, had I not had a support worker, had I been the only one, and perhaps a support worker myself in that sort of an environment, the other participant not only wouldn't have been able to have the help and support they need to keep themselves safe in that environment, but I could have then potentially had both children in that sort of a situation. It is not safe.
Okay.
And these things can't be accounted for in group settings.
Thank you. Thank you for that. Thank you.
Thank you.
Thank you.
I would just really like to thank you on behalf of the whole committee for taking the time and the bravery that it takes to come and share your personal story with us. It does make a difference. Thank you so much. Really appreciate it.
Thank you.
Thank you. We might just take a quick minute's break. Welcome back. I'll just check. Do we have Disability Intermediaries Australia online?
Yes, you do. Good afternoon.
Good afternoon. Thank you for coming along. Well, thank you for coming along online today. Can I just confirm that you've received information on parliamentary privilege and the protection and obligation of witnesses in giving evidence to the Senate?
Yes, I have. Thank you.
Excellent. Would you like to give us your full name, the capacity in which you're appearing, and then provide us with any opening statement you may have?
Thank you. My name is Tanya Walford. I'm acting CEO of Disability Intermediaries Australia. I'm also a carer to multiple participants. And I do want to note the irony that I was unable to travel today because of the short time frame and my caring responsibilities. So thank you for allowing me to speak via phone. Disability Intermediaries Australia is the national peak body for plan management, support coordination and other disability intermediary organisations and practitioners. We were founded in 2018 and it was basically, we formed because we wanted to advocate for better regulation of the intermediary sector. So for nearly 8 years, we have been recognising the need for professional standards when none existed, and we do support the idea of commitment to quality and integrity through reform. What I would like to say is that the way the legislation is currently worded, it is going to affect participants' genuine choice and control over funded supports. And we have two main concerns. The first one is the lack of partnership and information for members to navigate the uncertainty of this transition. We have a lived experience workforce of more than 40% in our members. We serve more than 2/3 of NDIS participants through our members. And we are well placed to support both the government, the agency and the Commission to implement standards that would provide quality and consistency to the intermediary sector. By having a lack of information, what we're seeing, which is our biggest concern, is a collapse of certain markets already, because announcements have been made one after the other. And what has happened is people who run genuinely high quality businesses are choosing not to stick around and see what happens next. We don't have the information that is going to give us what we need in terms of how we can move forward as a sector. The other thing we're mostly concerned about is the related party provisions ban, which it relates to plan management and was discussed in the explanatory memorandum. This exceeds the Corporations Act quite significantly, and we are of the view that there should be absolutely disclosure of conflicts of interest, and our members already do this as a matter of course. Some of the biggest concerns we have for the workforce affected by related party bans are independent operators of all sizes that might provide a mixture of plan management and other disability supports, where the arrangements are well disclosed and managed, but they're built in response to local on-the-ground needs. So we're talking about thin markets, regional, remote and rural communities, called communities, First Nation communities. And those organisations will often establish multiple services because no one else will. Effectively, at the moment, the legislation will ban those organisations from running at all. And the second one that it will affect is larger parent companies and significant investors who operate plan management as a separately governed unit within broader disability services groups. And for both of those types of examples, there have been large investments over time to move forward with the capability and requirements expected in terms of compliance, technology, integrity. We have met every request that has been asked of us over the last 8 years and uplifted and uplifted and uplifted. And we do feel that we need to be able to give good businesses an opportunity to move forward. I'd finally like to talk about support coordination in particular. because support coordinators have no information, very little. So we know that something's going to happen in 2028, but we don't actually know what that is. That is providing extreme uncertainty in a market that is already looking at increases to SHADS awards. Superannuation, payday super is coming. They have not received increases in price for a long time. They are struggling already, and we are very concerned about the outcome for participants that any unplanned transition may have on that market. So overall for us, we are asking for some partnership and some information so that we can start to support primarily participants. And if we're thinking about some of the planned cuts, for example, to plans of, social community participation budgets, the people on the ground that have to actually communicate that to participants and providers are predominantly plan managers and support coordinators. And we need the information now so that we can start preparing our staff and our teams to actually work with participants and providers to make sure that any changes are done well in advance and that we have a well-educated workforce. Thank you.
Thank you very much, Ms Walford. We will go directly to questions, and I'll go to Senator Steele-John.
Yes, thank you. Thanks so much, Chair, and thank you for your evidence, Ms Walford. First off, could I ask you, in terms of the view of Disability Intermediaries Australia, do you think that the bill in its current form should pass?
Thank you, Senator, for your question. My answer is no.
Thank you. Do you believe that the changes to plan management support coordination in this bill will be enough to prevent fraud in these areas of the scheme?
Thanks for your question, Senator. No, I do not believe that they will. And my reasoning is this. There has already been substantial work done on eliminating fraudulent providers in multiple sectors. But what we know is that at the moment, quality providers are being punished at the expense of low quality providers. It is cheaper to provide low quality than it is to provide high quality, and that hasn't been resolved.
Do you think the bill should go further on fraud, and if so, what would you recommend the government do instead?
I think that over the last 8 years, we've provided, in fact, we were naming fraud well before there was a fraud fusion task force. So DIA members have been extremely active in this sector and have provided multiple examples of the ways in which fraud was being enacted before it was even discovered by the fraud fusion task force. I think that fraud is actually a very small part of the cost of the NDIS. That's been well documented if we look at past evidence around the cost of fraud that's successfully been prosecuted. There is certainly an issue with quality, and we have no issue with regulation, compliance, standards, expecting more from providers. We think that is very important for participant outcomes. However, we do feel that we need to work in partnership with those that are providing and making the rules so that we can give our expertise and our experience on the ground in working with participants and providers and actually help formulate what is going to be a good response.
Now, you've talked about the fact that plan managers are often, plan managers and support coordinators are often the ones actually discovering and reporting the fraud. Are there any barriers you're aware of to reporting instances of fraud and non-compliance to the agency?
Well, I can tell you that, and this is from personal experience, I had a business for 10 years in an intermediary business. Often fraud and reports to Commission around vulnerability of participants or taking advantage and outright fraud, there is nothing that happens for 1, 2, 3 or more years. And I did give that evidence at the integrity inquiry a couple of weeks ago as well. This is one of the biggest gaps that we have, and I think that it's a lack of funding within the agency and the Commission to really investigate properly some of the challenges that we might have with particular providers.
Thank you. And there's been a conversation in this space for a while about the need to put in place stronger protections for whistleblowers in the NDIS. Would this address some of the barriers that you've either raised with us or experienced or heard of through your members?
I absolutely agree, and members would agree that whistleblowing is an important part of the process, and in fact we discuss whistleblowing with members on occasion and at some of our meetings that we have. I think we need absolutely a whole of society approach to quality provision of services for people with disability.
Thank you. Thanks very much. Thanks, Chair.
Thank you. We'll go to Senator Askew.
Thank you. Thanks, Ms Warford, for attendance today. Just got a question. When Minister Butler made his announcement, you issued a media statement outlining surprise and the need to see detail. Do you believe adequate detail and adequate time to review that detail has now been given?
No, I don't. I would have to say the explanatory memorandum and information has given us what I would call upper level information, but what we actually need is information on the ground around how and what it's actually going to look like. And we're not just talking about members that may or may not make it into the panel. You know, we're talking about employees, staff members, businesses with significant sized turnovers who are having to make decisions in the dark.
We had that, I'm not sure if you've been listening during the day, we had a discussion earlier around workforce and the possibility that, you know, there's an expectation that somebody moving out of the NDIS would be picked up through Thriving Kids or other support services by the same providers. Do you see that that would be not the case, or how would you see that working?
I think that would be a terrible loss for choice and control in the NDIS. I do know that particularly when I'm talking about members that we have who are ringing in distress, there is a deeply embedded community, often a community presence that cannot be replicated necessarily by other models. And it is something that has happened over a significant period of time. So people have invested not only their own lives, but those, and they often come with lived experience, but their staff come with lived experience. And we're talking about people with deep-rooted knowledge of community. And I think it would be a shame to throw everything out because we want to tackle something that is a small part of what is happening in the world of plan management and support coordination in particular.
Thank you. Your submission notes that you support the bill but asks for some key changes, and I noticed that was slightly different in the current form. You don't support it. Regarding reconsideration of the related party provisions to ensure plan managers are genuinely independent from the services they fund, your recommendation is a regulatory management framework to replace the structural prohibition. Can you outline how this framework would work?
Yes. We would like to see something where we are actually disclosing related party relationships, and that is running similarly to what the Corporations Act is already doing. It has a very precise framework with materiality thresholds and government-based assessment. It distinguishes a managed connection from an exploitative one. So we propose replacing categorical prohibition with a regulatory framework that comprises of alignment with the Corporations Act. So related party relationships are assessed by materiality and actual governance, not just structural connection. That there's a mandatory publicly searchable conflict of interest disclosure register operated by the Commission, targeting the information gap that enables harm without prohibiting legislative arrangements. That there's a thin market and community controlled provider pathway within panel and commissioning criteria if that happens, and that there's the explicit prohibition of specific harmful conduct regardless of corporate structure. So that's really important for us. Undisclosed commissions, financial inducements and directing participants to related services without disclosure and alternatives should be banned. And that's been our position ever since DIA was formed. I'd like to also add, we support elements of the bill. We support the need for increased compliance, integrity, quality. We have no question with any of that. But the challenge for us is working with the government on the areas where they're going to basically take a knife and cut through an industry that has, for the most part, developed a really great relationship in the last few years with the agency and the Commission. And by relationship, I mean the members who are actively engaged in doing the right thing.
And my final question then is just in regard to whether or not you believe that the scheme would benefit from being independently reviewed to determine whether excessive red tape is contributing to higher costs for all stakeholders?
I'm sorry, I missed part of your question. Would you mind repeating that, please?
So I was just wondering if you would consider whether or not it would benefit, the scheme would benefit by being independently reviewed to determine whether excessive red tape is contributing to the higher costs for all stakeholders.
I see some value to review. However, I do think that there is more benefit to openly working with and consulting with the wider community first.
Excellent. No worries. Thank you very much for your thoughts. Appreciate it.
Thank you.
Thank you so much, Ms Walford. Really appreciate your time and your submission. It's very helpful to us, so thank you so much. We really appreciate it.
Thank you.
But yeah, we will. I don't think you've taken anything on notice, so we will thank you for your time and let you go.
Thank you very much.
Thank you. And I would ask for the Royal Australian College of General Practitioners, the Royal Australian New Zealand College of Psychiatrists and the Royal Australian College of Physicians to join us. Okay, excellent. So, thank you very much. Welcome. Appreciate your time today. Can I just confirm that you have received the information on parliamentary privilege and protection of witnesses? Yes?
Yes.
Excellent. And I'll just get those online to confirm as we do the introductions. Now, just to cover a sort of procedural bit, bear with me. The Senate has resolved that an officer of a department of the Commonwealth or a state shall not be asked to give opinions on matters of policy and should be given reasonable opportunity to refer questions asked of the officer to superior officers or to a minister. The resolution does not preclude questions asking for explanations of policy or factual questions about how and when policies were adopted. Commonwealth officers appearing today are also reminded of the Senate order specifying the process by which a claim of public interest immunity should be raised. A copy of the order is available from the Secretariat. Now, if we could just troll through each of you and get you to identify your full name and the capacity in which you're appearing before us today, and then we'll move on to any opening statements after that. And if we start in the room.
Thank you. My name is Dr. Niroshini Kennedy. I'm a paediatrician and I'm here representing the Royal Australasian College of Physicians. I'm President of the Paediatrics and Child Health Division.
Thank you.
Thank you. I'm Dr. Tim Jones. I'm a GP. I'm representing the Royal Australian College of General Practitioners. I'm the Chair of Specific Interests in Child and Young Persons Health.
Fantastic. And do we have Dr. Anderson?
She's via teleconference.
Yes, I'm just
Sorry, beg your pardon.
Trying to identify whether she's actually there or not. No. Do we have Dr. Tomar? No. I wonder Maybe we are a few minutes.
Oh, yes, we are.
We are.
We're running early. How did that happen?
Said no Senate committee ever. I wonder if either of you have an opening statement that you'd like to start with.
I do. Would you like to go first?
Okay, thank you. Thank you very much. The Royal Australasian College of Physicians welcomes the opportunity to appear before the committee to provide advice on the NDIS Amendment Bill. The RACP represents more than 34,000 physicians and trainees across 33 medical specialties in Australia and Aotearoa, New Zealand. Our members work across hospitals, community settings and disability services and primary care, including many who support people with disability every day. My name is Niroshini Kennedy. I'm a paediatrician specialising in developmental paediatrics, and I'm president of the Paediatrics and Child Health Division of the RACP. I'm joined today by my colleague Dr. Caitlin Anderson, a rehabilitation medicine physician and president-elect of the Australasian Faculty of Rehabilitation Medicine at the RACP. The RACP supports the intent of this bill to ensure the sustainability of the NDIS. However, we feel that reforms must preserve timely access to supports for children and adults with disability and developmental conditions. As a developmental paediatrician, I have seen how the NDIS can transform the lives of children with complex needs. But I've also seen the harms caused by delays in assessment, barriers to access, and interruptions to support during critical developmental periods. These can have lasting impacts on development, health, education and independence. The RACP's first concern is the lack of a clear legislative definition of reasonable and necessary supports. While the bill strengthens the link between funded supports and an eligible impairment, significant discretion remains. Decisions about early intervention, therapy and developmental supports can vary widely, creating delays, anxiety and uncertainty for families already navigating complex needs. The RACP's second concern is that the emphasis on functional impairment as the primary gateway to the scheme. Children are not small adults. The nature of neurodevelopmental conditions are that they are dynamic and evolving. Many do not present with a definitive diagnosis, and functional impacts change over time as a child grows. Without child-specific guidance and robust assessment processes, there's a real risk that needs will be overlooked or inconsistently assessed. The RACP's third concern relates to the assumption that parents can provide substantial care and support, and that gaps can be absorbed by mainstream services. In my experience, many families are already providing care well beyond reasonable expectations. And at the same time, health, education and community services face significant capacity pressures. It is critical to consider whether these systems are adequately resourced to meet additional need. This is particularly important for priority populations, including Aboriginal and Torres Strait Islander communities, who have already disproportionately less access to the NDIS scheme. Finally, the RACP has concerns about reassessment arrangements. Children should not have to wait until deterioration is severe or permanent before supports are adjusted. Children's development is dynamic and early intervention must be timely. Reassessment must be flexible to respond to change before problems become entrenched. Similarly, we are concerned about the unintended consequence of automatic suspension of plans if contact is not made within prescribed times, without adequate consideration for those for whom contact might be difficult, for example, Aboriginal and Torres Strait Islander families or children involved with the child protection and out-of-home care systems. I will now like to hand over to Dr. Caitlin Anderson.
Dr. Anderson, are you online?
I'm online, yes.
So could you just please, before you start, state your full name and the capacity in which you're appearing?
Yes, my name's Dr. Caitlin Anderson. I'm the President-elect of the Australasian Faculty of Rehabilitation Medicine and the Chair of the AFRM Policy and Advocacy Committee. I'm a RACP Fellow and a Rehabilitation Medicine physician.
Thank you. And did you have any commentary you wanted to provide before we go to questions?
I did have some, yes, if I can.
Please go ahead.
Okay. So as a rehabilitation medicine physician, I provide comprehensive inpatient, outpatient and home-based rehabilitation to support people recovering from surgery, stroke, amputation, neurological conditions and complex medical events. A key issue before us is ensuring that disability is understood as more than a diagnosis. The RACP has been concerned by the continued use of the term substantial impairment without definition. This is inherently subjective and without clear criteria risks inconsistent and arbitrary application. A key measure in the bill suggesting a return to functional capacity being a primary criteria for scheme access is welcome and will hopefully have the intended consequence of providing clarity in access decisions. It does, however, make the definition of functional capacity in the bill critical. In rehabilitation medicine, we see every day that functional capacity is shaped by more than a person's condition. We support a definition that explicitly recognises these factors with its basis in the organising framework of the World Health Organisation's International Classification of Functioning Disability and Health. While stronger mainstream supports are important, they cannot absorb the disability-related needs of people excluded from the NDIS. These services should complement, not replace, dedicated disability supports and must be established prior to the implementation of any access decisions or budgetary setting policy changes. The bill's approach to permanence is also concerning the RACP. Many conditions fluctuate with gradual improvements or setbacks over time, and there is rarely a clear point at which all reasonable treatment is complete. Applied rigidly, this concept risks delaying access, prolonging hospital stays, and requiring physicians to predict long-term outcomes prematurely. Permanence must reflect real-world circumstances, not hypothetical inaccessible treatment options. The move towards standardised assessment tools and automated plan decisions poses further risks. While consistency is important, disability is complex and cannot be reduced to a score or automated output. Capacity building supports and allied health interventions must remain individualised. Over-reliance on automation risks undermining the scheme's person-centred intent. What is needed instead is a skilled planning workforce capable of engaging meaningfully with participants and making individualised evidence-informed funding decisions. Sweeping ministerial powers to make unilateral decisions on supports included in the scheme are also unprecedented and expose persons with disability to the mercy of political headwinds and wider budgetary difficulties. Finally, as Dr. Kennedy noted, the RACP has concerns about the reassessment framework, including statutory limitations on the rights of appeal. Adults with disability experience substantial variation in their needs over time, and functional capacity may not remain stable. Regular evidence-informed reviews are needed to ensure supports remain appropriate and responsive. We will now welcome questions from the committee.
Thank you. Dr. Jones, would you
Yes,
care to
thank
give?
you. So I wish to begin by acknowledging the traditional owners of the lands on which we meet, pay my respects to elders past, present and emerging. I'm here today on behalf of the Royal Australian College of General Practitioners. The RACGP is Australia's largest professional general practice organisation representing over 50,000 members, and I thank the committee for allowing me to be before you today. Specialist GPs are intrinsically involved in disability care. There is no substitute for the quality of care provided by a GP who knows the patient and their history. The NDIS is at a critical juncture with higher than expected participant numbers and fraud undermining the scheme. GPs stand ready to assist with getting the scheme back on track. However, the bill currently before Parliament misses an opportunity to acknowledge general practice for the care it provides. Embedding the role of specialist GPs in legislation would recognise their status as care coordinators, providing extensive, comprehensive and coordinated supporting evidence as part of NDIS applications. A fractured approach across health service systems has led to uncoordinated efforts, gaps in responsibility, and a lack of collaboration between general practice and the disability sector. GPs are treating health professionals for NDIS purposes, but this is not properly understood by NDIS staff, and anecdotal evidence suggests that their clinical input can be dismissed. GPs are already responsible gatekeepers to all other parts of the health system, ensuring appropriate utilisation of resources. Formalising this role within the NDIS will maximise outcomes, rein in costs, and build in an additional fraud prevention control. There is an opportunity with this bill for GPs to inform revised NDIS eligibility criteria and the definition of functional capacity. GPs can advise when a person has exhausted all other treatment options and share valued insights into their patients' care. There must be scope for GP involvement in the new framework planning, which will be underpinned by the ICANN tool. While personal reports and evidence can be submitted, such as those prepared by the regular GP, they may have no bearing on the NDIS funding that a participant receives. This bill is an opportunity to remove the silos between various insurance schemes. GPs have an extensive history as stewards of public funding via Medicare, and general practice is the natural home for coordination of support needs. The RACGP also recommends that all needs assessors have a health background at a minimum. Ideally, these roles would be performed by members of a GP-led multidisciplinary care team, such as practice nurses or other valued allied health professionals. Finally, while not directly relevant to the bill, but to consider better coordination between funding pools, there is an ongoing issue when GPs complete NDIS paperwork and applications. Medicare rebates are only available if the patient is present, meaning patients face potential fees when applying for the NDIS. We are keen to explore options to address this, including care coordination payments through the My Medicare scheme. I look forward to answering your questions.
Thank you very much. And do we have Dr. Toma on the line?
Yes, I'm here.
Would you like to provide us with your full name, the capacity in which you're appearing, and then any opening statement you may have?
Thank you. Will do. My name is Dr. Aska Tomar. I'm a psychiatrist, and I'm also the president of College of Psychiatrists, RA and ZCP. And, we as College of Psychiatrists, we have some significant concerns, but my first statement is that we do support a sustainable NDIS and the recognition for the need for reform. Our concern is not with the reform itself, but how these proposed reforms are adequately accounting for the realities and the impacts of people struggling with severe mental illnesses and the psychosocial disability, which is a big part and parcel of the symptoms people struggle with. People living with schizophrenia, bipolar disorder, recurrent depression, eating disorders, obsessive compulsive disorders, and other serious mental illnesses do represent one of the most vulnerable populations in Australia. Their disabilities are often profound, lifelong, and associated with significantly reduced quality of life, impaired social participation, unemployment, homelessness, physical illnesses, family burden, and premature mortality. The central concern for the psychiatrists and RA and ZCP is that the proposed reforms may reduce access to support or alter eligibility pathways without adequately recognizing the unique nature of psychosocial disability or ensuring that the equivalent alternatives are in place. We do support a sustainable and well-targeted NDIS, but are concerned that people with some of the most disabling illnesses in the community will once again and will continue to fall through the cracks. We know people living with severe mental illnesses have struggled to access disability support despite experiencing profound and often lifelong impairments. It is this particular cohort which anyways has difficulty in accessing the psychosocial supports which do make a significant difference to their recovery and their trajectory, and thus we are concerned that the symptoms, the disability, which is anyways devastating for a person's ability to work, study, maintain relationships, but also the impact it has on their families, on their carers. And for many people, these disabling illnesses with consequences do last a lifetime. But I think the most important part is that psychosocial disability, it does remain as one of the poorly understood and underserved areas of the disability system. Because in mental illnesses, unlike many physical conditions, it often fluctuates. People can improve, people can deteriorate suddenly, relapse repeatedly, and experience significant functional impairment over decades. The fact that a condition is sometimes episodic does not make it any less disabling. In fact, it is often the episodic nature of these illnesses that makes ongoing support so difficult or so important. The loss of that makes it so difficult. Our concern is that the current changes risk narrowing access to the scheme before alternative supports are available, before the new assessment framework has been properly tested. Because removing people from the scheme before alternative supports are operating will have serious downstream consequences. If people lose access to disability supports without equivalent alternatives being available, the pressure does not disappear. It simply shifts. It shifts to already overstretched emergency departments, public mental health services, homelessness services, and families and carers. We cannot negate the impact it has on carers and the families. We know that appropriately community supports do help people remain well, stay connected to their communities, and maintain housing and avoid crisis presentations to hospitals, to police, to prisons even. And we do know 10 to 11% of NDIS participants have psychosocial disability as a primary disability, which represents up to 80,000 of people nationally. But the government has to yet publicly release modeling on how many of these participants might have to exit the scheme under the proposed changes. Without that data, it is very difficult for the committee or the sector to understand the likely impact of the reforms or to plan for additional demands on an already stretched, crumbling, broken state mental health services. So the other main specific bit which we are concerned about is the proposed use of the ICANN assessment tool to determine access to the scheme. ICANN was developed for intellectual disability and has not yet been demonstrated to be clinically valid for psychosocial disability related to severe mental illnesses. Assessing the functional impact of mental illness requires a clinical judgment, comprehensive assessments which lasts for hours altogether, an understanding of fluctuating conditions which is not always captured through standardized tools. So we do have concerns around the pace of the legislative process, the limited time for the consultation on a bill, which will have significant, not just system-wide implications, but the human cost. The implications it has for the people struggling with severe mental illnesses, also the carers and the supporters who are committed to supporting young people, as well as the clinicians who are a part of that system. I think the consultation period for this 109-page bill is really short, especially for people with psychosocial disability, with severe mental illnesses, who may need more time to engage meaningfully. We, as psychiatrists, are committed to working constructively with the government and around the opportunity for the reform process. And this has been a long-standing gap in Australia's mental health system as well as NDIS system. So we do want to see a sustainable NDIS which continues and even steps up to support people with complex and enduring mental illnesses. We do see it as an opportunity to build a system that properly recognizes psychosocial disability related to mental illnesses and is able to respond to it effectively. We should be supporting people at the point where their trajectory can be changed, and they should not have to wait till they reach crisis points. So the measure of the success of these reforms will be whether Australians living with mental illnesses are better supported or whether they continue to remain largely invisible until they present in crisis, emergency departments, homelessness services, or the criminal justice system. So we are calling on the government to ensure no person with moderate to severe mental illnesses, especially with people with severe mental illnesses, that they do not lose essential supports unless equivalent, accessible, and adequately funded alternatives are in place.
Thank you. Thank you very much for that. We appreciate your contributions. It's very helpful. We will go to questions, and we'll start with Senator Steele-John.
Thank you very much, Chair. First of all, to Dr. Tamar, thank you so much for your evidence today, Doctor. Given the concerns that you've stepped out in your opening statement and your observation of the shortness of the consultation period on the legislation, would you, or I should say, would the college and yourself be recommending that we pause the passage of the legislation and potentially take a bit longer to consider it as a committee before passing the bill?
Of course, and also I think we would like to have more details around what the government is planning, because the government has promised that, you know, they will be looking at alternative arrangements, but we just want to understand what that, you know, is supposed to look like, and is it going to be adequate? And also, you know, around the assessment tools, you know, these are not validated tools for people struggling with severe mental illnesses. So to rely on, you know, whatever is being proposed in this bill is not adequate. It does need a lot more work before we are all confident about the approach which the government is planning to take.
Thank you. To the Royal College of General Practitioners and the College of Physicians, this has been a consistent theme for us throughout the entire day. Organisations have come and said either to withdraw the bill or to pause its passage, or to pause its passage and extend the inquiry to get some answers for the community. I hear in your opening statement a focus on potential unknown downstream effects of this legislation. Given all of this together, would you also support the call for a pause to the passage of the legislation and a longer inquiry? Dr. Jones?
Yeah, I mean, if I start, Senator, one of the things that I would say is that we do see this ongoing rollout of mainstream supports through initiatives such as Thriving Kids, but they won't even be starting until 1st of October this year. As a GP representing my 5,000 GPs with an interest in child and youth health, we are already hearing of families being removed from the NDIS every day when it has become the only support that they can access. And so it is a deep fear for our members that currently people with disability have been receiving support. That support is now being withdrawn, and this seems to be moving faster than any one of us can predict.
Absolutely. And so until we have a bit more of that information and a bit more clarity, do you, because we are considering as a committee what our recommendations to government will be, do you think an extended inquiry would be a useful recommendation for us to make?
Yes, I think that is a fair recommendation to make.
Fantastic. Yourself, Doctor?
I think that's a fair recommendation as well. I think for us what is missing is the detailed, and that's the clinically informed detail on the standardised tools that are being proposed to be made, the training, the credentialing of the workforce to carry out this, the clinical pathway, if you like, and to build that you actually need technical expertise. And as it stands, the bill talks about functional capacity assessments, but without actually defining that. And I think that is our concern. With those better defined, I think we have the beginnings of a scheme that can start to address some of the difficulties that they're trying to address.
One of the things that's been quite shocking for me is considering the scale, the numbers of participants that will be impacted by some of these changes. The 10% cut to capacity building will affect 99% of participants on the scheme. About 340,000 participants will be impacted by the 50% cut to social and community participation, for example. Given the numbers of people we're talking about, the only practical way it seems for government to action any decision it makes after the bill has passed is through an automated decision-making process, which is is greatly kind of expanded in the bill. Now, in the RSCGP's submission, you raised concerns about the bill allowing for greater automated decision-making within the NDIS. Can you talk to us a bit more about the concerns that you hold around automation?
Senator, we see human beings who are struggling, and they need those supports to be available to them in a way that is transparent, and they need a process that they understand for how to access those supports now and into the future. Our fear as a college around relying on computer-aided decision-making and AI-assisted decision-making is that it has none of that. It has none of those elements of human qualities. It has none of those elements of transparency to it, and we fear what that would mean for people who are already vulnerable when they're coming to the NDIS for care and support.
And what safeguards do you think would be useful to put in place around this decision-making process?
For us, one of the key elements is to make sure that people have adequate access to human connection as part of their process of accessing NDIS supports. I think we wrote in our submission that we must avoid the tragic consequences of another robo-debt. People need to talk to another human being about what they are experiencing and feel that the system understands that and is responding to that.
And do you see potentially a risk in the way that the bill is currently written of another robo-debt-like scenario playing out?
The concern in our mind, and I think it was shared by my colleague here, is that there isn't enough information about that decision-making process to enable confidence that people will have transparency and continuity of care.
Now, there's big changes to the role of medical and allied health professionals coming within the NDIS more broadly. Some of it's happening now, and a lot of it will be supercharged by the bill. Broadly, the move is away from medical evidence being a key factor in access to the scheme to a place in which that is no longer required for either access or the acquisition of supports. Do you have any concerns regarding non-health professionals undertaking functional capacity assessments? And this is for everyone with us today, all of the bodies.
Okay, I'll start from the College of GPs and we can pass to others. Yeah. I think that functional capacity assessments on paper are an easy term to describe what we're looking at, someone's ability to functionally complete meaningful tasks in their day-to-day life. What the challenge is and what requires extensive health training to understand is the degree to which that depends on dynamic factors, what other things are involved in someone's care, and that isn't something that can be easily delivered by a minimally trained workforce. It is not something that can be delivered by an algorithm, and we do strongly believe that the system needs to retain that dynamicism to acknowledge that circumstances change, and when they change, our people who live with a disability have less buffers that protect them against that compared to people where disability is not a factor in their health.
And Doctor, could I just ask you to clarify, because I think I do know what you mean when you say dynamic factors, but could you just give us some practical examples of what you mean when you say dynamic factors?
So I will speak from my perspective. I do a lot of my work in child development, and if I am seeing a 3-year-old who is already struggling with multiple differences in their development, let's say their parents separate or there's a natural disaster sweeps through their town. That is going to have an immediate and significant consequence on the developmental trajectory of that child. And if we do not intervene at that point to provide extra support just for a time, that child misses a developmental window that was entirely related to the circumstances in which they found themselves.
Fantastic, thank you.
Can I just have a little follow-up? So when you talk about that kind of circumstance, you see that as being an NDIS rather than a health or support service function?
Well, to me, one of the things we're talking about here is what is the role of health, which is to support all the factors involved in someone's health, and what is the role of the NDIS, which is to provide disability-specific supports to someone. Here, in that example, what I was hoping to share is that the developmental need of the child, the thing that would render them eligible for NDIS supports, has been impacted in a way that's obvious by other factors in the health and well-being of that family, and that you cannot distinguish that from how that disability is presenting at the point of care.
Okay, thank you.
I don't know if I'm able to add
Yes,
something.
please go ahead.
I mean, I work in the disability sphere for adults, particularly those that have nuanced disability. And I think this hard boundary between health and NDIS is impossible to define, and in the real world doesn't exist. And I think that's one of the biggest problems with NDIS at the moment, is that they want this hard boundary, whereas in fact the two sectors intersect continuously, and there's constantly changing factors that affect people's function. And I think there needs to be instead of a drift away or an attempted disentangling of the two, they actually need to be better intermeshed to function more suitably for people with disability.
And sorry,
and if I could jump in from psychiatry perspective.
I was just going to ask Dr. Anderson, do you have a sense of how you think that would look?
Well, I mean, my view particularly is that I think the problem that's really existed is the planning, well, the access decision and planning are being made by untrained people that don't have a health background or any real understanding of disability. So as a result, they're relying on reports from external providers such as health, but they don't understand what they're reading. I think that the NDIS really needs a specialist workforce within the scheme that do a lot of those assessments to determine what people's needs are and to match their funding to their needs. I think a lot of these changes that they're putting into this bill going completely the other way are really drifting the scheme away from its original intent. And I think with better planning decisions, there could be cost savings. And I think they do need to return the system to people with high complex disability needs. And I think they need to reinstall the foundational supports, not just for children, but for adults who have lower levels of disability, so that they don't need to access the scheme, because often they will end up with inflated plans to help get them on because they really have no other alternatives. So that's my view, is they do need to tighten up the entry criteria, but I think they need to be very careful how they do that, and they need to ensure that there are foundational supports available for people that don't meet access to the scheme, and they need to be comprehensive. There will be a significant need there as well.
Thank you.
Doctor, can I ask you, just following on from that, the proposal in the bill is that we have a functional capacity assessment that is basically the yardstick for entry, and that while there may be a process for a participant to submit the reports of a specialist or somebody that knows them, somebody well trained, potentially somewhere in that process, there is no requirement on the result of the functional capacity assessment to take account of or in any way reflect the input of a health professional or somebody with training or experience. Would a process like that in any way address the problem you've just articulated to us?
Well, I don't really think so, because I think the two, you can't disentangle the health condition from the disability. They are dynamic, they work together, they are part of what contributes to disability. I think, especially if there's an introduction of a requirement for all reasonable treatment to have been considered, to have been attempted, I just don't know how that could be possible without medical reports being included. I'm generally supportive of a return to functions being the primary sort of driver for access, but I think there has to be ongoing contribution from medical, the health system to help inform that access decision to a certain extent. And I'm very concerned that functional assessment is going to be used or misused to help to develop plans rather than making them individualised. So I think it is very key how that is designed. And I think I don't understand how it would be done without medical involvement. It definitely require allied health trained specialists who are, trained to assess disability and function.
Thank you. And I think we just hadn't heard from, I think, maybe Dr. Kennedy, and that was the... Was it that?
I don't have anything to add
And
to
if
that.
I could also talk from the psychiatry perspective, please.
Yeah, please go
Toma,
ahead.
sorry, yes.
Please go ahead.
Oh, should I go ahead? Okay. So I think for psychiatry, the main concern we have is that the disability systems, also the existing NDIS, has been built around relatively stable impairments. For example, intellectual disability or a physical disability or a sensory disability. But people living with schizophrenia, bipolar disorder, treatment-resistant depression, their psychosocial disability can be quite different, where they do experience fluctuations in symptoms and functioning. And these fluctuations can sometimes happen over a period of weeks, over a period of months, over a period of years. But a fluctuating disability can still be a permanent disability. The symptoms can change, but the vulnerability always remains. For example, a person with schizophrenia who has been in an inpatient unit for, let's say, a few months, and they have, got enough support, right treatment, and they have been discharged. And they might attend an NDIS assessment appointment where they might look really, well cared, they're communicating effectively, and they look like they're living independently because, now they're not in the hospital. But that independence sometimes is more sort of, it can look different because, the support could be from the family, bringing them to the appointment, the medication which they're being supported for a particular period of time. But if those supports are not there, then very soon wheels start coming off. And that fluctuant disability or difficulties a person has in their functioning because of the mental illnesses is not being captured, I would say to some extent currently, but definitely not in what is being proposed. So one good day out of 50 bad days can seal someone's fate, and that is something which should be unacceptable because we all know, people living with schizophrenia, they die 15 to 20 years earlier than the general population. So when we are talking about a condition which shortens people's life expectancy by 2 decades, we're not talking about mild impairments. We are talking about one of the most vulnerable populations in Australia. So how do we make sure that the disability which is related to mental illnesses, the biopsychosocial approach, even in terms of treatments and support is needed, it can't be captured by a snapshot AI-generated assessment. And again, even as a psychiatrist, I can't just do a 5-minute assessment on someone, even for someone who's, has been doing this for many years. It still takes quite a lot of time to be able to connect and help the person express the difficulties that they're facing. So we all know, people struggling with mental illnesses, especially who are quite incapacitated, might be the least able to communicate those needs. So, that is something which we have to account for as community, as a government, as all of us sort of sitting here together today.
Thank you. Senator Askew.
That's right. Thank you. Some of my questions have been touched on by Senator Steele-John again, but I will just go back to Dr. Toma. You just mentioned in your last response there, you were talking about the wheels coming off if the correct, and I like that term, the wheels coming off if the support's not there. What other impacts would be there if somebody is moved out of the NDIS and the correct supports are not available in their regions, or especially if they are living in rural and regional areas? Where would the responsibility then fall for those people to be cared for? Would that come back to the GPs and into that world, or into the hospitals?
I think the first impact is on the families and the carers around the person who's struggling. If the families have not already been burnt out, because even with adequate supports in place, the families do go to a large extent in supporting, people struggling with mental illness. And I think, sometimes it's helpful to have a think around, 15, 20 years ago, we were supporting, I would sort of say confidently, in psychiatric systems, we were able to support people to a large extent because a part of care which was provided also included that psychosocial support. And once it got separated, in a way, the bed numbers have gone down, and that sort of burden has ended up on the families who have not been trained to provide that support. So in a way, we're almost substituting the care which was provided by clinicians and allied healthcare and even sort of non-clinical staff members in a mental health unit. All that burden has fallen onto the shoulders of the carers. Once they're burnt out, either the person ends up homeless, ends up in emergency departments waiting for hours, if not days, and sometimes we've heard weeks, people just waiting to get some support in a very stretched health system. And we've also sort of seen the, people getting into the criminal justice system because they have not been provided with that support. And sometimes that support is really important to get that biological treatment or psychological treatment. We can't separate in mental health, in psychiatry, we cannot separate out housing support, community support, social interaction, support to the families from the biological treatment or psychological treatment which we will offer to a person struggling with mental illnesses. So I think that's something which gets quite frequently lost when you're looking at a very structured system which is going to define your disability and whether you meet particular criteria or not. And sometimes people are not able to express or document all of that. So I don't know whether,
Thank you. No, that's
a big problem.
That's fair. Just for the RACGP and the RACPs, representatives, get the acronyms right. You mentioned it earlier, I think, in regard to the thriving kids and the supports that would be available. Obviously, in a similar scenario to what we just had then in regard to the adults with psychosocial disabilities, how would that impact coming out, being moved out onto thriving kids? How would that impact the work you were doing with the children and the families? And particularly if the supports aren't as available, often that is the case in the rural and regional areas.
I think that's a huge anxiety for the families of children who I'm seeing at the moment. There are still some questions about eligibility criteria for thriving kids versus the NDIS and what plans are going to look like. My understanding is at the moment that the states will be designing foundational supports state by state with those overarching recommendations. But I think, again, to come back to our primary concern that there's insufficient information about these changes for us to really fully support, although we fully support the intent of the bill, which is to preserve the integrity and sustainability of a life-changing bill.
Do you want to add anything?
Yes,
Dr.
Senator,
Jones?
I'll comment as well. And I will just declare for the record that I served on the government's expert advisory group that designed the Thriving Kids model. So there are some conflicts of interest present in the room. One of the things I would say as a GP is that we see patients with high levels of complexity who are not eligible for the NDIS, either because their conditions aren't recognised disabilities or because the degree of impact that those conditions have renders them ineligible. We have done that for a long time, and we think we're pretty good at working with those people to identify what are their key support needs right now. Under Medicare, all we have access to are chronic condition management plans, which give us $59 odd of Medicare funding times 5 for a year in allied health support. We will always make sure as GPs that that funding goes towards the area of greatest need for that person right now. But our strength in being able to do that is that we can be really dynamic. As needs change, we can deploy that where the greatest need is. The hope as foundational supports build out is that we will have systems of support that let us do that. The challenge as the NDIS reform is proposed is that it still remains an in or out system, and it is entirely on the participant to justify why they deserve to be in. And currently, without access to any other foundational support systems, basically if you're out, you get our $59 5 times a year, and if that isn't enough, as Dr. Tamar was saying, the burden is going to fall on the carers and families, who we know are already experiencing some of the highest levels of stress that any sector in our population of Australia are experiencing right now.
So transition is going to be very important, obviously, in managing that process. And I think you have touched on it already earlier around the link between the health services and the disability service providers. It is very siloed. So do you foresee further fragmentation, or are you looking to see it actually to come together and actually work in unison? And also adding on to that, what downstream impacts do you anticipate the reforms will have on hospitals, emergency departments and primary care? So it's a bit of a bigger question.
Yeah, I'll start by sharing some anecdotes around just accessing of care. One of the reasons why as general practice we're so passionate about trying to strengthen our links with the NDIS is we think that we can bring our skills in dynamicism to what the NDIS is trying to deliver. As a GP, I've actually written to the NDIS asking them to reduce the support being provided to a child and family because the family was becoming overwhelmed by the number of appointments they were accessing, and so their child was actually disengaging from the valued early intervention because of family burnout. Now, we will tell systems to spend less money on people. That's not a common skill, but we're so connected to the people that work to support the person at the centre of this that we really see that that's the value we can bring. It's been more than 12 months for us as GPs where we were informed that our letters of support for our patients to the NDIS would no longer be recognised. They would essentially be considered a waste of time. And so we feel really passionately that reform towards functional need is so important to get right. And one of the factors we would really love to see is that we have the ability to access a truly stepped care model of care where people can step up to high levels of support when it is needed, step down to low levels when it is needed, and that we have that ability to say to the support system for that person, we can help you access what you need when you need it. And to come to the second part of your question, Senator, needless to say that the impact that would make on our hospital sector and on our mental health sector as well is staggering, because that's just people getting what they need when they need it. If people don't get that, they end up in hospital or they end up in our mental health system, or both.
Exactly. Did you want to add something, Dr. Kennedy?
Thank you. In my clinical role, I work at the Victorian Aboriginal Health Service, where we serve a very vulnerable group of Aboriginal children, over 50% of whom are involved in the out-of-home care sector, and many have complex neurodevelopmental needs. We have a huge amount of variation in access, and as Tim said, some have, depending on how strongly their parents have been able to advocate for them, that can lead to quite large discrepancies in the scheme. Thriving Kids and these NDIS reforms are really an opportunity for Australia to build more effective and mature disability supports for children and for adults. But the key to this is to address some of the problems that have beset the NDIS, and that has been the low value care, the variation in care, to deliver service that have impact and have that impact measured. In order to do that, we need to have standardisation, and you need appropriate medical expertise in order to support that standardisation. And ideally that should be done at a national level. And that needs to be flexible. There needs to be a program by which programs that haven't established their evidence are allowed to build the evidence. But certainly when we're talking about tools that are used to provide eligibility to the scheme, they need to be very carefully used and in conjunction with clinical judgment in order to be effective. And Additionally, I think, as I think Dr. Tomar mentioned, we need to look at specialised, directly commissioned workforces for this to be effective. The NDIS, and I have worked long enough to remember the pre-NDIS era, the Helping Children with Autism scheme era, and before that when we based on state-based what are now foundational supports. The NDIS was transformational. It gave parents control and choice, and that is an incredibly important principle that we hold very dearly. But what hasn't come hand in hand with that is the evidence and the information that parents need to make some of those decisions, and that's led to variation in care. So direct commissioning should be considered, and a specialised workforce that parents can, and also service navigation, so that families are investing their time in services that are actually effective.
Did you want to do it?
Could I just clarify something, Dr. Jones? General practice is one of Australia's central medical specialties, and the relationship between patient and general practitioner, sometimes over large periods of a lifetime, is recognised in many other parts of our government bureaucratic system as being of high quality. Did I just understand correctly that, in your answer to my colleague, that the NDIS communicated with you about 12 months ago that referral or evidentiary letters from GPs are no longer considered valid or valuable?
Yes, Senator, to be clear, letters of support for patients were no longer considered valuable. And I can't give you an exact period of time. I can take that on notice, but certainly there has been a shift in even just trying to advocate for our patients to access appropriate NDIS supports over time.
And they used to be key pieces of evidence, but is it a pattern of rejection that you've seen, or an official communication?
I do not recall an official communication. What we had come to us first was just statements from our patients saying that they were told by NDIS assessors that letters of support would no longer be accepted and valued at the agency, and that they were essentially a waste of paper and time.
Wow. Look, if you wouldn't mind taking on notice to just provide us with a bit more evidence of that, I think that'd be useful. Thank you.
Too.
Yeah.
I could support that statement from sort of psychiatry perspective, because the experience of psychiatrists is that the letter of support, and usually psychiatrists are writing that letter of support, especially in a public health service, is for people struggling with, schizophrenia. And the success rate people have in those supporting letters is so abysmal that, that helplessness, hopelessness starts creeping in, and people stop being asked for supporting letters, and even if you're writing them, you have the sense that it's not going to go far. So I think in the last few years, initially I would sort of say when NDIS was initially implemented, yes, it did not solve every problem for people with severe mental illnesses, but for many it was in a way first system which recognized the disability and proposed that support. But in the last few years, the success rate, psychiatrists or public health system or private health system they have had in getting people on some sort of psychosocial support related to their disability, which is related to a severe mental illness, is really low.
I mean, Doctor, you're quite right. About 67% of all NDIS participants who are psychosocial participants are on the scheme with a primary diagnosis of schizophrenia. I just want to check that we're talking about the same thing. So are you saying from your perspective, from the knowledge that you have and from your members, that the agency is disregarding support letters from psychiatrists on a routine basis?
In a way, I think it's largely related to people's understanding of medical conditions like schizophrenia when they're doing those assessments as a non-clinician. So I suppose a lot depends on the person who's putting the papers together, especially for NDIS. We all know if you find the right NDIS provider who can put your application together, your success rate is higher than you going to your long-standing, whether it's a GP or a psychiatrist or a pediatrician, and someone who's known you and knows about your struggles, knows about your presentations to emergency departments and, you know, the struggles you have in being compliant with your medication or keeping up with your appointments. You know, those are the people who have continued to fall through the cracks when, you know, in a way, those are the people for whom NDIS, in a way, was set up. So we also have to look at, yes, there is a large proportion of people who are on psychosocial disability, but then there's a larger proportion of people out there who do struggle with severe mental illnesses. But even in the cohort of people who, you know, who are getting support for psychosocial disability, there's a huge cohort of people who have much disabling conditions, much more disabled, and are not able to access NDIS.
Thank you.
Thank you.
In the last few years.
We'll go to Senator De Liga.
Thank you, Chair. Afternoon, guys. Dr. Jones or Dr. Kennedy, just want to ask you about how you see the technical advisory group and whether or not you think it's appropriate that the group should provide advice on appropriate workforce competency standards and requirements, including training and guidance to undertake assessments and including decision-making safeguards and quality assurance.
I think those sound like very sensible inclusions for the terms of reference for the group. In addition, I think there should be a process by which evidence-based selection of assessment tools is considered as well. I'd like to ask my colleague, Dr. Caitlin Anderson, who is a rehabilitation...
Please.
Dr. Anderson, are you online?
Yes, I'm still online. Yeah, I mean, I do think it is crucial how we design all these assessment and planning, how we make these assessment and planning decisions. I think that was a flaw with the original rollout of STEAM, that a lot of these concepts weren't adequately defined. So I do think having a technical advisory group to really nut out all those issues is vital. I think it will be really important to make sure the right people are on that advisory group, and it should include people with lived experience and various different departments. I think it should also include health. Because, as I've said before, the sectors are so interrelated, and I think any of those pathways need to appreciate that there are different ways of entry for people into the program. I mean, I guess I can just comment from an entry point of view in health. I mean, a lot of the people we are supporting to access are hospital inpatients, and the navigation of that pathway is extremely challenging and really contributes to excessively long hospital lengths of stay. And so I think, yeah, I do think it's very important who sits on that technical advisory group to ensure that it is designed adequately.
Thanks. And from the college?
Yes, so Senator De Liga, we would fully support those as sensible inclusions, and we would support everything that our colleagues from the College of Physicians have said. We would like to comment that GP representation in that technical advisory group we would see as critical, or at least extensive consultation with the general practice workforce, seeing as we see all the people who live with disability. We would be very valuable to talk to about who is currently not getting what they need out of the system and why.
Thank you.
And similarly, the RACP representing paediatricians, rehabilitation physicians, we would really welcome an opportunity to be part of that technical advisory group.
Could I make one more comment actually too for the committee, which is that one of the things that has to be critical in these tools and evidence-based assessments is that they translate to the real world, that they have to be usable across broad swathes of our population. We know that, coming back to the question on letters of support, the people we were most writing letters of support for were the people who had no voice. either due to their circumstances, their cultural background or their disability. They had no way of navigating the system, and that inequity of access to NDIS is something that we have seen, sadly, and we're passionate about correcting. One of the things that we need to make sure is that those tools themselves do not embed those same biases of access.
Thank you.
And I would entirely support that point. I think it is really vital that they are applied consistently, and that there is the ability for people who don't have that voice to access. It is so difficult to access the thing. Some people don't give up. And as others have said, that this does lead to people with significant needs going without support, and that can contribute to adverse health outcomes, premature death, and multiple other complications.
Thank you.
And if I could just add to that, I think it also needs to be tested. It has to be evidence-based. We can't have an assessment tool which, has not been demonstrated to be fit for purpose. And that's really important.
Great. Thank you. We'll go to Senator Kovacic.
Thank you so much, Chair, and thank you all for your time today. As frontline medical practitioners, you're often the first to see the impacts when the boundaries between Medicare and the NDIS don't align with a person's needs, and the fact that, policymakers and governments see those as two very different silos. And I know some of the comments that you've already made around this, but what are the most significant gaps or the unintended consequences that you're encountering here, particularly when we have such a strong intervention or influence from support needs assessors from the NDIS who don't have that clinical experience? How do we bridge that gap? What do we do here?
I don't know if I'm happy to comment. I mean, I definitely think there needs to be much more sophisticated planning. The process around planning is very inconsistently applied, and I think means that there is a great deal of variability in plans. People can have arbitrarily have needs not funded just on the whim of someone that probably doesn't understand disability at all. I strongly believe that, I really am not supportive of the robo-planning type approach without any additional oversight. I think that they need to have specialist planners within NDIS that are able to create more equitable plans for everybody, and also easier access pathways so that people can have access to the scheme when it's needed.
Sure, thank you. Anyone else on that?
I would be supportive of that, where quite a few times possibly when someone has a permanent disability, you might not need that clinical oversight or clinical input or clinical expertise. But especially for, people struggling with mental illnesses, the clinical lens is just so important. It can't be done by a questionnaire. It can't just be done by an assessment tool. And I think Senator, you did mention Medicare and NDIS, but the third part to this story is also the health systems. The public health systems, whether it's emergency departments or, when that need gets sort of reflected in other parts of the system, like prisons and police and homelessness, it plays out in so many different spaces, which means the health systems have to be a part of the NDIS. It can't continue to operate in silos, especially for mental health.
Thank you.
From a paediatric perspective, certainly the lack of standardisation of assessment is a major factor. What that means is that families who have the means to collect a number of allied health reports might be privately commissioned, might be in a better position and end up with a, say, the example that Tim gave of a quite well-funded report, whereas other families who may not have the funding to do those initial reports through the private sector are at a disadvantage, and that is an inequity right at the start, the gateway to the system. So we do need standardisation and ideally a specialist workforce, perhaps directly commissioned to do this work, and that needs to be multidisciplinary and needs to have medical input. A really important recommendation that came out of the Thriving Kids Parliamentary Inquiry was that it highlighted that we actually don't have Medicare support for developmental assessments of children, analogous to, say, annual assessments of function in geriatrics. And that was a really useful recommendation that came out of the Thriving Kids Advisory Group, which I think would add a measure of medical consistency and oversight to review of a child's needs, to be used in conjunction with a multidisciplinary team of approved assessors.
In addition,
Thank you, and thank you, Chair.
We'll just let Dr. Jones have a
I'll only make
moment.
two
Sorry,
brief comments here.
I missed that. Apologies.
No, that's no trouble. It's the first, and I would say this from a patient lens, is involving the support team of the person in the creation of the plan. Because so often my patients will tell me, and my network tells me this is true everywhere, that they feel like passengers on the ride. You know, the NDIS is a monolith, they're talking to the monolith tells them what they get, and then they go from there. But from a paediatric place and from an adult place, the families, the support team, they know where the greatest need will be. They know what the most meaningful intervention a system can give them will be. And I think as part of new framework planning, that needs to be embedded. The second thing is just keeping, back to what I said earlier, that idea of, for the duration of a plan, what are the most meaningful interventions? Because one of the unintended consequences of the NDIS to date has been that in returning choice and control to families, that has been wonderful, but the fear of this could get cut off, so I have to always justify what I need, has led in a way to over-servicing, because we have seen families fear that if they're not adequately seen to be utilising the systems that the NDIS provide, then they'll be taken off the scheme. And so embedding that idea of what is most meaningful is critical, because if families know that the system can be trusted to deliver that to them, we will see more responsible use of those resources and that workforce.
Thank you very much. And just finally, we'll go to Senator Ananda Raja.
We've heard a lot about the fluctuating nature of disability, and you know, as the technical advisory group now tries to work through some sort of standardised definition for assessing functional need, what kind of thinking and features should they take into account in coming up with this? Because I also would challenge you as well, as a colleague, that there is a lot of variation within medicine, right? And report writing is incredibly time consuming. There is that issue of the diagnostic gateway, which acts as a barrier to access. It's expensive, it's slow. So I don't really feel like the status quo is helping anyone necessarily, but if we're moving to a newer model of assessment, then how do we ensure that we land at the right place that takes into account this fluctuating nature that you've all talked about?
Could I please start and give two examples? The first is that Medicare already supplies an annual health assessment for our patients who live with an intellectual disability. And as part of that assessment, we use a tool called the chat tool, which was developed through the department as a tool that embeds all the same qualities of fundamental needs, but also some of the psychosocial needs as well too. So we're already doing that for our patients with an intellectual disability. There is a lot of duplication of information there. We would love to be able to just give what we are already performing for our patients on an annual basis, funded through Medicare, to NDIS, and say you don't have to duplicate that. You are entirely entitled to work with that information. It's already within the patient's record. The second is that we saw as part of the Thriving Kids budget announcements that we will be able to perform that for our 3-year-olds from 1st of November of this year. And like Dr. Kennedy was suggesting, we would see that being able to do that annually for the first 5 years of a child's life is an excellent way of ensuring consistent and timely care and reducing duplication that is using existing Medicare structures to provide that.
So in terms of paediatrics, there is a gap in terms of an understanding of the complexity of developmental paediatrics. So our Medicare schedule has initial and review item numbers, but we don't have an annual review for developmental conditions like our GP colleagues have or geriatricians have. Senator, I agree with you, there's lots of variation in practice, and that is of concern to us, and we're certainly through the college working on pathways to embed more developmental paediatric training at every level, whether you're a general paediatrician or a specialist developmental paediatrician. But we see our members, especially our specialist developmental paediatricians, doing this work very well and very thoroughly. I think the inclusion of a specific annual Medicare item number would help to highlight the work that was done, and that could directly feed into this process. The elements of that assessment usually cover psychosocial functioning, it covers mood, it covers medical health, nutritional health. For young people, their lifestyle factors, their sleep, their mood, their social environment, a risk assessment. This is what I do every day when I reassess a child, but at present there are no dedicated Medicare item numbers for this, and I think that was a gap highlighted by the Thriving Kids Parliamentary Inquiry, and the RICP strongly supports that recommendation. We think that would really assist and support the work of the NDIS in monitoring and providing a medically informed input into planning around functional needs. A functional needs assessment is always part of a review appointment that we consider, and we too always look at priority setting and priorities within those consultations, taking into account what's important for that child in front of me, their family, and in the context of their developmental trajectory.
Thank you. Dr. Tamar,
and
do you
if
have
I could
anything
just
to add?
advocate for I was just going to advocate for the rehabilitation medicine physicians as well. I mean, our training is in disability and function. That's our entire job description to a certain extent, and managing and reducing disability and providing support. So I also think rehabilitation physicians are extremely well placed to help with some of the report writing, but similarly, it's not at all remunerated within Medicare and is exceptionally time consuming. So in some rehabilitation physicians actually won't write reports because it's not possible for them within their existing job description. So I mean, obviously with the RACP, but personally also support the introduction of Medicare items to help remunerate that.
Thank you.
And from sort of psychiatry perspective, I think fluctuating disability at times is a reality for people struggling with mental illnesses. But it doesn't mean that it's not a permanent disability. So it is, and that's where I suppose that nuanced approach becomes so important. The bit we talk about is person-centered care, and having the person who's struggling with the condition, their families, they need to be able to have a say in the matter and not have to live in the fear around, if I don't say the right thing, the support is going to be taken away from me or us. I think we have to really set up a system which is able to move away from having to write the right thing or say the right thing, and it has to sort of sit in partnership with people, clinicians, psychiatrists, GPs, pediatricians, allied health, psychologists, the clinical people who are trying to support the person struggling with mental illness and are able to identify, what supports are critical. I think that just becomes so important. We cannot keep it separate. It cannot be siloed, and we cannot have people living in the fear that today I'm doing better because I've got the supports in place, but they know the reality. And, we know that people struggling with schizophrenia, you remove those supports in place and they will just fall through. Like, we know that. That's so again, I suppose that nuanced approach around what condition the person is struggling with, which stage of illness they are in, what supports they have in place, including the treatment options they have in place. I mean, there is so much variability that yes, we have to have a consistent approach, but we have to be able to cater for that variability.
Thank you. Thank you so much for your time this afternoon. We really, really do appreciate it. You have taken a couple of things on notice, and the time frame for returning those is very short. And the sooner the better, but Friday is the deadline, Friday the 12th of June. So if you have any problems with providing those answers by that time, please get in touch with the Secretariat and we'll do what we can to amend and adjust to make it a possibility. Thank you so much for your time. We really do appreciate it. And that actually concludes today's hearing. I would like to thank all of the witnesses that have joined us throughout the day. It has been a very, very helpful day of evidence and lived experience and knowledge. So thank you to everybody. We'd also like to thank Hansard and Broadcasting for their assistance, and also to our Secretariat. That we are now adjourned.